laughter is free and being easily implemented and cost effectively. So we will be searching for complementary therapies. We can use laughter as a complementary therapy because it's freely available and easy to use and cost effective. You may be using vitamins, massages, yoga, but they are all expensive. But this is cheap. Okay, the effect of humor is being studied in terms of psychological outcomes such as stress and physiological responses and ultimately and health outcomes. So by reducing the stress, laughter will improve the health outcomes. Okay, it all started some not 30 years ago in 1976. Norman Cousins had published an article in New England Journal of Medicine justifying the potential benefits of humor and laughter, its benefits on health of humans. Norman Cousins also identified that laughter and humor therapy, if used, improves doctor and patient relationship. It's not only useful to the patient, it is useful for improving the doctor-patient relationship. This is the book written by Norman Cousins. You can get it and Audible also. I'm hearing that now. When Norman Cousins was diagnosed with a crippling and irreversible disease, he forged an unusual collaboration with his physician, and together they were able to beat the odds. The doctor's genius was in helping his patient to his own powers, laughter, courage, and tenacity. So Norman Cousins found out that if he can laugh, he will have less pain. So Anatomy of Illness was the first book by a patient that spoke to our current interest in taking charge of our own health. It started the revolution in patients working with their doctors and using humor to boost their body's capacity of healing. So this is the how people found out that laughter is useful in medicine. And you may be knowing this Robin Williams Patch Adams. It's a movie. Actually, this movie was based on this Hunter Doty. Is an American physician, comedian, social activist, clown, and author. He founded this Glunshed Institute in 1971. Each year, he also organizes volunteers from around the world to travel to various countries where they dress as clowns to bring humor to orphans, patients, and other people. He uses humor for these things in the routine practice. And there are some doctors who use a clown as dressed up as clowns and use in Chennai. They follow his, and as you know, laughter is inexpensive, simple, and can be used without significant expenditure in a cost-effective manner. So whenever we want to use some therapy, we will see the cost effectiveness, and it is cost effective. It has positive effects on different psychological aspects such as depression, stress, and anxiety across age groups, in addition to promising results on clinical and biochemical variables. Laughter therapy is currently used complementary to other regular treatments with few, if any, contraindications. And there are very few, I don't know any contraindications you may be knowing. There's no contraindication for laughter. And if you see this laughter is divine also, there is one famous Madhurashtakam, which says that even laughter or smile of God is sweet. This Madhurashtakam is very related to diabetologists because we deal with patients who are sweet. So your lips are sweet, charming, your face is sweet and charming, your eyes are sweet and charming, and your laughter is sweet and charming. So keep laughing because laughter is divine. Okay, and I want to pay my some respect to Dr. Shaukat Sadikot, founder of Diabetes India. He's past president of IDF and great teacher. And he used to show us these slide with this comedy slide. He said, doctor recommended me 1 glass of wine per day. You look at the size. So he always says that what you eat is not important. How much you eat or how much you drink is important. So salutations to Dr. Sadikot. And he will also show the slide where people are going by escalator to the gym. So they're not walking. And this is last year where they started this Dr. Sadikot's oration. You can see our Bansi and Mrs. Sadikot, Dr. And other friends. So what is laughter therapy? Laughter therapy is known as a psychotherapeutic technique or strategy intended to produce mental and emotional benefits through laughter. It is important to learn to laugh at yourself. Laughter therapy helps to dramatize the life situation, developing the competitive spirit. So, what are the physiological effects of laughter? The direct benefits, other than stress relief, that laughter therapy offers is that patient's mood feel uplifted. Whenever you laugh, your mood is uplifted, as you know. And also medically, there is an increase in heart rate, respiratory rate, and depth. Also, improvement in oxygen consumption by cells. So, this is what happens when you laugh. And post laughter, there is a period of relaxation of muscles and also decrease in heart rate, force of contraction, and blood pressure. So these are all the benefits of laughter when we do laughter. So clinical evidence, we did some research, and it is useful in the geriatrics, oncology, critical care, psychiatry, rheumatology, home care, everywhere they are using. Okay, as you know, smiling makes us attractive. If you smile, people like us. Smiling relieves stress. Smiling elevates our mood. Smiling is contagious, and smiling boosts your immune system. Smiling makes us feel good. Smiling makes you seem successful. Smiling lowers your blood pressure. Smiling makes you look younger. This is useful for our lady doctors. And smiling helps you to stay positive. So if you smile, everything will become positive. So these are the advantages of smiling. And another thing is you can burn some calories, 30 to 40 calories if you laugh for 15 minutes, which will add up if you smile every day. And it was studied worldwide in USA, Asia, Europe, and Australia. We did a review, and we found out that it is used and studied everywhere. Outcome measures varied broadly from mental health and well-being to physical health. Means it is, as you know, laughter will be helpful in anxiety, other things, coping mechanisms, and blood pressure, blood glucose levels, body weight, fatigue, heart rate, immune function, insomnia, pulmonary function, etc. So moreover, there are no contraindications, which makes it safe for many people to try. These are our colleagues from Andhra Pradesh, and we are honoring Dr. Seshia. So how do you classify this therapy? Classifications were operationalized as following. An intervention was classified as using humor if some humorous stimulus was mentioned as being a part of the therapy, such as humor jokes or humor videos. Interventions were classified not using human therapy and is similar to laughter, but specifically mentioned that only laughter yoga. Laughter yoga is which is non-humor per definition. It means in laughter yoga they don't use any humor comedy, but they still make people to laugh. Or non-humorous laughter was used, or when elements of the intervention were clearly mentioned, none of them are involved in humor. Okay, and they found out that in this review, Bennett, he says that simulated laughter was mentioned as specifically interesting. So, as practical significance, laughter-inducing therapy seem to be applicable in wide range of settings for many different populations, and we can use it in severe or terminally ill, cancer patients, disabled, healthy employees, elderly, adults, and children. So, laughter is useful for all the people.
communication. NFC is very, at one point of time, people thought that NFC will replace Bluetooth, but somehow it has not gained so much popularity. But for devices, medical devices like this, NFC is very useful. So the reader and the sensor connect with each other with using NFC. If you've seen a credit card being used by new credit card machines, they just tap the credit card on the machine and it automatically takes the data. That is also NFC. So same way, similar technology is being used here, that is known as NFC technology. So whenever you want to check your sugar, all you need to do is you need to take your reader, put it close to the sensor, and it will take the data from the sensor and it will flash you the glucose value which is there presently. So this is why it's known as flash glucose monitoring, because whenever you flash it, you get a reading. Right now, it's like, there's a saying in Hinduism that, if you don't ask for it, you will not get it, right? This is from Gita. So, if you ask for it, if you ask for the reading, right, you'll get it. This is famous story of Sanjay, telling the Mahabharat live session to Dhritarashtra, but only when, he was asked about what is going on, he would be able to tell what's going on. So that is how it is with this also. So whenever, the reader, asks the sensor for the glucose reading, you will get the reading. So if you don't ask for it, you will not get the reading. That's the challenge of flash glucose monitoring. So on one hand, it is better than a real time. It's better than a professional CGM, which is retrospective. On the other hand, it is not as good as a real time CGM, because your sugar might be dipping. Your sugar might be 50, and you will not get the reading because you're not asked for it. That's the problem. So, flash glucose monitoring is, this slide I just added. I had to add this after this wonderful talk by Dr. Ram about laughter. And, this is a comedian called Ronnie Cheng. And, this is my joke, my version of a joke. I'm not as good a, a comedian as as a person rather as Dr. Ram. But I would say that, Ronnie Chang is a Chinese American comedian, and this is one of his specials on Netflix. And this actually, why this is important, because flash glucose monitoring is kind of, it typifies what Ronnie Chang was talking about in this comedy special. So what he talks about is that we are in this world where we want everything now, right? We want it right now, right? We need it now. Like you have Amazon Prime, so we need it faster, we need it stronger, So, it's not enough that, you want it within the same day, you want it within that hour, you want it, it should be like, as soon as you click a button, that device or that whatever you ordered should be available in your hand, So flash glucose monitoring is like that, as soon as you flash the glucose, flash the reader on the sensor, you will get the reading, it's instant value. You don't have to take, a glucometer, you'll have to, take the strips, you'll have to put the strip inside the glucometer, you'll have to, prick yourself, then you have to take the blood, that blood has to be put on the glucometer. It takes typically a typical glucose monitoring would take 5 minutes, plus it will be painful. Whereas a flash glucose monitoring is instant, just take that reader, put it on the sensor, and you'll get the data, right? So that's the, this is the world we are living in. Everything is instantly given to you. So what are the real world evidence of flash glucose monitoring, right? How does flash glucose monitoring stand up in the real world? What is interesting is there is a lot of data which is emerging on flash glucose monitoring, and it has become very, very popular, and it's also a very popular mean for, a way of studying diabetes also. So this is a study done from Spain, where what they wanted to see was that does flash glucose monitoring really have any benefit to the patient? Ultimately, does it improve the glycemic control? Does it help the patient in any way? And what the study found was that time in range, which is a parameter of good glycemic control, was higher for the people who used to scan the highest, right? So if you scan more, if you ask for more data, you will get better results. So ultimately what they found was that people who use this CGM more or a flash glucose monitoring more, they found better results. So if you talk about the glycemic variability matrix, it correlated positively with the time below 70 or below 54, above 180, and negatively with the time in range. And as seen from clinical trials, flash glucose monitoring real world settings allows frequent glucose checks. High scan rates are associated with favorable glycemic markers of increased time in range, reduced time in hyperglycemia and hypoglycemia, and improves glycemic variability. So ultimately, the more you flash the CGM, the better your glycemic control will ultimately be. This is another review on the topic. In this, what they looked at is a recent review. You can see, I think it's as recent as 2021. So in patients with type 2 diabetes, receiving insulin therapy, what they found was that the data from, there's a study known as replay study, 6 months replay study, where they compared the use of flash glucose monitoring vis-a-vis an SMBG for the same period of time. And what they found was that the patients who used CGM, they had less time spent in hypoglycemia, less severe hypoglycemic event, but overall there was no difference in terms of the HbA1c, but the hypoglycemia period reduced. And then you had subsequent RCTs and real world data using flash glucose monitoring, where they found was that in real world settings, in type 1 diabetes and in type 2 diabetes, it was found that it actually not only improved the glycemic variability and reduced the time spent for hypoglycemia, but it also improved the HbA1c. So in a in a research setting, it did not improve the HbA1c, but in a real world setting, it improves the HbA1c. And similar to what we found from the earlier study, this review also says that the more time you scan your reader, scan your sensor, the more time you flash your CGM, the better glycemic control you'll achieve, right? So I think this is the missing point in a lot of our patients. It's a learning point here that the more the patient is involved in the care, involved in his or her own care, the better the patient will do over a short term as well as a long term period. Another study from Brazil also found similar results. They concluded that patients who had higher frequency of scans, more frequent, taking up readings, they found that these patients had better glycemic control and had better clinical outcomes. This is a study done from India, right? This is from Dr. V. Mohan's group. What they actually used Libre Pro. And again, they also found that, overall using a flash CGM with an AGP was associated with better HbA1c reduction, both in type 1 as well as type 2 diabetes. So overall, the improvement in HbA1c was maintained across all age groups at different centers across the country. And so it's in a multi-centric trial, they actually found that this was a very, very effective thing. And ultimately, what they concluded was that use of flash CGM was very useful in Indian patients also. So all these studies have similar conclusions. The conclusions which you can talk about are that we can expect better glycemic control and better time in range, better HbA1c, less episodes of hypoglycemia and other glycemic emergencies in patients who use flash CGM. So ultimately, the more you use a flash CGM, the better impact it will have on the glycemic control. Now, this benefit is not limited to type 1 diabetes. The benefit was seen in both type 1 as well as type 2 diabetes. And most importantly, the more the patient scanned, the more benefit the patient got. So ultimately, it is very important that the patient scans more frequently, and more frequently the patient scans, the more frequently the patient does a CGM, the better it is for the patient in terms of the glycemic output and in terms of the clinical benefit. Now, there is one very important aspect of flash CGM is that it gives you trend arrows, right? So you can actually predict where you're going. So if your trend arrow is flat, that means your glucose is stable. If your trend arrow is going up, that means your glucose is going up. And if your trend arrow is going down, that means your glucose values are going down. So with this, you can predict, let's say my current, glucose value is 120 and it is showing a trend value going down. That means that perhaps if I don't eat enough next few hours, I'm probably going to develop after, hypoglycemia after, 5 or 6 o'clock in the evening, right? So let's say my sugar is already 80 and I'm going to bed and my trend arrow is showing down. Then it tells me that, if I don't, have something to eat, perhaps the patient, I will develop hypoglycemia in the next a few hours, and that will lead to a nocturnal hypoglycemia. So hence, a trend arrow is very useful for the patient to predict, and those patients who understand these trend arrows are able to do better in terms of their glycemic control and overall glycemic parameters. So, but we don't. At end of the day, when you talk about flash CGM, the flash CGM is ultimately being used by the patients. It is not being used by the doctors. The doctors, of course, you get the data ultimately, and you use the data for better glycemic control. But at end of the day, it is the patient who has to use it, right? So what are the reviews of a patient with the use of flash glucose monitoring? This is something which is very interesting, and this is something which I really wanted to find out, that how do patients perceive use of flash glucose monitoring. Now we talked to some of our patients already on flash glucose monitoring, and took some feedback from them, especially those who are of the younger age and who are very technically sound. We talked to those patients a little more, but then I also wanted to see what people across the country, what patients across the country have to say about it. So I got a sort of flash of an idea, that why not look at the customer reviews on Amazon. And very interestingly, flash glucose monitoring or a Abbott Libre is available on Amazon. And let's see what patients are talking about as far as the flash glucose monitoring is concerned. So these are some of the terms which were frequently used. These were trending issues in the overall reviews which the patient talked about. Of course, Freestyle Libre, Libre Pro overall, all these things were fine. People talked about overall experience, whether it's worth buying or not. They talked about glucose levels, blood sugars. They, hassle-free, something which was the word which was used very frequently. Experience with free lifestyle is generally good, highly recommended. So these were some of the terminologies which patients preferred using when they talked about flash CGM. Right now, some of the issues were very common. So I've highlighted some issues which were very common to patients. And this is what, when you prescribe a flash CGM to your patient, these issues you have to be aware about. And I also talk about, the answers which you should give to your patient with regards to these things, right? So this patient says that, I'll just talk about what is highlighted here, right? What he says is that Mr. Satish says that sensor life is unpredictable. It is a bit odd to see that the sensor is always 30 to 40 points lower than the readings of a built-in meter. Remember the flash CGM which you get from Abbott, it also works as a glucometer itself. Again, it is also observed that the sensor reading is 40 to 50 points lower than that of a AccuCheck reading, right? So that AccuCheck is another brand of glucometer. And one more comment related to data management. I could not transfer the data from meter to any other device. So these are some of the issues which this patient has with regards to the use of flash CGM, right? Now, I'm going to talk about the lower glucose reading in a few minutes. So, that point will take, in a while. But there's another thing, which we are not highlighted here, and that's the one here. This patient, actually, the sensor died after use in a couple of days. This has been observed in a lot of patients. So, be careful. Sometimes what happens is that the sensor, doesn't work at all, or within 1 or 2 days, it dies. I had a couple of patients who had this issue. And, thankfully, the Abbott, there is a toll-free number in that you call them up and they'll replace the sensor. That is what they generally do. So they do a free replacement of the sensor. And these are things. The issue about lower readings compared to AccuCheck or compared to their own glucometer, we'll discuss in a few minutes. We'll talk about this point. This patient says that it's an excellent product, very useful. But of course, he talks about price, which is very important, right? So the sensor costs about 5,000 rupees for 14 days, right? So if you talk about a monthly cost, that's added 10,000 rupees an extra month to the patient. So this makes it a little expensive compared to if you talk about a Freestyle Libre Pro, the sensor costs only 2,200 rupees. So the Libre Pro is much cheaper compared to Libre, and the Libre it costs about 5,000, which is on the expensive end. So all patients may not be able to. A lot of patients would read it, but a lot of patients would not be able to afford it, and that is one of the challenges which you have. This is another patient who says that it stopped working after 2 days. It didn't work for 14 days. So this is a common issue. Especially, it is seen in Indian context. I don't know why. I think the company can probably, tell us more about it. But one thing, like I said, is that they'll replace it free of charge if this issue typically happens, right? This patient says that in his or her experience, the Freestyle Libre is simple and it's a painless process. One of the best part is that it is receiving information about glucose level without having to prick your finger, use test strips, lancets, or blood. All you need to do is just press the button on the reader and scan the sensor. So for this patient, this is a very useful tool because it makes the life of this person very, very simple, right? This is another patient who has again good things to say about it. The patient says that the sensor is put on painlessly, so a very easy process to apply. That is a good part about this. It stays on for the next 2 weeks. You can sleep using it. It's waterproof, so you can take a bath. You can wear it under your clothes. It's very easy. It is very discreet. So it's a great product in that sense for this patient to use. There's another issue that is constant in a lot of these reviews is that you cannot lack of transfer data in India. There is a reason for this. I'll deal with this at this point of time. See, the issue is that currently the Freestyle Libre Pro, there is a desktop software which comes along with it, but the Freestyle Libre, which is the more expensive one, and that's the Flash CGM, the company has not released any software or has not released any system by which you can transfer the data to the desktop. So you'll get the data within the reader, and you can review the data from the reader, but you cannot download it. But there is a workaround to this. There is a international website which is official website of Abbott, which is known as LibreView. So it's www.libreview.com. So you can go to this website. The only thing is that this website cannot be used in India. So what you need to do is you need to use something which is known as VPN, right? Those who are very familiar with using day-to-day computer and electronics will be familiar with VPN. VPN actually basically hides that fact that you are from India, right? So you can use a VPN. You can sign up with this. Give a you can give an American address or a UK address or something like that, right? So you can do that. Once you sign up, it will download a small software on your hard disk, and then using that software as an adapter, you can plug in your CGM device and it will take up the data just like your desktop. In fact, you don't need any software at all. Directly you can transfer the data to this website. It gives you beautiful reports without doing it. Now, if you don't want to do this, there is another third-party app known as Tidepool, Tidepool. So Tidepool is a free software which can take data from Abbott Libre, and it can again sync the data on the website, and you can generate reports for the patient. You can also get data like time in range, the glycemic variability, the standard deviation, and everything, right? So you can use either Tidepool, which is a third-party software, or you can use the official software called LibreView. But the only thing is LibreView, I don't know what the issue is with, why are we treated as a third-class citizens in our own country? I don't understand. But at the same time, LibreView is not available in India, but you can use a VPN and you can easily sign up. That is what I do. I've been using this for quite some time now, and it's very seamless, and it works perfectly. So if you need any help, you can get in touch with me. I'll help you how to kind of sign up to LibreView and download your data. So you can download the data. Only thing is you need to work around it. They have not made it as an easy process, which is unfortunate. So if anybody from Abbott company are listening to this, I think they should be sorting out this problem very, very soon. Okay, but so there are issues which people need to understand about CGM, right? So from these reviews, there are a couple of issues which I'd really like to point out. The first is, a lot of people talk about accuracy. As you saw from a couple of reviews that, people wanted to know about the accuracy. Why is it so accurate or inaccurate? Well, to measure the accuracy, there is a data which we generate, which is known as mean absolute relative difference, or MARD. This is a popular way of characterizing the performance of any glucometer or CGM device. Now, if you see the data, these are the MARD values of various glucometers which are available across the world. And the lower the MARD value, the better the accuracy of the device. So the best device is actually Contour Next. Contour Next is available, in India. It is manufactured by Panasonic, so it's available in India as Contour Plus One. So it's available in India, so you can use that. We have One Touch also available in India, AccuCheck, etc. So this is Freestyle Abbott Freestyle Lite. So these are some of the glucometers. Similar glucometers are available in India. These are very accurate glucometers compared to there are certain companies where the glucometer is not very accurate, right? So typically, we see from this glucometer, the MARD value is anywhere about 6 or 7 to something as high as 20, right? It cannot be more than 20 because FDA does not allow the inaccuracy to be more than 20%. So typically the accuracy is in the range of 10, about 5 to 20. So average of 10. So median values of 10 is typically what you find in terms of the MARD value. So if you compare that to glucometer, to the CGM devices, the MARD value of CGM is also very comparable to the glucometer. So typically, if you talk about Freestyle Libre, the MARD value is 9.7. So it falls somewhere in the middle in terms of accuracy with the glucometer. So you will expect a difference of 10% very easily compared to any glucometer, right? This one person who talked about 30 to 40, well, in clinical practice, we don't see that big a difference, but we definitely see a difference of 10%. So typically, let's say your glucose value is 100, your CGM would typically show 90. It generally shows a slightly lower value. So typically you would show a value of 90. If your value is, if your glucose reading is 90, it will typically show something like 81 or 80, right? So always consider a 10% difference. And remember, your CGM device will always show 10% lower value. The reason is that these devices are factory calibrated, and Abbott has intentionally made it as a slightly lower calibration so that we don't miss out hypoglycemia. So that is the reason why these tend to be on the lower end of calibration, and you will typically find about 10 milligram per deciliter, about 10% lower value with a CGM compared to the glucometer, right? So this is something you should keep in mind while you are dealing with this glucometers. Second, like I said, you need to understand trends. This is very, very important. So if you have a trend value up, it means that the glucose value is very rapidly rising. If it is something like this, it shows it is rising. That means it is increasing by 1 to 2 milligram per deciliter or 30 to 60 milligram per deciliter in 30 minutes. When it's flat, it means that it is not changing much. This is the best case scenario. When it is falling like this, it means that it is falling by 30 to 60 milligram in 30 minutes. And if it's rapidly falling, this cases you have to take immediate action. Otherwise, the patient will develop hypoglycemia, right? So typically you can see here, right? You can see some, down dippings here. But what you have to remember is that don't use CGM for hypoglycemia, especially in normal people. Like I said, if you use CGM, you will get lower readings. Typically in this, you can see that, this is a normal person using a CGM, and you'll find slightly lower readings, right? So always keep in mind that don't use CGM to detect hypoglycemias, because, you will get false positives, and, you might end up misdiagnosing the patient. Flash often. The more you flash, the more you will get more accurate result, right? This comes from the law of what is known as law of averages. So the more, see, this is same principle if you use let's say an SIP in a mutual fund, right? So more frequently you invest in a mutual fund, the more better average return you will get, right? The same way, the more you flash, the more data you will get, and more data you'll get overall, you'll get a more decent figure in terms of the accuracy, right? Again, there are a lot of third party apps. There is an app known as GLIMP. In this GLIMP app, you can do a calibration. So in this, we have used the GLIMP app to calibrate the sugar reading. This is a type 1 patient, right? And you can see what this red dot you see, that means the patient checked using their own glucometer, then entered the data, and using all these third party applications, you will be able to calibrate it and make your readings much better, right? This is a great article by one person who is a user himself of the CGM, and what he says is that overall inaccuracy is higher in the first few days after using the CGM and the last few days of using CGM. So when you are using it for 14 days, the first one to 2 days you will find more inaccuracy, and the last 1 to 2 days you will find more inaccuracy, right? So ultimately, the middle part is when you get the most accurate data, right? Some patients, like this patient, first patient said, the difference was 30 to 40 milligram per deciliter. Perhaps it was because the readings were taken in the first day. So allow the CGM to kind of get into its momentum in the first 2 days. So first 2 days, you will find a lot of inaccuracy, but after that, your accuracy becomes very, very solid, and it becomes very close to what you use, in your using your glucometer in day-to-day practice, right? So just to summarize what we learned today, flash glucose monitoring or flash CGM is a form of intermittently used CGM. The one which is available in India is known as Abbott Libre. There are various real-life evidence studies from across the world which have shown that the use of flash CGM improves glycemic control, improves the time in range, reduces the risk of hypoglycemia and hyperglycemia. The more you flash, so this is something you should tell your patients, the more you flash, the better results you'll get. Indian users are very happy with the ease and convenience of the use of CGM, but they have issues with price, they have issues with the dying of sensor, lack of data transfer, and accuracy. We have tried to deal with all these issues. Perhaps, again, if your patient has any queries, these are things you can kind of discuss with the patients. And most importantly, CGM is more useful for trends rather than for accuracy. So try to use CGM more to predict data, to get trends of the data, rather than to and to see a bird eye view of the data, rather than to really focus on accuracy. This device is not made for accuracy. This device is basically made for to look at the trend and you look at the pattern, right? And that is the key fundamental you should understand while you're using a CGM. So I thank you all for a patient listening, and once again I thank the organizers for allowing me to give this talk. Thank you so much.
Thank you, Dr. Om. Thank you. Over to you, Dr. Praveen.
Thank you, Dr. Om. You've given a wonderful exposition of continuous glucose monitoring and flash glucose monitoring. It's indeed eye-opener. In fact, in day-to-day clinical practice, whenever we insist upon monitoring of blood sugar, we always say self-monitoring of blood glucose, and many of the times we find our patients are not really complying with the instructions. But if they have easy access to the simple gadgets like flash glucose monitoring, that is wonderfully depicted by you in one of your pictures, that I should know before I want it, right? The moment you take it close to the sensor, immediately it tips and gives you the reading. That is amazing. So the two issues which I think I have got the queries to ask you, which I will be asking subsequently after the lectures are over by all our esteemed speakers. But other than that, it was a wonderful lecture, and I'm sure people have definitely a good learning experience, and they would be much more encouraged. The fellow clinicians would be also encouraged to improvise and increase the use of the blood glucose monitoring in the day-to-day clinical practice for good blood glucose. Thank you
Thank you,
very
sir.
much.
Thank you so much.
Now, we have next speaker, Dr. Will you introduce him?
Yes, sir. Go
Next
ahead.
speaker we have,
Dr. Sanjay
next
Reddy.
speaker we have, is Dr. Sanjay Reddy, and he's going to talk about, is it the time to use SGLT2 for all type 2 diabetes patients? Now we have seen many of the international guidelines virtually giving much more importance to drugs like DPP4, SGLT inhibitors, and GLP-1 analogs. Now, where do these SGLT2 inhibitors stand today when we think of the algorithms led by various international organizations? What are the merits? What are the distinct advantages associated with SGLT2 inhibitors when it is compared with GLP-1 analogs? We have none other than a wonderful person, one knowledgeable person, Dr. Sanjay Reddy, to elaborate, to discuss upon, to highlight upon this topic of SGLT2 as a drug which should be more prolifically used in management of hyperglycemia. Dr. Sanjay, a senior consultant diabetologist at Center for Diabetes and Endocrine Care in Fortis Hospital, Bangalore. And I think he's a very well-known figure. We have seen in the inaugural ceremony also Dr. Sanjay Reddy was very much seen. And I now hand over the podium for Dr. Sanjay Reddy for his talk.
Thank you.
Dr.
Dr.
Reddy.
Thank you, Praveen, and other chairperson for introducing me. And can I allow me to share my screen? I have a couple of slides which I've taken off because the topic given to me today was something which I need to put in a little thought. So can you allow me to share my screen, or you're sharing my screen? Okay, I can. I can, but they've already put up they're not allowing. Okay, thank you. I'm sharing my screen. Give me a second. Okay, there we go. Now, is it the topic given to me? Is it time to use SGLT2 for all type 2 diabetes patients? I know the forum listening to this talk would have listened to a lot of SGLT2 inhibitors, and over the years, and we've been bombarded with information and where they're used, where they're not used. What I will give you is an open forum to, I believe, that it's time to use SGLT2 for all patients with type 2 diabetes, in type 2 diabetes patients. Now, I don't have conflict of interest for this talk. This talk is not sponsored by any of the pharmaceutical countries. I have no conflict here. Now, though I have to declare that I worked with many of these SGLT2 inhibitors in the early part of development, phase 2 and phase 3, for many years, till 2016. So what would you call an ideal diabetic drug? What do you think would be the best drug you want to give to a diabetes patient? What are the characteristics you look for this drug? You're looking for glycemic efficacy, easy to administer, should be an oral drug, not injectable. You can ask the once a day usage probably. Yeah, the patient must be able to take it anytime he wants. It should be durable. You use it in any part of the lifetime of a diabetic patient. It should be durable for some period of time. Meaning to say, for longer periods, it has to give you the same efficacy. Has low hypoglycemic potential, probably additional benefits if their BMI, blood pressure, additional. Can it give additional benefits apart from having these effects on BMI, blood pressure, probably lipids, weight, waist circumference? Does it have additional protective effects on the end organs? That minimal or no adverse effects, minimal glycemic variability. We were seeing Ohm's talk on flash glucose monitoring, and how time in range has become an important factor in the management of diabetes to reduce complications. Probably we're too early to predict too much, but early trends suggest that they do have some value in improving glycemic, in improving probably outcomes related to diabetes care. Usage can be used in all comorbid condition. Should have minimal monitoring. You don't like, now if you're taking some of the drugs, you don't want the patient to monitor himself regularly to say that his sugars are fluctuating, meaning again going into variability issues. Should have least effect on the beta cells. And there you go, cost of therapy, and the list goes on. Should be there for always. So, what I'm going to do is, does SGLT2 inhibitors have are going to give us all these benefits? And if so, are they idealistic to be used in all patients with type 2 diabetes? We all know it all started in 1853 from French chemist isolated fluorescein from the bark of an apple tree. And there you have J.R. Tolkien saying, few can foresee whither the road will lead them till they come to its end. 1835, it has taken us 200 and odd years to decide that an apple bark has some medicinal properties to see that it can be used to treat diabetes. Now, introducing SGLT2 from a natural product to an investigational drug, just wanted to touch upon certain facts. You know that it is from the apple bark and naturally found also in the fruit and skin of the apples. In 1886, reported to cause glycosuria. 1913, fluorescein used as a tool to investigate renal physiology. And in 1987, fluorescein was used to show that insulin deficiency leads to insulin resistance. Fluorescein diabetes is something which discovered at that point of time. Now, why did it take such a long time for us? We all knew there was an earlier drug which was used, but there was both SGLT1 and SGLT2 inhibition, and that caused severe hepatic damage. So it was banned. Now, I was thrown out of an ethics committee meeting way back in 2003 for a phase 2 trial on an SGLT2 inhibitors. The learned council at that time thought that it's against pathogenesis of diabetes. And I wouldn't find fault with them. But going back and revisiting, I said they missed an opportunity to prove or disprove a drug at that point of time. They said, what are you asking? You're coming and telling me that this drug is going to throw a lot of urine there? No, we're not going to give approve this. This is against pathogenesis of diabetes. That was the understanding of pathogenesis. Now, what happened with this pathogenesis and what had changed? Says that SGLT2 inhibitors, which are present in the kidneys, which are mainly responsible for glucose reabsorption, when you block them, you're going to excrete a lot of glucose in urine. Now, addressing the pathophysiology, this also is key of any drug when you want to choose it for or think for using it for diabetic patients. Now, what are the different pathophysiological mechanisms it can address? And the known mechanism, pathophysiological mechanism, we know so far. It increases insulin sensitivity, increases glucose uptake, this inhibits renal glucose absorption, there's a lot of excretion of glucose there, increased lipid oxidation to a certain extent, improved beta cell function, or it probably had status quo on the beta cell function, increased glucagon secretion in the physiological range, increased exogenous glucose production. So what happened is, what are we trying to do? It does address certain pathologies, but doesn't cover everything. It doesn't have any effect on the incretins. It doesn't have anything on the neurotransmitter dysfunction. Doesn't have anything on the beta cells. But it did preserve them. But it didn't increase insulin secretion. What is the relationship? We all know healthy subject. The renal threshold is around 180 milligrams per deciliter. This is just a recap of what these drugs do. And in a type 2 diabetes patient, the renal threshold is shifted to 250, meaning to say, even with 230 to 40, they don't start excreting the glucose in urine. Now, glucose reabsorption in kidney, healthy versus an adult patient, a healthy patient, the absorption rate is more in the absorption rate with diabetes patients is increased. So, taking this, I wanted to touch upon efficacy of SGLT2 inhibitors. I've taken an example of dapagliflozin, but all SGLT2 inhibitors, looking at the efficacy. Their efficacy independently, they will get down the A1C by 1%, meaning to say 0.86. FDA says that any molecule which gets independently an A1C with that of the placebo of 0.6 to 0.7 is given approval as a glycemic lowering drug. Now, this is on the efficacy. You see now the efficacy? Yes, it does decrease glucose. Body weight, definitely. The higher the BMI, the maximum loss of weight you have and the decrease in your BMI. So it has glycemic efficacy, as we're talking about an ideal drug. It decreases weight. Third, durability. Yes, it is durable. Going by this study, treatment with dapagliflozin results in similar reduction in HbA1c with compared with other OADs, and durability is preserved up to 4 years of treatment period. What are the next one which have? You want less or no hypoglycemia. Now you compare it with other drugs, the chance of no, this is sorry. This is on blood pressure. If you look at blood pressure lowering, independently, these drugs, SGLT2 inhibitors, had blood pressure lowering to a to a certain extent, not very robust, but did have a synergistic action when they are used and compared with placebo. They definitely decreased blood pressure. So you had all these additional benefits coming in now, and one is weight, glucose efficacy, decrease in BMI, and blood pressure. What about hypoglycemia? Now, when you compare with other drugs, the chance, other oral hypoglycemic drug, the chance of you getting hypoglycemia is nearly 10 times lower than with a combination of metformin and sulfonylurea, which you see very commonly used by most of our patients. Now, these are the things which you need. We thought about efficacy as well as lower hypoglycemia risk. What about its superiority in CV risk aversion? Now you look at SGLT inhibitors versus other OADs. I'm not comparing SGLT2 with other SGLT2s. You have 19% risk reduction in MI, all-cause death by some 49%, heart failure risk by 36%, and stroke by 32%. So we have on the cardiovascular continuum, there is decreased relative risk reduction when you use an SGLT2 inhibitor compared to other OADs. Now, what about its effect on heart failure was very profound. So in all the programs of SGLT2 inhibitors and the cardiovascular endpoint driven trials, there's a significant reduction in heart failure risk from somewhere around 30% on heart failure hospitalization. Effect on renal outcomes. Now, no other drug till date did we find that it had some effect on the kidneys and showed deterioration or stopped deterioration of kidney functions in terms of progression to microalbuminuria or progression to end-stage renal disease. So there was relative reduction on the renal outcome. So you have two other things. It had favorable effect on the heart as well as the renal outcome. And looking at worsening of end-stage renal disease or renal death, when you look at SGLT2 inhibitors, they definitely had benefit, whether it's in the EMPA-REG outcome, the CANVAS, or the DECLARE-TIMI, all of them, they had benefit on the renal outcomes. Now we know SGLT2 inhibitors have a strong benefit on renal composite outcome seen in patients with type 2 diabetes and established cardiovascular risk. Now if you look at all the drugs which we use, its effect on the biomarkers or the improvements in metabolic parameters. Look at SGLT2 inhibitors. If you look at A1C, body weight, blood pressure, albuminuria, MACE, heart failure, progression to DKD, they had all the benefits seen by them were robust compared to several anti-hyperglycemic drugs, though GLP-1 RAs did match to a certain extent. Now, if you look at, these were all clinical trial data. Do we have data in real world showing us people taking SGLT2 versus people with diabetes taking SGLT2 inhibitors versus not taking SGLT2 inhibitors? What is the risk reduction in heart failure? It is 56%. This was looked at the Observe 4D study in a real world setting where a canagliflozin was used. And in the SL study, cardiovascular outcomes in mortality after initiation of canagliflozin versus SGLT2 inhibitors, those who took SGLT2 inhibitors, there was a 37% risk reduction in CV death versus non-SGLT2 inhibitors and a 26% reduction. This is real world data, quite a large number. So what we are saying is so after this, what were the indications recommended by every agency on SGLT2 inhibitors? Now, then came in the ADA classification as to say, okay, ASV, if depending on atherosclerotic cardiovascular risk factors, you start giving patient treatment. Now, we all know treatment has to be individualized for every patient with diabetes. But I'm being asked a question that can we give SGLT2 inhibitors to every type 2 diabetes patients? But this is the recommendation. You all know this. You've been saying this for a long time. You know, first metformin, lifestyle, along with depending on the cardiovascular risk, renal risk, comorbid conditions present, compelling or cost, which is a factor you need to decide. So what are the approved indications? Blood glucose reduction, CV risk reduction in type 2 diabetes, CV death reduction in patients with type 2 diabetes, heart failure risk reduction in type 2 diabetes, renal risk reduction in type 2 diabetes. Benefits on the kidney, slowing progression to DKD, slowing progression to CKD, and in heart failure patients. Apart from the regular diabetes patients, these are all the additional approved indications we have for SGLT2 inhibitors. I don't think many other drugs do have these approved indications with these presence. Now, what are the absolute contraindications for doing an SGLT2 inhibitor? Severe renal impairment, ESRD or dialysis, hypersensitivity, hemodynamic instability, and severe acute stress. We have seen in severe conditions like COVID pneumonia, moderate to severe COVID pneumonia, you're not supposed to use SGLT2 inhibitors. One of the examples I said, in severe acute illness or type 1 diabetes, there are those trials happening with type 1 diabetes, they are not to be used. So these are the contraindications for use of SGLT2. Saying this, what is the most biggest drawback of them? Genital infection in type 2 diabetes and SGLT2I. Now you look at I put in all the three different classes of DAPA, CANA, or empagliflozin, a number of people, up to 4% of patients, do complain of some sort of genital infections, especially fungal infections of the genital tract. So you can prevent them by genital hygiene, adequate hydration. If symptom of urogenital infection, you need to report to the doctor. Now, the last part of it, going by the my initial slide as to say what an ideal diabetic drug could be. Could it be an SGLT2 inhibitor? Canagliflozin. This is the cost of drugs which I picked up from the pharmacy a couple of days ago and looked at Cana, DAPA, EMPA, generic DAPA, which is around $12, 10 to 12 rupees, remogliflozin. So this is the cost of drugs today in an Indian market for all the SGLT2 inhibitors, cost per day. This is cost per day. Now, if you compare it, and all of you have been practicing doctors, know how much a cost, how much metformin costs, how much sulfonylurea costs, how much pioglitazone costs. Yes, they're cheaper, though, but looking at the benefit of them, I think they are also come to a cost benefit. If we do a cost benefit ratio analysis, I think the generic drugs in future they're going to become generic, and their advantages are many. So what we already know is on the left side. What we will know in future: improving outcomes in heart failure with preserved ejection fraction, improving outcomes in acute decompensated heart failure, prevention heart failure in post-MI patients, slowing renal disease progression in CKD, even with type 1 diabetes. I think the nephrologists are more interested in trying to use that as a nephroprotective drug in future. I think there's some things which are happening in this front too. So SGLT2, is it for all type 2 diabetes patients? No, choose your patients widely. I would always say no one drug fits all. It is again trying to choose the drug. But in majority of the patients, with the benefit it is shown in different individuals, it is the first, second line drug after metformin. It's an add-on therapy at any stage of the disease, can be used in young and elderly diabetes patients as an add-on therapy to insulin to patients without heart diabetes, with heart failure, established CV complications. As for now, For me, I would say it is not for everybody who's coming to type 2 diabetes across the patient. Please assess the patient, think about what you have to, but to look at the benefits. And also, I'm not denying the fact every no drug has been here without an adverse event. So it's not Ayurveda where there is no effect or no adverse effect. We're not going to talk about it. We have effect here, so which gives an adverse effect. So every drug is there. Choose carefully, but I think they can be used for a wide population of people with type 2 diabetes. Thank you very much.
Excellent talk, Dr. Sanjay Reddy. Thank you very much for highlighting the importance of an SGLT2 inhibitors in practice and how one should do not miss any chance to give SGLT2 inhibitors in the practice and helping the patient. So with this, we are moving ahead with the fourth talk of the today's afternoon session, the inaugural session. And Dr. Sujay Majumdar from Kolkata will speak on again place of other oral antidiabetic agents in the era of SGLT2 inhibitors, which, when, and why. So again, I think so. It's a debate kind of talk actually. Dr. Sanjay Reddy already spoke for in favor of SGLT2 inhibitors, and probably Dr. Sujay is going to against. So this is a really hot topic actually for today's afternoon session. And Dr. Sujay Majumdar is head of Department of Diabetology and Judy Hospital and Diabetes Institute, Kolkata. Senior visiting endocrinologist, Peerless Hospital, Kolkata. Is MD, MRCP, FRCP, and you name the fellowship, you will notice in his biodata. He is examiner for MRCP for clinical examination in India, a vice chairman for Indian chapter, Royal College Physician of Ireland. He has a 23 publication in peer-reviewed national and international journals, 7 book chapters, and reviewers in diabetes medicine, and editor, joint editor and author. More than 200 oral presentations at regional, national, and international meetings. So he has a vast experience in terms of speaking in different platforms. And today, I'm sure he will really put his line, his view that not just SGLT2 inhibitors is the way forward, but there are other lot of gems in the field of diabetes, which is really need of an hour to understand once again. Over to you, Dr. Sujay Majumdar, sir, please.
Thank you, chairpersons, for such kind words. I hope I'm audible and visible. And I really agree with you. This could have been a debate session between myself and my dear friend, Dr. Reddy. We know each other only too well, and this could have been a very good debate session.
Yes, I think
I'm
so,
pretty
Sujay.
sure. Yeah. Thank you, Sanjay. Yeah, it could have been a Sujay versus Sanjay debate. But anyway, as Banshi and others have put me down in this sort of a scenario, I know I'm fighting a difficult game, trying to save the older oral agents. And to be very honest, I really don't know where I should start from after this such a wonderful talk from Sanjay. So this is my conflict of interest. And we all know, just like a tsunami, the SGLT2 inhibitors and the GLP-1 receptor analogs have actually been capturing the show. This is a 2020 AAC-AC guideline. And here you can see at any stage of the disease, irrespective of the HbA1c, be it less than 7.5, between 7.5 to 9, or more than 9, you have to, what they're recommending is that you start with either GLP-1 receptor analogs or SGLT2 inhibitors. So that is independent of the glycemic control. This has to be added because, which we all appreciate, that atherosclerotic cardiovascular disease, heart failure, and CKD, these are definitely very important comorbidities which contribute drastically to the adverse outcome in a patient of diabetes. And you really cannot save a patient of diabetes if you cannot control these particular comorbidities. And what is important is to bear in mind the fact that both SGLT2 inhibitors and GLP-1 receptor analogs have gone a long way in taking care of these comorbidities and thereby improving the outcome of the patients. The same thought came in the ADA 2021, and this is something which Dr. Reddy has also shown earlier. So if you've got an atherosclerotic cardiovascular disease or a heart failure or a CKD, you start with an SGLT2 inhibitor, particularly if you have got a heart failure with reduced ejection fraction. that is less than 45%. And SGLT2 inhibitors are recommended independent of glycemic control in patients with high CV risk, heart failure with reduced ejection fraction, albuminuria, apart from established atherosclerotic cardiovascular disease. This is something which we all know. And there's no fact disputing that, and I do not want to fight on this issue. But does this mean that other oral glucose lowering therapy has got no role in the management of type 2 diabetes? Answer is no. I'll give you a good analogy. I understand that if I want to travel from, say, Calcutta to Ahmedabad, the best way to travel is through a flight. But if I do not get a flight ticket, should I be prevented from traveling from Calcutta to Ahmedabad? Should I not take more recourse to a train service? Or maybe if I've got a good car and now with the fantastic roads between Calcutta and Ahmedabad, should I not take, say, a road service if I have got a good car and if I don't have the access to a plane? Well, that is exactly what the same thing is there with the other agents. Answer is not no, because apart from the additional cardiovascular and renal benefits that you get with SGLT2 inhibitors or the GLP-1 receptor analogs, we should not forget the fact that as diabetologists or endocrinologists, when we're dealing with a patient of diabetes, the reason primarily why the patient comes to us is to get the glucose under control. And to be very honest, if you look at it, SGLT2 inhibitors are not the best agents to get the glucose under control. On an average, they get your HbA1c down by around 0.7 to at best 1%. Whereas there are other good agents, including the DPP4 inhibitors, which give rise to a similar sort of an HbA1c reduction, but without some of the adverse effects that you get with the SGLT2 inhibitors. As Dr. Reddy rightly mentioned, there's no drug which you can apply for each and every patient. But at the same time, you should not factor that there are certain very glorious, I should say, inconsistencies, or I should say, contraindications of the use of SGLT2 inhibitors. So whenever we are choosing a second OAD after metformin, these are the 6 agents that I should give the maximum weight. First of all is the efficacy. Secondly is the durability. Thirdly is the mechanism of action, which means that whether this class addresses the core pathophysiologies of type 2 diabetes. And the last 3 are very, very important. Is the class indicated for a broad range of patients? We have to understand something that not all patients, as Dr. Reddy has shown, can afford, even if indicated, the SGLT2 inhibitors or the GLP-1 receptor analogs, primarily because of the cost factor. And this is a very important issue in India. And obviously the tolerability. We have come across many patients who have to give up SGLT2 inhibitors because of recurrent urinary and genital tract infection. And lastly, but not the least, is the class available to most of the patients. Whenever we're talking about SGLT2 inhibitors, if you're talking about the metro cities or maybe even the tier 2 cities, they're easily available. But I can say just travel around 100 kilometers outside any of the metro cities. You'll find that getting an SGLT2 inhibitors is sometimes very difficult. So should these patients be debarred from any diabetes treatment at all whatsoever? Obviously, the answer is no. Different drugs work differently, and SGLT2 inhibitors have shown this particular table just to give an importance to the fact that there are multifaceted ways by which the glucose-lowering therapies act. For example, the metformin, acts by reducing the hepatic glucose output and improving the insulin sensitivity. At the same time, it has also got a second reaction by increasing the GLP-1 secretion. Thiazolidinediones basically improve the insulin sensitivity and nothing else apart from that. The DPP4 inhibitors, again, they have got an effect on increased insulin synthesis, increased insulin secretion, reduced hepatic glucose output, reduced glucagon secretion, and GLP and GIP stabilization. If you compare, say, for example, a DPP4 inhibitor with the SGLT2 inhibitor mechanistically, the mechanistical benefits are much less. I mean, in other words, the SGLT2 inhibitors has got only one direct method of action, that is reduced glucose absorption. Everything else which happens as a consequence of reduced glucose absorption is an indirect effect. And sulfonylureas, as we all know, its primary effect is on increased insulin secretion and release. So having a look at the mechanistic way how the different drugs act will perhaps be in a better state to appreciate the role of the other non-SGLT2 inhibitor drugs. We've got different types of patients in our diabetes OPD. We may be having a young diabetic, newly diagnosed diabetes, who is not that old, they're around 37 years. We might be having a patient of diabetes who's presented with a heart failure. We might be having a lady with the diabetes with renal impairment, and she's around nearly 60 years old. And last but not the least, an elderly diabetic with recurrent hypoglycemia. Now, it's obvious that all of them certainly do not need SGLT2 inhibitors, even if they can afford it. In fact, in these four classes of patients, I should say primarily, SGLT2 inhibitors are the drug of choice in this gentleman, a diabetes with a heart failure, and to some extent with this lady, a diabetes with a renal impairment. So these are the two patients who would definitely benefit to an extent with SGLT2 inhibitors. But again, at the end of the day, particularly the lady, there are other agents which can also probably bring about the same sort of a benefit so far as preservation of the renal function is concerned. SGLT2 inhibitors, they definitely provide a renal benefit, but what would a SGLT2 inhibitor do in somebody whose EGFR is around 15? So these are the contraindications where you cannot use SGLT2 inhibitors. And I have put particularly the slide to emphasize the fact that you cannot use SGLT2 inhibitors in all of them. And the list of conditions where you cannot use them is actually pretty big. Recurrent UTI, GTI, and what we mean by that, more than 3 episodes of a UTI, GTI in a period of 6 months. The setting of an acute medical emergency, sepsis or shock, MI, acute LVF, hypotension, even if the patient has been on SGLT2 inhibitors before, they have to be discontinued. There is no data in pregnancy, and obviously in acute kidney injury and in patients who have got EGFR less than 30, though very recent guidelines suggest that this could be lowered as low as 25. But that does not take away the fact that if somebody's EGFR is down to 15 or 20, we still cannot use an SGLT2 inhibitor where we can safely use a DPP4 inhibitor, or maybe a sulfonylurea, or even a pioglitazone. Euglycemic decay is one of the sequelae of the use of SGLT2 inhibitors. And there are certain SGLT2 inhibitors which have got certain contraindications. For example, there's an increased risk of lower limb amputation with canagliflozin. There's an increased risk of adverse effect with uridine glucose transporters inhibitors, inducer drugs like rifampicin, phenytoin, and ritonavir. You cannot use canagliflozin with these drugs. And lastly, they should be used with extreme caution in elderly, particularly those with a history of postural hypertension. And the other issue is there is regarding the dosing. Canagliflozin is recommended to be used with the first meal, though that issue does not exist with other SGLT2 inhibitors. But this again suggests that you cannot use all the SGLT2 inhibitors as smoothly as you do with some of the other non-SGLT2 inhibitor drugs. Now, going back to the ADA, we've always focused on the left side of the panel. We have not looked at the right side of the panel. If the patient does not have any significant cardiovascular comorbidity, we can certainly think about the other drugs. And if you look at it again in full details, at least 3 classes of oral drugs, we can use them quite efficiently. And these are the DPP4 inhibitors, the thiazolidinediones, and the sulfonylureas. And particularly where a cost is a major issue, sulfonylureas and thiazolidinediones are recommended by the ADA even in 2021. If the cost is a major issue, then they should be the second add-on drug after metformin. And this is, I think the ADA has very rightfully realized that SGLT2 inhibitors are not cheap in all across the globe. And there are many people who basically live from hand to mouth, find it difficult to afford an SGLT2 inhibitor. So one of the important treatment issues regarding the treatment of diabetes is the simplicity issue of 3E. And what are these 3Es? They should be efficient and effective for the patient, easy to understand for the doctor, and error-free for both. In other words, you should be able to prescribe a medicine which will be convenient to both the patient and the doctor, and there will not be much hiccups with the use of that particular medicine. With that thought frame, let us think about how DPP4 inhibitors will fit into this bill. Which DPP4 inhibitors we should use and when and why. So we all know that DPP4 inhibitors, they have got a very simplified treatment regimen in the diabetes management. They carry a low risk of hypoglycemia, they're weight neutral, they have documented safety, except saxagliptin in hospitalization for heart failure. They've got a safety profile very similar to the placebo, few interactions with co-medications. There are no timings or dosing issues, like, for example, I talked about the canagliflozin, which is to be given with the first meal. They can be given with any meal, even they can be given even outside, being paired with any meal. And obviously these drugs, because they're given usually once daily and some of them twice daily, there's usually no compliance issue. And last but not the least, DPP4 inhibitors have got very good durability studies, which means, and there have been safety data which have looked at safety and efficacy data and durability of DPP4, which has looked at the duration of even up to 4 to 6 years. And if you look at the efficacy of the DPP4 inhibitors in glucose lowering, this is a meta-analysis which looked at of 83 randomized control trials, which looked at the glucose lowering potential of the HbA1 of the DPP4 inhibitors. And what they found out was that essentially the four major gliptins, that is sitagliptin, linagliptin, vildagliptin, and saxagliptin, essentially in conjunction with metformin, they usually have a very good, or I should say comparable, HbA1c reduction. So you can choose probably one of them. You can say that there is difference in figures, but you should not forget that in this randomized control trials, there was hardly any head-to-head study. So you cannot say that one gliptin is superior to another in that. And what is more important is that primarily the three gliptins and the four gliptins, that is saxa, allo, sita, and lina, all these four gliptins have demonstrated satisfactory cardiovascular safety, that is non-inferior 3-point MACE. The issue comes with vildagliptin, which does not have any proven CVOT, and in teneligliptin, there is no CVOT, and there's a concern for the QT prolongation. Now, regarding the cardiac safety of teneligliptin, I thought to put about this slide because teneligliptin is one of the very highly prescribed gliptins in this country. With a dose of 40 milligrams per day, there's a prolonged the placebo-corrected QTF by around 4.9 milliseconds. So we have to remember the critical upper threshold for the QT is around 5 milliseconds. Now, therefore, this caution whenever you're using teneligliptin to exercise in patients with arrhythmia, heart disease, such as a congestive heart failure or a low serum potassium, we should think about the core drugs which are administered with teneligliptin, for example, antibiotics like azithromycin, antihistaminics like astemizole, terfenadine, thiazides, antiarrhythmic drugs, etc. They can lead to the prolongation of the QT segment. And particularly, we should be very, very careful about what other agents are being co-prescribed with teneligliptin. And this includes particularly sulfonylureas, because hypoglycemia is one of the strong proponents of prolonged QTC. So hypoglycemia with teneligliptin can worsen the QTC prolongation, leading to the torsidity points and ventricular tachyarrhythmias. Regarding hospital for heart failure, only saxagliptin has been shown to have an adverse effect on the heart failure. There's a 27% increased risk of hospitalization for heart failure. The others, there is no significant difference or no significant difference in the outcome so far as the heart failure is concerned. With teneligliptin, as I mentioned, no CVOT, and in vildagliptin, though there's no CVOT, the VV trial shows there's an increase in the left diastolic, end-systolic, and end-diastolic volumes. Regarding the use in CKD, we can see that DPP4 inhibitors can be prescribed in any stage of the CKD. And apart from saxagliptin, sita, vilda, lina, all these three can be prescribed at any level of CKD, including end-stage renal disease and dialysis. Let us move on to the next drug, which we talk about, the glitazones, which, when, and why. And obviously, right now, we know that rosiglitazone is probably dead as a dodo after the first study which looked at the rosiglitazone and the cardiovascular outcome, which showed there was a 21% increased risk of cardiovascular events and a 27% increased risk of heart failure and 17% increased risk of MI. So obviously, rosiglitazone is not approved in India, and so there's no scope of discussing anything about rosiglitazone. So the only glitazone that we're left with at the moment is pioglitazone. And if you look at the effect on the HbA1c in the fasting plasma glucose, what we can see here, this is again a meta-analysis which looked at nearly 24 studies. What they have found out is that there is a significant effect on the HbA1c, not a huge difference, but it produces a substantial reduction of HbA1c between 0.5 to 1% in the majority of the patients. And similarly, there has been a proven benefit on the fasting plasma glucose. But again, whenever we are prescribing pioglitazone, the important concern that comes about is in the use in coronary artery disease. What we have seen with the pioglitazone, there is a 10 to 15% elevation of LDL, And this is more or less of less atherogenic type LDL and reduction of the more atherogenic small dense type P. So in other words, pioglitazone has got definitely some sort of role in reducing the atherosclerosis. It reduces the concentration of the more atherogenic small type LDL. And there is significantly lesser progression of atherosclerosis compared to glimepiride, as has been shown in the PROACTIVE trial. The PROACTIVE trial has shown there's no significant primary composite benefit of mortality in non-fatal MI stroke, ACS, or vascular intervention, but there was a significant secondary endpoint benefit. And last but not the least, we should not forget that pioglitazone comes with an increased risk of peripheral osteoporosis. But what has been seen, and this has been one of the benefits of pioglitazone, this is again a meta-analysis which came about around 4 years ago, which looked at 3 studies, IRIS, J-Spirit, and PROACTIVE, and they found out, on the whole, with a pioglitazone, there was a 32% risk reduction of stroke, and it has been propounded that pioglitazone may reduce the risk of recurrent stroke and major vascular events in ischemic stroke and TIA in patients with insulin resistance, even with prediabetes and type 2 diabetes. So obviously, when it comes to the stroke reduction, pioglitazone has a role to play. But off late in the last year, and we all know that isolinidiones have associated with an increased risk of heart failure. So this was a meta-analysis which was published by my dear friends, Dr. Samit Ghoshal and Dr. Binayak Sinha, and this was published in Nature Scientific Reports. And this was a meta-analysis which looked at several aspects of pioglitazone therapy. But the ones that I've chosen for my discussion is basically the MACE, the MI, the stroke, and the CV death. And what we can see from this meta-analysis that there's a significant 3-point MACE benefit and significant benefit in the stroke reduction, but there was no added benefit in MI or CV death. And obviously, this particular meta-analysis also showed pioglitazone predisposes to an increased risk of heart failure. So whenever you're using pioglitazone, you have to use it very, very carefully. How? I'll come later at the fag end of my talk. This brings us to the next agent that we talk about, one of the most commonly used agents in our day-to-day practice, the sulfonylureas. Now, which sulfonylurea to choose? We have got a host of sulfonylureas. We have got older sulfonylureas like glibenclamide and newer sulfonylureas like glimepiride, glipizide, and gliclazide. And you can see here all these sulfonylureas that metabolize extensively by the liver route. And at the same time, expression is predominantly, particularly the newer ones like glipizide and gliclazide, is the renal route. So therefore, there has to be a considerable dose adjustment, particularly with glibenclamide. And with the glipizide and with glimepiride and glipizide also, there has to be a significant dose adjustment. Gliclazide does not need that dose adjustment. And glibenclamide and glimepiride and glipizide, there is usually a slower elimination. So these factors have to be taken into mind whenever you're prescribing sulfonylurea. One of the biggest concerns of sulfonylurea prescription is hypoglycemia. This is a nice meta-analysis which compared the hypoglycemia of glibenclamide, taking glibenclamide as an index molecule and compare it with other sulfonylureas. And this is quite a busy slide. Just to summarize, let me tell you that the hypoglycemia potential of glibenclamide is more than that of glimepiride, which again is more than gliclazide. And the least hypoglycemic one in that sense is glipizide. Now comes the big question. Does this hypoglycemia actually contribute to a cardiovascular mortality? This was a meta-analysis of 47 randomized controlled trials, which reported that sulfonylureas are not associated with any increased risk for all-cause mortality, CV mortality, myocardial infarction, or stroke. There is a non-significant 40% increased risk of these events, but this is not statistically significant. This was based on this forest plot. We can see that sulfonylureas are reasonably safe. And if you look at the individual sulfonylureas, what we can find out, this was again a study which looked at nearly 9,000 patients and elderly patients, and the median age was around 70 years when people are at more risk of cardiovascular events. What they found out here, they compared gliclazide with other sulfonylureas, and what they found out here was that gliclazide was relatively better than the other sulfonylureas like glimepiride, glibenclamide, glipizide, and tolbutamide. So obviously, gliclazide was supposed to be associated with a lower risk of CV death in comparison to other sulfonylureas. But then we have got this Carolina trial, which was a head-to-head comparison between glimepiride and linagliptin, which showed that the CV 3-point MACE, CV death, non-fatal MI, non-fatal stroke, and total stroke was absolutely non-inferior. So there was no difference between linagliptin and the glimepiride arm. Again, and then when we looked at a 4-point MACE with the Carolina, we found out there was also no significant, statistically significant difference in hospitalization for unstable angina. And this is despite the fact that there was a 23% higher risk of hypoglycemia with glimepiride. So obviously, we can well understand in an agent which would probably produce a lesser degree of hypoglycemia, but having a better action, something like gliclazide. If gliclazide was the agent which was chosen in Carolina study in comparison with linagliptin, who knows? Linagliptin might have lost. About the kidney outcomes, this is again a real-world study looked at nearly 12,000 patients, and they compared the efficacies of, it was a head-to-head comparison between glimepiride and gliclazide. So they looked at two particular potential indicators of renal impairment. One was the progression to the end-stage renal disease and the sustained doubling of serum creatinine. Now they found out in the CKD stages 1 and 2, basically with gliclazide, there was a lesser sustained doubling of serum creatinine. With the HbA1c was less than 7%, again, gliclazide performed better in preventing the progression of renal failure. And also in the age group more than 62 years, gliclazide had a substantial benefit in progression of the prevention of the progression of renal failure. So to summarize, in this matched cohort of more than 12,000 patient years follow-up, there was no significant difference between the groups of the end-stage renal disease or doubling of serum creatinine, although there was a trend towards a higher risks in the glimepiride group and in the early CKD groups, as I've already pointed out. Which brings us to the million-dollar question. Whenever we're using an oral glucose-lowering therapy in CKD, we all know that in these patients, we cannot SGLT2 inhibitors beyond a certain point. So what are the agents that we should use? This is a slide taken from our book chapter, and this particularly gives you a very clear-cut idea to what extent you can use which agent, to what level of EGFR, where you can use them with the constant dose and where you can use them with the reduced dose. Then you can see here the gliptins, Sita and Vilda, they can, and also Lina, they can be used either with a reduced dose or with an intact dose up till the stage of hemodialysis, something which we cannot say about a dapagliflozin or empagliflozin. Now, the other important groups, and which is again a very problematic group, is the oral glucose-lowering therapy in the elderly. You can see here in this proposed algorithm, this was basically a joint British Societies of Geriatrics and the Joint British Society for Diabetes, which came up with this beautiful guideline. And I feel, still date, this is one of the best guidelines to deal with elderly people, particularly those above the age of 75 years. So you start with metformin and then subsequently move on to the metformin and DPP-4 inhibitor therapy. And if that doesn't work, you can add something like a sulfonylureas, like a low-risk sulfonylureas like a gliclazide or gliclazide, or you can use a GLP-1 agonist. But you see, nowhere they're mentioned about the SGLT2 inhibitors. Now you can debate that this was a pre-SGLT2 inhibitor guideline. What about SGLT2 inhibitors in elderly? This is a Japanese study which was published in 2018. And the conclusion of the study was that in older Japanese patients with diabetes, treatment with SGLT2 inhibitors for 6 months resulted in a favorable hypoglycemic effect, while no sign of dehydration was observed. Now, this is very important. We all know that as you grow old, your hypothalamus doesn't perform that well. So obviously, your thirst sensation can go down. So whenever you're using an SGLT2 inhibitor in an elderly or the super elderly, somebody whose age is more than 85 years, you run a high risk of leading this patient to a degree of significant dehydration. Because one of the ways by which we prevent dehydration in our own system is by feeling thirsty. And if the thirst sensation is gone, there's no way you can be protected against dehydration because of the SGLT2 inhibitors. So the final take-home messages about the role of the non-SGLT2 drugs in the SGLT2 era, what can we see here? If we talk about the DPP-4 inhibitors, which, when, and why, so far as the glucose lowering is concerned, there's minimal difference between Sita, Lina, Vilda, and Saxa. It can be given in any stage of the disease. Minimal drug interactions. CV safety, that is 3-point MACE, and non-inferiority has been demonstrated with Sita, Lina, Saxa, and Alo. Sax and aloe to be avoided in patients with the risk of high heart failure. And Wild and Tenelli, there have been some areas of concern which I've discussed already. Usually, these four gliptins are very safe in the elderly. They can be used in CKD, CETA, and Wilda with dose modification, and Lina without the dose modification. Saxa to be avoided in patients on hemodialysis. But one of the cons of the DPP-4 inhibitors is costly, almost as costly as the SGLT2 inhibitors. So this becomes one of the factors. But again, nowadays you have got a cheaper varieties which are much cheaper than the SGLT2 inhibitors. Pioglitazone, obviously, there's no which here, it's when and why. It's got an effective glucose lowering and a good durability action. It can be given early and late in the disease. It's beneficial in lowering the atherogenic LDL. It has got some helpful in CV outcome benefits in the 3-point MACE and stroke, but no benefit in reduction of MI or CV benefit. But you have to remember when you're giving glitazone, it is primarily for reducing the insulin resistance and reducing the glucose, and not to have those additional benefits at the same time. We should not forget about the risk of heart failure and peripheral osteoporosis, and they're preferably used as a third add-on drug without documented in patients who do not have any documented cardiorenal comorbidity. See, if the patient is otherwise safe, doesn't have any history of heart failure, doesn't have any significant renal comorbidity. Having said that, there have been studies which I did not go into for the paucity of time that pioglitazone can have a substantial benefit in preventing the worsening of the albuminuria. It is safe in CKD in the absence of fluid retention, and that is very important. Regarding the sulfonylureas, which, when, and why, again, even in the SGLT2 era, it remains a good drug to initiate treatment in newly diagnosed type 2 diabetes because it has got a rapid duration of action. It brings down the HbA1c pretty fast. We have seen with sulfonylureas, they can bring down HbA1c by as much as 2%, which none of the other agents can do. And the durability, however, is lesser than that of the other two. That is, it is less than the DPP-4 and the pioglitazone. There's an increased risk of hypoglycemia. It is lesser with the newer sulfonylureas like glipizide and gliclazide. All sulfonylureas are primarily excreted renally, so there needs a substantial dose reduction in the CKD. They should be used with caution in the elderly and the CKD with those with high risk of hypoglycemia. Glimepiride and gliclazide have demonstrated equal efficacy in the prevention of duration of renal function, except in the elderly, where gliclazide is better. Sulfonylurea, contrary to the popular belief, does not contribute, and this has been documented by several studies and meta-analysis, to increase death, all-cause mortality, MI, or stroke. Glimepiride demonstrated to be as CV safe as linagliptin in the Carolina study, despite having a 23% higher risk of hypoglycemia. And it is this Carolina study which I must say put the final nail in the coffin of this concept that sulfonylureas are associated with increased. And last but not least, so, ladies and gentlemen, I've tried to summarize the role of the non-SGLT2 inhibitors at the current moment in 2021. And these drugs, I'm pretty sure they're going to stay so long as there are going to be patients who cannot afford SGLT2 inhibitors and who have the comorbidities or the contraindications. Till we get an SGLT2 inhibitor which can overcome the majority of these contraindications, till we find some acute benefits of SGLT2 inhibitors, for example, the setting of an acute MI and LVF, something which we have not been able to unearth so far. Till then, these drugs will remain their position of importance in the management of type 2 diabetes. Thank you very much.
Thank you very much, Dr. Sujay Mukherjee. It's an excellent talk. And I think so for the diabetes India, as far as the oral hypoglycemic drug is concerned, is over because everything I learned in 2021, what's new about the OHA as far as the OHA is concerned. And this is what happened when the two stalwart in the field of diabetes is fighting for the cause. And what we have found is that multiple positive points and silent points where one should be very cautious to use all the drugs and how, when, and which drug needs to be used in the clinical practice to helping our patient. Thank you very much once again. Meet, are you there or not? Meet, reporter. Sir, Dr. Praveen, sir, can you find out any question in the chat box?
No, I couldn't retrieve any. In fact, I was looking for that. The chat box is empty. In fact, I have got a couple of questions to be asked to Dr. Holmes. That's regarding, he said that for initial 3 to 4 days and the concluding 3 to 4 days of continuous glucose monitoring, the the accuracy of blood sugar measurement is not up to the mark, right?
Sure.
For
Yes.
initial 2 to 3 days, there may be some what is called a lag period in establishing interstitial and blood glucose level. But what is why the accuracy is affected during the second, I mean, after 10th day of monitoring, why accuracy goes low?
Yeah. Actually, sir, the lag issue. Am I audible?
Yeah.
Yeah.
Yeah. The lag issue is basically sorted by the company because they use a factory calibrated device. So what they do is they develop the Abbott in small batches, and every batch it undergoes a calibration. In their one of the devices of the batch undergoes a calibration, a physiological calibration, and then same algorithm is then applied to the other members of that batch. So that is the process of calibration which Abbott is doing, and that's why this is the only device currently in market which doesn't require a calibration at all. Otherwise, all the devices, including Dexcom, you will have to use a finger stick glucose at least once or twice a day initially in the initial period to do a calibration. Now, that is the advantage of Libre, but the disadvantage is that this calibration is never perfect. So what the algorithm does is it uses its own data to auto calibrate, right? So, and that initial data, you need 1 or 2 days to generate that data, and that's why first 2 days are actually a little inaccurate. Coming to the last 2 days, we don't exactly know why it is inaccurate in the last 2 days, but the simple reason probably I understand is that perhaps the sensor starts getting detached a little bit, or maybe perhaps the whatever battery life it has, I think it starts wearing down, and because of that, perhaps the accuracy comes down. But again, including their own product monograph also, they in the product details also they mentioned that it may show inaccuracy in the tailing period and the early period. Now, perhaps the exact intricacies are not very clear, but again, in our own practice also we observed. In fact, and now we are doing a lot of studies taking data from CGM. And one of the things we learned is that we eliminate the data from the first 2 days of monitoring. Gives us a much more clearer picture rather than to use all 14-day data.
Great. Wonderful. So,
Yeah.
Yes, sir. Praveen, sir, please go
Any
ahead.
more questions? Yeah. I just wanted to have some comments about the first lecture by Dr. Ram. He had wonderfully illustrated the importance of laughter as the best medicine treatment of diabetes. Why diabetes in the entire spectrum of disease, we can say laughter therapy has enumerated the highlights. What was quite amusing and interesting was increment of NK cell activity and increase in immunity and decrease in epinephrine and cortisol levels. And the statistical figures he quoted, like 1 minute of anger is equivalent to 6 minutes of immunity, and 1 minute of laughter is 25 minutes of immunity. What an amazing, immunity booster we have in the form of laughter. So carry on for everybody here in the audience would be, yes, this practice is art of yogic laughter, wherein you don't have anything to incite laughing, right? It's something spontaneously done. And we really have to inculcate this habit of doing what is called yogic laughter. And 46% reduction in the blood sugar levels with 15 minutes of laughter. What is commendable? Why talk of drugs like HGLT2 or OHS in that case? Fantastically explained. And then I come to Dr. Reddy Saab. He had virtually a clean sweep when he spoke about the drugs like SGLT2 inhibitors. But my equal compliments and congratulations to Dr. Sujoy. He contested very brilliantly the position of OHS in the form of sulfonylureas and all other drugs. So in all, friends, we had a wonderful session, brainstorming session regarding laughter.
Dr. Zadgar, am I connected to the right now Gama Hall?
Yes, sir.
I want to comment, sir. I want just one.
Okay, I just have a concluding remark. Thank you very much for being present here, and thank you very much for being part of this symposium. And I think we have already crossed the time limit because somebody is already there.
3:55 is already there.
Sincere thanks for all of you for participating and wonderfully explaining to us what is the emerging trend in diabetes and how nicely it should be managed.
Thank you very
sir.
much.
Thank you very much. Thank you very
Thank
much.
you. Thanks a lot.
Thank you,
Keep
sir.
laughing.
Thanks a lot.
Thank you. Bye-bye.
Thank you, Dr. Mead.
And nice seeing you, Dr. Zargar, here after so many months.
Hey, God bless you. Pleasure seeing you, Sanjay.
Hi, sir.
Hi, Dr. Zerger.
Hey,
Long
hi.
time, long time. Yeah.
Hi, sir. Praveen from Bilaspur.
That is the contemporary life.
So we laugh.
Yeah, that's last.
We are following advice. We are following advice.
So we laugh, yeah.
Sanjay,
We're all
last
laughing,
time we
so that's
met
the best thing.
face-to-face was only in Bangalore during Diabetes India only. No meeting
Yeah.
that day.
From that day, we have something
That
over
was the
the
last one.
That was the last one, yeah. Last physical meeting we had. Yeah.
So
Am
thank you,
I
everyone.
connected to the right place?
Yes, I think so.
Yes, sir.
Ah,
Yes.
Metformin Symposium. Yes.
Yes. So thank you, everyone. Thank you, reporter Dr. Mead, chairpersons and speakers about these hotspots in diabetes. Now we will be having 3 therapy-related symposiums, and first symposium is related to metformin, and I will invite Dr. Ishita Sachdev, reporter, to carry on with the proceedings of this second session. Dr. Ishita, over to you.
Hi, good afternoon, everyone. And it's an honor to introduce to you chairpersons, Dr. Sandeep Rai from Mumbai. He's one of the biggest names, as we all know, in our field, established over so many years and doing wonderful work. And also Dr. Bhavesh Patel from Modasa. Over to you, chairpersons.
Thank you, Dr. Ishita. I hope I'm audible. First of all, thank you to my big thanks to Dr. Banshi Sabu and his team for inviting me to such a prestigious conference, and my profound privilege and pleasure to invite to speak one of the senior most endocrinologists of the country. He otherwise needs no introduction, but just as a formality, I must tell you, is the chairman, Department of Endocrinology, director and ex officio secretary to Government Sher-e Kashmir Institute of Medical Sciences in Srinagar. He has been a former member of the Medical Council of India and a past president, Endocrine Society of India. He's a member, Institute Body of AIMS, New Delhi, and he runs his own, he's a director of his Center for Diabetes and Endocrine Care in Srinagar. I invite Dr. Zargar to speak on very, very relevant topic as far as diabetes treatment is concerned. That will be metformin supreme position as first choice. Sir will be speaking on both pros and cons of metformin as the first choice. The floor is yours, Dr. Zargar.
Thank you so much, Sandeep, for your affectionate introduction. Are my slides visible?
Yes, sir.
Yes, sir.
In the next 15-20 minutes, what I will be deliberating on what apparently would appear obvious today, but wasn't all that obvious when we started endocrine practice. Metformin in a very supreme position. And I wish there was more time because, metformin was first time synthesized and talked about not 60 years back when people think, it was introduced to the Western world in 1960s, but 100 years back, even a bit before the insulin. It was first synthesized in 1920, and it originates from a plant product known as French lilac or goat's stew, Galila officans. But it finally crystallized into a molecule which would be used in the management of type 2 diabetes, and first time was introduced as an important therapeutic armamentarium in Britain in 1960s. And that was a time when, the world was still struggling in diabetes therapeutic armamentarium with lantinsulin, NPH, and some crude old-time sulfonylureas. None of the current generation 3 sulfonylureas were not even the generation 2. It was that chlorpropamide era. That time the metformin was introduced. But after some time, it went into a rough weather because Metformin belonged to a group of products known as bigonides, and there was another bigonide known as fenformin and buformin. Buformin in India we have not used much, but fenformin I continued using till it was available. An amazing insulin sensitizer, and some cases of lactic acidosis were reported after this product. So it hit the reputation of metformin as well. Its image was tarnished. And there was a blanket ban on all bigonides in the Western world. But gratefully, retrospectively, once we look at it, we were fortunate that it continued to be available in India. And we continued using it ad libitum from our, not only from our postdoctoral days, but from our postgraduate days only. It was reintroduced in the Western market in 1994, because by then some data from Wikipedia started trickling down and people had started feeling at least this particular molecule has some benefits when in a comparative manner, people were getting sulfonylureas and insulin. And FDA gave its permission, in a limited permission, in 1994 to be used with some caveats, like if a person has renal dysfunction, if a person has heart failure, blah, blah, blah. And if person has any propensity to have a drop in blood pressure, it should be withdrawn, so that, that heritage of lactic acidosis continued to haunt for quite some time. And at that given time when it was marketed, many people started thinking the precise mechanisms were relatively less known. But what was obviously seen was it was causing, hepatic glucose production, particularly nocturnal hepatic glucose overproduction at that given time was a very important way of liver contributing to dysglycemia. And we know its mechanisms very clearly. And this was supposed to suppress this nocturnal glucose overproduction. And understandably, all of us know that is an insulin sensitizer and improves peripheral insulin sensitivity, but also simultaneously was shown to enhance the release of GLP-1 and other gut hormones. And that had many collateral benefits. And in fact, starting right from gut. And there was a current paper published, I think just 6 months back by a basic group from Italy. We showed how metformin changes the age-related changes that occur even in the endothelium. Now, this data, when it came out in 1998, changed everything. And this came in Lancet. We showed that when you compare metformin with sulfonylureas, that long study of a couple of decades, then you have another decade, you have 3 decades data available. People who were intensely treated, and that intense treatment included metformin, there was a significant reduction in myocardial risk. And that risk reduction was up to the tune of 40%. And that is what changed everything. It was only after that long-term study published in 1998 that metformin became an important initial harbinger of managing hyperglycemia in patients with type 2 diabetes mellitus. Thereafter, over a period of time, many studies started appearing. I have picked up a few meta-analyses. Annals of Internal Medicine published in early 2017, this data which showed that metformin as a first therapy for type 2 diabetes gives good A1C reduction, is pretty safe, gives hemoglobin A1C reduction, and has tremendous advantage in terms of cardiovascular safety when compared with sulfonylureas. There was another study about meta-analysis published again in Annals of Internal Medicine only in Jan issue of 2017. We showed that there were certain classical contraindications put to use of metformin by FDA in 1994 when it was reintroduced in the North America. One of them was renal failure, cardiovascular disease, heart failure. Now look at this meta-analysis. On your left side, right at top, all-cause mortality 5 observational study. Hazards ratio 0.77. Means people who were on metformin and their diabetes was controlled had a much lower overall death rate. All-cause mortality, another 11 observational studies. Hazards ratio 0.78. Cardiovascular mortality, hazards ratio 0.77 favoring metformin. Heart failure, again, 4 observational studies. Hazards ratio 0.87 favoring metformin than the comparator. And so this is the summary of this data that I have collated from these 17 studies. Understandably, by then, metformin had become an important drug in management of diabetes. And there was a total revamping of those conventional historical contraindications to use of drug. In fact, it was seen that when the so-called quote-unquote contradictions were present, it acted even better, reduced mortality, reduced cardiovascular disease, reduced cardiovascular mortality, reduced all-cause mortality, reduced hospitalization for heart failure. And that changed the whole thing. And this is what was published just a month before that. In fact, these 2 meta-analysis and this whole chapter in 2016 in Endocrine Metabolism Clinics of North America changed the whole gamut. In fact, the authors are same 20 guys, up and down. So after this, it stamped it. Metformin is the first-line glucose-lowering drug to control hyperglycemia in type 2 diabetes mellitus. And metformin lactic acidosis, which we are more, sort of scared of, is metformin-associated lactic acidosis often caused by other conditions. If somebody has a hypotension, if somebody has an overwhelming septicemia, invariably there has to be an associated disease that causes lactic acidosis rather than metformin alone. And in 2019, 2016, FDA loosened the restrictions on the use of metformin in those so-called contraindications of metformin, particularly renal dysfunction. Metformin may be safely used in patients with mild renal impairment and some with moderate renal impairment, according to this new label change that people started talking about. Now, after that, all the guidelines were in favor of that. Metformin was used in pre-diabetes, newly diagnosed diabetes, established diabetes, diabetes with renal impairment, in type 2 diabetes with cardiovascular comorbidity, and in fact, in elderly people. And benefit was, if you have a person who has pre-diabetes, he is obese, even if he is age 60 or more, or has a history of gestational diabetes, a strong family history and obesity, metformin recommended. Data published just last year. Cardiovascular benefits, all of us know about diabetes prevention program. The data was published in 2005, showed 31% reduction in metformin arm of progression to diabetes. In fact, when that study was reanalyzed, a decade later, it was shown that metformin group experienced a further 18% reduction in their when they compared with the comparator. This is current scale of CKD where we can use it. Till this, up to 45, it can be reasonably used. But if you're using it at half the dose, up to 30 eGFR of 30 ml per minute per 1.73 meters is reasonably safe. But below 30, you need to be cautious. In elderly people, as I said, if eGFR is more than 30, this in itself is not a contraindication giving it to people. And in fact, if you just look at this, some of those age-related things that you would be considering at 60s, general health parameters, high cancer risk, hazards ratio 0.72, cardiovascular disease, hazards ratio 0.58, even in that old population, whatever other symptoms and disease associated, much better outcomes. Now, if we look at all this, many things have happened in this space of last decade and a half. Whatever has happened, has metformin lost its space? The answer is resounding no, given that data of decades and decades and decades. We look back from right from 1960s, we never stopped using it. The Eastern world never stopped using it. Now people are talking in terms, we know that better drugs have come in. SGLT2 inhibitor, GLP-1 receptor agonists, new insulin formulations, new gliptins, they have their own role. But looking at the commonality of the disease, looking at the epidemiology of the disease, looking at the economic scenario globally, metformin is probably the most cost-effective option in the treatment of type 2 diabetes mellitus. And not only that, you have people who are on metformin, good potency, durability. Your people on gliptin, metformin is a part of it. Your people on SGLT2, metformin is a part of it. Your people on sulfonylurea, metformin is also there. You have people on insulin, metformin is a part of it to prevent getting more obese. So, and clear benefits, cardiovascular benefits. And in the recent times, it has been seen that if we look at metformin in the COVID times, a possible role, metformin possesses some of the properties that could be beneficial even in these COVID times as an anti-inflammatory agent. In fact, people who have been on metformin and developed COVID, cytokine storm was seen to be lesser in them, more manageable, mortality was lesser. The huge data published rather recently, a retrospective data in diabetics who are on metformin or on alternative therapy. And you can see it there. You look at markers which were, suggestive of a cytokine storm. C-reactive protein, see on the metformin, 1.79, and on the contralateral side, 2.83. Interleukin 6, picograms per ml. People who are on metformin, 4.07, and who were not, 11.1. And that's another standard that this molecule seems to be still surprising the researchers as well as the clinicians. So these things make it an indispensable molecule even in the current times. Now, this is the data. You can see metformin users and metformin non-users. If you look, you see now today what happens when we look at how critical a person is. We look at who has COVID, how bad his lung disease is, what is the score of his lung involvement, but we also from 5th to the 7th day quantify his either a cytokine storm or a procoagulant state. And now we measure, C-reactive protein, we measure fibrinogen degranation products, we measure ferritin, we measure interleukin. And now interleukin is probably one of the most stable molecules that we measure to see the cytokine storm. And you see this huge difference that I was just alluding to. And the significant reduction has been shown also to translate into a gross reduction in morbidity and mortality, hospitalization as well as a death. Yes, understandably, we have been talking about B12 deficiency associated with metformin, and all of us have been aware of it and looking at it from time to time that they get supplements, they get evaluated if there is a collateral suggestion of a B12 deficiency. But usually in some studies have shown right from very few percent to 1/3 of people might have it. Non-vegetarians, that's relatively lesser. In vegetarians, there might be this B12 deficiency, but not a huge issue. So in summary, if you look in totality, the experience of medical community with metformin is extensive. And I must tell you, particularly in the Eastern world, particularly with us, we knew it all along. And as I'm telling you, in fenformin, I never stopped using it. The last paper on fenformin on this planet has been published by us. Because after using that for decades, we've seen one case of lactic acidosis, who also survived but had a prolonged lactic acidosis. Very low cost for a nation like us, easily manageable still with all those generics. Anybody can afford half a gram. Remains, so I believe it remains a foundation stone. And whatever other treatment we chose during the journey of this diabetes, near 100% people will continue to be tagged by this metformin. You might add on things to improve your HbA1c. We might add on things to improve the beta cell function. We might add on to improve the cardiovascular mortality, renal dysfunction. But invariably, metformin would be in 80 to 90% of the situations. And if on top of that, in the current times, in this quagmire of COVID, if it has some benefits, as people say, it's an anti-inflammatory role, it's an immunomodulatory role, and benefits pulmonary disease. So understandably, there's no reason to believe anywhere in near future this molecule is going to lose that strong position in the management of diabetes that it holds today. Thank you so much for listening to me. Over to Sandeep.
Thank you very much for that masterly oration, sir. You gave a very nice summary of metformin. And my co-chair is there, Bhavesh Patel. You can, if he's not there, then Dr. Ishita, can I invite the next speaker?
Absolutely, sir.
Sir, Dr. Zargar, we'll have the questions at the end of the session. Kindly be with us, sir.
At your disposal, sir.
Thank you so much,
all
sir.
Yours.
Thank you, sir.
Stock and barrel.
No, sir. Thank you so much.
Thank you, sir.
And speaker is there, Ishita? Dr. Virmani is there?
Dr. Anil, sir?
Dr. Anil Virmani is there?
He's not logged in, sir.
Okay. Then Dr. Piyush is Dr. Piyush Desai is there. We can have him first and wait for Dr. Virmani.
Yes, he is there, Dr. Piyush.
Can I introduce him, Ishita?
Yes, sir. Yes, sir.
Okay. So again, my pleasure to introduce a very prolific diabetologist from Surat, a young diabetologist. He's a diabetologist and endocrinologist, postgraduate diploma in endocrinology from University of South Wales, UK, recipient of Award for Excellence in Diabetes by the RSSOI in 2019. He's a member of American Association of Clinical Endocrinologists, and he's working as diabetologist and endocrinologist at Desai Diabetes and Endocrine Clinic, which is an advanced center in Surat, and also attached to the Government Medical College, and is associated with many phase 3-4 clinical trials. And he will be speaking on use of metformin in situations other than diabetes. And so I invite Dr. Piyush Desai to kindly come and give his presentation. Thank you.
Thank you, Dr. Rai. And hello to all of you. It's always been a pleasure to be a faculty in Diabetes India, and it's always a great show. And so as metformin is. I will say that metformin is something which, as Dr. Zarkar has already described it very, very nicely with his own experience with fenformin to metformin till date, that it is always considered as a first line whenever we are talking about type 2 diabetes. But I am not going to talk on type 2 diabetes and metformin because it is accepted by ADA, it is accepted by ESD, AAC, National Health Institute of Health and Clinical Science, Canadian authorities, even our own RSSDI and IDF. All. But I am going to talk today on how metformin works on other aspects of clinical profile. One, women's health, including gestational diabetes and PCOS. Metformin, cardiorenal aspect. Metformin in metabolic disorders like obesity, dyslipidemia, non-alcoholic fatty liver disease, even in an infectious disease like TB. Another comorbidity, important comorbidity in diabetes and hypertensive patient, that is cancer and age-related morbidity. So let's first talk on women's health. That women's health is basically affected by PCOS in their early reproductive age, or I will say at the time of menarche or the teen age, or in an early marriage life, and later on they got affected with gestational diabetes, very, very high association of this particular disease. And here metformin works as an anti-androgen effect. Definitely insulin sensitivity improvement is always there as a part of PCOS treatment, but it reduces risk of miscarriage. And the second line ovulation agent is also a metformin. First line is clomiphene citrate, And even now, letrozole is also accepted as a first-line drug for ovulation. But along with them, if you give metformin, it increases ovulation in infertile couple. And if you are giving metformin and patient is going for IVF, then hyperstimulation syndrome, ovarian hyperstimulation syndrome rate is less. That is very important because metformin is not considered by gynecologists as a very important drug as far as fertility is concerned. But if you see the whole aspect, actually it is a very good conjunction to whatever they give for fertility. And when person becomes gestational diabetic during her pregnancy because of affected by PCOS or family history of diabetes, again in GDM, it is found to be effective. So from PCOS with menstrual irregularity, where metformin helps to reduce hirsutism as well as menstrual irregularity, in anovulatory PCOS, it improves ovulation, increases pregnancy rate. When IVF, it reduces hyperstimulation syndrome. If patient becomes diabetic during pregnancy, then even chances of miscarriage rate is reduced and reduction of risk of gestational diabetes is also there. And over and above all, these are the potential candidates for future type 2 diabetes or cardiac disease or cancer therapy, and it improves dysglycemia, it improves metabolic dysfunction for long-term survival of this patient. We have our own Dr. Avdesh Kumar Singh's data regarding usage of metformin in gestational diabetes, because by now in gestational diabetes, insulin is the only well-validated therapy, but there are several RCTs where Dr. Avdesh Kumar has meta-analyzed and done a meta-analysis of that observational studies also, where it was found to be safe and it was found to get less maternal weight gain, less maternal hypoglycemia, and acceptable outcomes without affecting fetus as such. So we can use this drug. Yes, obviously insulin is the first drug, but along with insulin, sometimes for support, along with insulin, you can add metformin during gestational diabetes, and so as for obesity. In obesity, one of the key factor is hyperleptinemia and leptin resistance, where metformin works on leptin resistance also. Metformin may enhance leptin sensitivity, it reduces leptin secretion, and thereby it changes the expression of neuropeptide, causing hunger and increased feeling of satiety, which leads to appetite suppression and decreased food intake, which helps. And so as insulin resistance, it is a very good insulin sensitizer, improving hyperinsulinemia to a normal level and along with change in the dyslipidemia, which helps to reduce weight also. But here I would like to say metformin is not a weight loss drug. If patient is pre-diabetic, if patient is having hyperinsulinemia, it works, but it doesn't work in all patients. If you see the DPP, diabetes prevention program, now here the patients were having NGT or IGT, impaired glucose tolerance also, where 29% of the patient in metformin group lost more than 5 kg, 5% of their initial body weight in 1 year. 26% maintain over 2 years, and subject in metformin arm experience a weight loss of 2.1 kg and reduce their incidence of developing diabetes by 31%. So in this pre-diabetic population, along with the sustained weight loss, it reduces chances of getting diabetes. And in this 10-year of follow-up, the patient who were highly adherent to metformin therapy, they lost 3.5 percentage from baseline. So if patient is hyperinsulinemic, acanthosis is there, family history of diabetes is there, you may get a very good sustained weight loss as well as prevention of diabetes by giving metformin. And not only weight loss, in lipid parameter, because here improvement in the insulin sensitivity, especially at the hepatic level, because liver is very important part in dyslipidemia management. So by that, it reduces rate of lipolysis. It slows the conversion of free fatty acid to lipoprotein precursors. Thereby, it improves dyslipidemia, and along with that, weight as well as impaired glucose metabolism is also improved. And it accompanies with pro-atherosclerotic functional changes in HDL and LDL particles, and it increases the increase in triglyceride level, which is reduced by metformin. So dyslipidemia associated with poor glycemic control in type 2 diabetic patient, metformin affects that level and it reduces LDL cholesterol as well as triglyceride level. So it's a lipid-friendly anti-diabetic medicine. And if it is really works that, then why not NAFLD? So a probable mechanism by which metformin works is definitely one of the main parameters weight loss and lipid parameter benefit, but it induces insulin sensitivity, and the insulin sensitivity as well as decrease in the gluconeogenesis in the liver so that it reduces that liver glycogen synthesis. It increases glycogenolysis. It increases glucose uptake in periphery, and it increases fatty acid oxidation. So obviously, fatty deposit will be less in an FLE patient. And what about safety and long-term tolerability? We have experience of 60 years with metformin now, so there is no second thought about its safety, about its tolerability in patient. We know that there are a few gastric side effects, but it is very well taken care of. Hardly there are few percentage of the patient where we have to discontinue metformin because they cannot tolerate by gastrointestinal side effect. And the four drugs, statin, glitazone, metformin, and vitamin E, as well as adenosine L-methionine, which are considered as hepatoprotective agent. Metformin is one of the most important cornerstone because glitazone, a very good drug for fatty liver, but it doesn't reduce its weight. Statin protects, but it doesn't reduce its fatty liver. These are the good agents. So vitamin E and L as adenosine methionine and metformin are one of the most common therapy which is given by even gastroenterologists for NFD because it improves liver biochemistry and metabolic syndrome features. And if metformin can do such wonder, then why not cardiovascular system? It is having direct action through which it reduces endothelial dysfunction and it protects myocardium, which reduces chances of myocardial infarction. It reduces protein synthesis as well as transcription of NFAT and MPAK that reduces cardiac hypertrophy. It reduces endothelial dysfunction through various factors like this, by which it affects reduction in heart failure and increase in autophagy, including with inclusion with insulin sensitivity improvement. It reduces diabetic cardiomyopathy. So the new cardiovascular benefit, which has found that it exhibits anti-thrombotic property. Even Dr. Zargar just recently told that even in COVID patients who were on stable dose of metformin, cytokine storm was found to be less. Why? Because of this endothelial proliferation action, anti-thrombotic property, endothelial dysfunction reduction, which is there with metformin, which ultimately leads to protection against ischemia, reperfusion injury, followed by myocardial infarction, and so as it improves cardiomyocyte function, which reduces cardiomyopathy. And this is very good study. I would like to say that was published in Annals of Internal Medicine. This was a systemic review. The clinical outcome of metformin use in population with chronic kidney disease, congestive heart failure, and chronic liver disease, and it was found to be safe. It was found to be reduced mortality. You can see the hazard ratio of 0.77, 0.78, 0.77 in all different type of patients. And that's why even today, when we are talking about diabetes and when we are talking about ASCVD predominates or heart failure predominates or CKD, even go for KITCO guideline, which is just recently they have taken up dapagliflozin and SGLT2 inhibitor as a one of the very important part in diabetes and DKD management. Still, they have put metformin just side by side of gliflozin, SGLT2 inhibitor. So it remains a first line therapy because of this only. And if you are worrying about heart failure, see, this is not the drug to start when patient is already in heart failure or hospitalized because of heart failure. This is a drug to start in a stable heart failure patient to prevent further loss. So this is very important. And opposition to saxagliptin and pioglitazone, metformin and SGLT2 inhibitor are considered to be included in patients with diabetes and heart failure. And what about CKD? Because again, see, if patient is already having liver damage, don't use. But if patient is having NASH, use it. So it is very important to use this drug at a correct point, so you can reduce or you reduce the progression of to the further damage. So if patient is having EGFR more than 60, you can use. If it is between 45 to 60, still you can use. If it is between 30 to 45, you can use. Just you have to be cautious. And I can say with all parts of my clinical practice, it is very safe. Just monitor renal function and just see the weight loss and other parameters when you are giving metformin to a compromised EGFR. Only thing where you should stop metformin is EGFR less than 30. Along with that, we have few data regarding metformin action in tuberculosis. If patient was given INH, these are the INH treated mice when INH isoniazid was given alone and when it was given with metformin, when the combination was given, the AMPK activation by metformin inhibits mycobacterial tuberculosis growth and it has shown a benefit in comparison to isoniazid alone. It is very important that this drug affects on metabolism of bacteria, given the evidences that bacterial NDHI complex is similar to mitochondrial complex I in the both structure and function, and metformin can be a potential candidate to inhibit NDHI for mycobacterial tuberculosis. That is what exactly you can see. So these are the similar structure in mitochondrial complex and this NDHI complex, and thereby it inhibits mycobacterial tuberculosis growth. So it is one of the important extra effect what we can get with metformin when we are treating diabetes with tuberculosis. And last but not the least, the cancer. Metformin through GI absorption, through portal circulation, it goes into liver, which reduces gluconeogenesis, reduces glycemia, reduces hyperinsulinemia, because hyperinsulinemia is one of the proliferator for successive stage subcellularly, which leads to oncogenic potential. So it works by reducing that oncologic potential and direct effect on cancer cells also by changing in the oxidative stress mechanism and proliferating kinase inhibition. So we have beaming evidence from 2015, 2019, 2018, and 2016. There are multiple cancers where metformin is shown as a good implication in cancer therapy. But we have very significant meta-analysis of 6 case control studies involving a lower risk developing lung cancer in metformin group with odds ratio of 0.55. There is another data with reduced incidence of prostate cancer, and we have 35 observational study meta-analysis which has shown reduction in liver cancer, colorectal cancer, pancreatic cancer, gastric cancer, and esophageal cancer. So it's a very good therapy, and if it works for oncogenic potential and oxidative stress, then definitely this drug has some role in age-related comorbidities also. So patients who are healthy but aged, if patients are aged with high cancer risk, high CVD risk, or high fragility risk, you can see the odds ratio 0.53, 0.72, 0.58, and 0.39. So it suggests that when patient is on metformin, it is having effect on mortality. It reduces significantly. So it has shown a age-related comorbidity reduction when it was given in a type 2 diabetic old age patient. And it also improves cognitive decline and overall mortality through various diseases. How it works? Because metformin works on AMPK, that is adenosine monophosphate kinase inhibitor, through which it works on the protein and lipid synthesis, cell proliferation, angiogenesis, which is blocked by this agent, and thereby it improves cell survival and cell metabolism because this insulin-like growth factor is also blocked. So by giving metformin, by improving insulin sensitivity, it is not only controlling sugar, it is affecting everywhere in a small span of our whole body. And microbiome modification, protection against protein and lipid DNA damage, Along with that, reduction in inflammatory response, lipid metabolism, and reduction in hypoglycemia ultimately leads to anti-aging property also. So just I would like to end that after 60 years of metformin use, what we got from a seed to a big tree which treats dyslipidemia, which treats diabetes prevention, which can be a part in type 1 diabetic patient who become obese later in their life. For type 2, as we all know, it's a first line therapy. Cardiovascular disease, it reduces that. It helps in obesity. It improves microbiota. We have evidences with that. Inflammation is reduced. Aging process is reduced, so is cancer and PCOS. And it also helps to fight with tuberculosis and few other bacterial infection as well as non-alcoholic fatty liver disease. So this is what all about extra glycemic role of metformin. Thank you.
Thank you, Dr. Piyush Desai, for elaborating so many uses of metformin. And we'll take the questions at the end of the session. And so now we have the third speaker, Dr. Anil Virmani. I think he has joined us late, but nevertheless, he has been able to join. He's a very well-known diabetologist from Jharkhand. He's from Jamshedpur and he's in all conferences. A very nice, prolific speaker. He's a consultant physician and cardio-diabetologist from Jamshedpur. And I would invite him to speak on a very relevant topic today, which is very useful to the clinicians, that what to choose after metformin. What is the drugs he is going to choose after metformin? And so I request Dr. Virmani to kindly take over and start his deliberation. Thank you, sir.
Anil, you are muted. Anil, you are muted.
Sir, please unmute yourself. Yes.
Okay. Am I audible now?
Yes, yes.
Yes, sir.
Thank you. Thank you. At the outset, I would like to apologize for the network issues. I'm right now speaking through my cellular network on the mobile phone, and the slides have been shared by the technical advisors. Thank you. So what to choose after metformin is a $1 million question. I think it is no longer relevant today, but still I will discuss about pros and cons of all the oral anti-diabetic drugs. Next slide, please. Declaring my conflict of interest is basically against those fake babas who claim to have a cure for type 2 diabetes and claim that type 1 diabetes does not require insulin. Next slide, please. Earlier days, life was very simple. We all know metformin was introduced way back in 1959, but it was not till 90s that the United States approved it, but we were using it. When I started my practice in 1977, we were using metformin, and the 1993 guidelines that came for the first time were very simple. Start with metformin unless fasting sugar is very high. If that's not enough, add a sulfonylurea, otherwise stop both and start insulin. It was easy to remember, but not very patient-centered. Next slide, please. And we now know today that all guidelines segment metformin as the first line of therapy, even though its throne has been threatened by SGLT2 inhibitors, but at the moment they still remain as the first line therapy. Next slide, please. Next slide. Yeah, a lot has changed since I started my practice. Today there is a paradigm shift in treatment, and we have learned a lot about type 2 diabetes, from the classical triumvirate to a newer concept of ominous octet, egregious 11, filthy 15, and so on. And from being glucocentric, we have gone to patient-centric and now become complication-centric. We have today with us a wide variety of therapeutic agents with similar glucose-lowering efficacy in the short term and distinct adverse event profile due to specific mechanism of action or potential off-target effects. And these drugs are all well known to you. Next slide, please. The question then comes is any drug superior to the other as far as treatment of diabetes is concerned, especially in those with CVD? And the answer is, next please. Next slide. Yeah. The results of various cardiovascular outcome trials imply that the type of drugs used to achieve glycemic control does matter, because the total effect of the drug is not entirely conveyed by its effect on glucose levels. As a result, the diabetes field is moving away from its historical reliance on surrogate markers towards studies that assess outcomes such as heart disease and mortality to identify drugs that achieve goals of diabetes care. Next, please. Next slide. Yeah. And go back, please. Go back. Yeah. So we have these recent guidelines. So the choice is very easy when the patient is suffering from atherosclerotic cardiovascular disease or is high risk or has heart failure or CKD. Then of course the choice is either an SGLT2 inhibitor orally or perhaps a GLP-1 receptor agonist. Next slide, please. But the problem comes when these things are not there, then what is the direct choice? Direct choice is then patient-centered, depending on the efficacy, how much glycemic on, and the safety of the drug, especially in patients with comorbidities, whether they have a synergistic action with metformin, what are the pleiotropic effects, whether they are devoid of hypoglycemia and weight gain, are they cardiovascular safe, what is the age and duration of diabetes, what does the patient really want, what is the patient's preference, and whether he's able to comply with the cost and have good adherence. Next, please. So let's look at the various drugs. Sulfonylureas, they way back started in 1950s with tolbutamide and glipizide and glibenclamide in 84, and then we had the modern sulfonylureas, glipizide and glipizide in 95. We have now extensive clinical experience, almost 60 years. They are most potent oral agents in the early stages and can reduce A1C to the tune of 1.5 to 2%. There is a decreased microvascular risk was shown in the UK PDS study, and various randomized controlled trials did not give a bad cardiovascular signal. And of course, they are affordable. But unfortunately, they are glucose-centric or disease-centric. The durability is less. There is a hint of possible beta apoptosis. Secondary failure is common. And of course, the risk of hypoglycemia and weight gain. Next. Next slide, please. You have to reduce the dose in renal impairment and stop with hepatic failure. So sulfonylureas are effective second-line agents after metformin, and we must shift to the modern sulfonylureas like extended release gliclazide and glimepiride. And why? For the simple reason that these modern sulfonylureas have reduced mortality, less hypoglycemia, better CV outcomes, and renal protection. And these should be indicated early in the course of type 2 diabetes so that we can achieve maximum glycemic benefits and obtain the benefits of metabolic memory. The main side effect of sulfonylurea is hypoglycemia, but that can be mitigated by good patient education, and the effect on body weight can be mitigated by adding to metformin. Next. Yeah. And the use of fixed dose combinations improves both compliance and adherence. Next. Next slide, please. And to quote the Lancet Diabetes, go back, please, go back. Can you go? Yeah. Gliclazide and glimepiride were associated with the low risk of all-cause and cardiovascular mortality compared with glibenclamide. That is why we are emphasizing that we use only these two drugs. Next. Next slide. Yeah. And the South Asian Federation of Endocrine Societies came up with a consensus statement, which very rightly said that a careful choice of sulfonylureas, appropriate dosage, timing of administration, and adequate patient counseling that is person-centered will ensure that deserving patients are not deprived of the advantages of this well-established class of antidiabetic agents. Next. In addition, they are backed by a large body of evidence, experience, and most important outcome data, which supports their role in managing patients with diabetes. Next. Considering the efficacy, safety, pleiotropic benefits, and low cost of therapy, they should be considered as agents of choice for the treatment of diabetes in South Asia. Next. Looking at pioglitazone, which came in 1996, it rarely causes hypoglycemia. It has a relatively higher A1 efficacy. It is durable, reduces triglycerides, and proactive. Though the primary result was not achieved, the secondary outcome did show that MI, stroke, and cardiovascular death was significantly decreased. Then we had the IRIS trial, which showed a decreased risk of stroke and MI in patients without diabetes and with insulin resistance and history of recent stroke or TIA. Unfortunately, it leads to weight gain, edema. It can precipitate heart failure, bone fractures, especially in postmenopausal women, and macular edema. But having said all that, next please, it is one of the best insulin sensitizers. And as perspective from the Indian perspective, because we have a very high prevalence of insulin resistance. Next, please. And this cohort study has very nicely shown that there is no evidence to link it with bladder cancer. Next slide, please. And the IRIS study has shown a very nice reduction in both non-fatal and fatal stroke, fatal and non-fatal MI, ACS, heart failure, and look at the incidence of diabetes mellitus, reduced by a whopping 52%, and decrease in all-cause mortality. Next, please. So to quote Inducci, who said that my personal belief is that this drug, which is now available as an inexpensive generic formulation, is underutilized. And I'm talking about USA, but in India, this is a very cheap drug and we should be using it on a regular basis, especially very judiciously. Coming to another drug which has never been mentioned in the guidelines, the AGIs, which came somewhere in 95, 96. They decrease basically postprandial glucose excretions. They have a dual mode of action, inhibit glucose absorption and increase GLP-1. There is no hypoglycemia, no weight gain, and especially they're very suitable for the Indians because we consume a lot of carbohydrates. Unfortunately, they have GI side effects, but which have been mitigated by the newer drugs. And can you go back to the previous slide, please? Yeah, and they need frequent dosing schedules after each meal, and they have a very modest A1C efficacy. Next. And a consensus statement was published in the JAPI for the Indians especially, and which really said, yes, please go ahead. Next. AGIs have a crucial role in Indian patients due to high carbohydrate diet. They effectively control postprandial hyperglycemia and provide additional benefits. And domino effect, they also control the fasting hyperglycemia. And they can be used either as first-line drug in early type 2 diabetes who are presenting to us with only postprandial hyperglycemia or a bit in combination. They have a favorable effect on all the glycemic parameters and they improve the total glucose profile. Next. Then coming to DPP-4 inhibitors, sitagliptin came in 2006, Saxa, gliptin and linagliptin came in 2013. Now, they have an A1C reduction at par with the sulfonylureas. They are weight neutral, low risk of hypoglycemia, side effects comparable to a placebo, cardiovascular safe, and possibly pleiotropic benefits in beta cell protection. But they have a theoretical risk of pancreatitis. I've never seen one, arthralgia, and edema, increased risk of hospital and heart failure with saxagliptin and possibly alogliptin, and possible off-target effects. Next. And if you look at the egregious 11, these DPP-4 inhibitors have a wonderful effect on almost all. Next, please. Go ahead. Next. Yeah, so they have an effect on the total egregious 11, and they are basically covering the entire egregious 11 pathogenetic defects. Next. So if you look at the various trials, next, we had the PCOS trial with sitagliptin, non-inferior trial with so the CV neutral. Next. Go on. We had the SAVOR, where saxagliptin showed increased heart failure, examined with alogliptin. And then recently we had the Carolina trial with the versus DPP. And please go ahead. And all have really shown what? That DPP-4 inhibitors are cardiovascular neutral. Next. Please go ahead. Next. Yeah. Yeah. Next. So as a second option, they lead to less hypoglycemia, less weight gain, have less glycemic variability, and better quality of life. Next. Next. Next slide, please. So how do the gliptins outscore all the other anti-diabetic therapies? They have a comprehensive mechanism of action with dual targeting of alpha cells and beta cells. They have a glucose-dependent insulin secretion, so there's lesser risk of hypoglycemia, and they are weight neutral. Next, please go ahead. They are also preservation of beta cells and they stimulate beta cell neogenesis and reduce beta cell apoptosis. So overall, next. Hello, next, please. Yeah. So in addition, we have the renal and hepatic safety profile. This makes gliptins an attractive choice. These are one.
ये इसको कैसे लाना वापस? ये बंद नहीं किया है उसी पे म्यूट करना इसको म्यूट।
Some audio issues.
Yeah, can you please share the screen?
Hello, Dr. Virmani, we can't hear you.
Dr. Virmani, you are muted.
No, they have muted me. They have muted me.
So you must have got a notification to unmute yourself, Dr. Anil.
Dr. Anil, please unmute yourself.
No, I am already unmuted.
Okay,
Dr. Virmani, it is showing muted here.
I am unmuted.
Actually, his internet connection is really poor, so that's why maybe.
But we are able to hear him. Let him continue.
You continue, sir. Please continue.
So you can continue. We are able to hear you.
He again logged off.
No, he's there.
I think it's still screen sharing. Can you hear me?
Yeah. Continue.
Yeah, we hear you.
Am I audible?
Yes, Anil,
but I can't see the screen. They are still trying to share the screen. They are still trying to share the screen. I cannot see the screen.
Screen is there visible, sir. Your internet connection is unstable. That's why you are not able to see it. If you have got screen on your laptop, you can speak on those sides.
Okay. What I'll do is I'll continue.
Yeah.
Right?
Yes.
Is that slide on SGLT2 inhibitors?
Yes, it is.
Yeah, okay. Yeah. So if you look at the pros, the A1C reduction is at par with
Again, not able to listen to anything.
Yeah. I think there is a connectivity issue. He is not able to log in through.
Yeah, there's a lot of connectivity issue. Can you listen to me now?
Yeah, yes. We are able to listen to you.
Can
but
you listen
in between,
to me now?
Yeah. But in between, the voice is going off.
But can you see slides?
Yeah. Continue, sir. We are able to hear you.
Slides visible?
No, sir.
Yes.
Slides are not visible, but you can speak.
So and we all know the cons of SGLT2 inhibitors, the genital and urinary tract infections, volume depletion with loop diuretics, postural hypertension with RAS blockers and diuretics, safety in the elderly more than 75 years, and then there is a, decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased glycemic efficacy with deteriorating renal function, and then there is a decreased of these sites can be mitigated through a judicious selection of patients, through a good patient counseling, education, and then being pharmacovigilance. Can you speak in a light, please? Am I audible? Am I audible?
Yes, sir, you are audible. Yes, continue.
Okay. The various effects of SGLT2 inhibition. I hope you can see that slide on the kidney, liver, pancreas, blood vessels, blood plasma, adipose tissue, and the heart. So I will not go into details of this, but if you look at the perspective of the SGLT2 inhibitors, we'll see that they have plenty of glycemic benefits, right from insulin independent mechanism action to
His signal is breaking off in between.
reduction, calorie reduction. Yeah. And individual protection. Can you right now?
Yes, sir.
Am I
Continue.
audible?
Yes. Continue, sir. Continue.
Okay. So look at SGLT2 inhibitors, they have a very robust data for the prevention, and they are as good as statins and aspirin, and it could be negligence not used on secondary prevention. But individuals with type 2 diabetes and without established cardiovascular disease is a very important cohort for primary prevention. And primary prevention by SGLT2 inhibitors holds the greatest promise for reducing hospitalization for heart failure and CKD in patients with type 2 diabetes. But there is very weak evidence-based recommendations. And the proof of the pudding lies when you try to compare between the different drugs. So this is a meta-analysis of 12 head-to-head studies, and which very clearly shows DPP4 inhibitors. There are 12 head-to-head studies with sulfonylureas and DPP4 inhibitors, and it shows that the DPP4 inhibitors may be less glycemic, but they have less hypoglycemia. They have less their weight and less adverse events. And as far as MACE is concerned, definitely favors DPP inhibitors. And this is a study between sulfonylureas versus SGLT2 inhibitors. Can you go back to the other slide, please? Next slide. Now I'm seeing my slide, but yeah, please go back to the next slide. Yeah. So what I was talking about, the meta-analysis of 12 head-to-heads sulfonylureas with the DPP4 inhibitors, and they all show, next please, and they all show that though the DPP4 inhibitors have a lesser glycemic efficacy,
Dr. Virmani, I think we are your connection is breaking in between. Can you kindly summarize? Sir?
I know. So, yeah.
Dr. Anil Kumar Virmani, can you summarize?
I'm to the, but it's finished. So what is the add agent best suited individual by prioritizing the patient characteristics? So the first priority is, of course, atherosclerotic disease or high CV risk, hospitalized for heart failure and CKD. And then you have to have given SGLT2 inhibitors with demonstrated efficacy. But if these things are not present, then the choice of a drug would depend upon the degree of hypoglycemia, the risk of hypoglycemia, overweight, obesity, the presence of various comorbidities, preferences, and access to treatment. To give you the final message, again.
Okay, I think Dr. Virmani is almost finished or is finishing now. I would like, sir, we will have you in question and answers. Yeah, sir. Sir, because you are breaking, your voice is breaking in between. Yeah. Yes, sir. Yes, sir. Please summarize, sir. Please summarize, sir.
Yes, sir. Stop
Okay.
your video.
So when all
try
options,
to
this is the last summary slide. Please go to the summary slide. When all the options are relatively safe, given the benefits they confer, therapeutic decision making must rely on a personalized approach, taking into account patients' clinical circumstances, phenotype, pathophysiological defects, preferences, abilities, and costs. Now, regardless of the specific therapy selected, the overarching goal should be to safely achieve glycemic control at the earliest possible stage with the least risk for adverse events, thereby increasing the likelihood of the long-term durability of control and avoidance of complications in the future. Perhaps the most important message that I want to give is that the selection of one agent over another is not as important as implementing some form of early intervention and advancing rapidly to some form of combination therapy as needed. So friends, the question today is not what after metformin, but what with metformin. Thank you, and I'm extremely sorry for the connectivity issues.
Thank you very much, sir. Thank you for giving this very informative presentation in spite of so many difficulties you were facing. Still, we could get the message and it was really very nice. We have still about 15 minutes to go. We can go for some question and answers, although I find none in the chat box. I have few questions from my side since so many stalwarts are here sitting. Yes, and what difficulties I face in my practice. So I would like to ask Zargar sir and even Birmani sir, Jetwani sir, or all those stalwarts sitting. Sir, one is this question on pregnancy. I mean, to use metformin in pregnancy. Now we know different organizations, ADA is not keen to use metformin first. They want to use insulin. UK, Scotland gives green signal to metformin. Indians Ministry of Health Family Welfare, I read was about after 20 weeks you can use. A patient comes and asks, say in the 20th week or so, that sir, I have a mild raised sugar. Now, should I take metformin? Is it good for my baby? It not harm my baby? And what is the legal position? So I would like to ask Dr. Zargar. He has more than, I think, 40 to 50 years of experience as to how do you deal with this?
We have been using metformin liberally right from the word go. There have been some apprehensions that in the first trimester, it has a potential of crossing the placenta barrier. But till date, whatever data we have analyzed over these decades, we have never seen any issues. Why? You know, all of you know that polycystic ovarian syndrome is a very big issue. And in fact, currently, this is rated as the most common endocrinopathy in women globally. And we have been using this metformin to sort of break that insulin resistance as one for taking care of obesity, and second, in order to be a supplement to ovulation induction. And in our earlier endocrine practice in 80s and 90s, we found out many people got pregnant when they were on metformin and they had continued on metformin. You know the Indian scenario, a lady coming for an endocrine consultation much after getting a OBG consultation. And then once she is continuing on, 3 months have gone by. And we found out when we compared them with the guys who were not on metformin, there were no issues. In fact, I must tell you, in all these decades, I have never stopped metformin if there was no overt contraindication. One of them was that many women, would have a very severe morning sickness. And sometimes a gynec would tell them that it is this metformin which is causing them rather than educating them, it's a part of the pregnancy, particularly in the first pregnancy or second pregnancy. Now, majority of the people today globally are comfortable with it. And most of the organizations are comfortable with it. FDA has not given a blanket thing to it. I'll tell you how it evolved actually. You see, if you look at the basic concept of gestational diabetes, this was a concept that a diabetes that usually would come in the third trimester. And by that third trimester, most of the organogenesis would have started, in fact, completed, and metformin was used, no issues. But we know now in recent decades, many individual youngsters who have pre-diabetes or have had diabetes and gets for the first time diagnosed in the first trimester only, where you would always be suspicious whether you diagnose it as gestational diabetes or it was a pre-gestational diabetes that just got diagnosed during that period. In many patients, we did use metformin, so long as it gave us the glycemic targets. And the moment the glycemic targets were off short, we supplemented insulin. And if anybody walked into pregnancy when we knew she is a diabetic, now there's a third scenario now. Somebody is already pregnant, type 2 diabetic. Now, know so many people getting married at 35, getting pregnant at 36, which was not a case when we earlier on started our endocrine practice. If I look at 35 and above, 20% of those women will have gestational diabetes. But pre-gestational diabetes also would not be all that uncommon. To such people, we say walk into the pregnancy with insulin only. And but the first time we strike there, a person has been on metformin. In fact, you'll be amazed to know, even Britishers use it, even women who are obese, metformin, they use liberally, even in the first trimester, even if they do not have a frank gestation diabetes. Because they found out that baby carry home percentage is much higher in them who got metformin than in those. Placental insufficiency is relatively lesser in those guys. So I think overall, Sandeep, what is the problem? Nobody would own a molecule like metformin today and conduct a clinical trial because it's a generic molecule. And you end up in spending multi-million bucks in that clinical trial. And benefit goes to 500 companies who produce metformin globally. You see, when Piyush was just now talking about the benefits of metformin and that molecular mechanisms, what it does to heart, what it does to endothelium, how it behaves. This is exactly what we today discuss every second webinar when we talk about SGLT2 inhibitors. Jardin is doing this, Canva is doing this, DAPA doing this. And all this actually metformin does. Why it is not getting promoted? Because nobody is directly getting a major bulk economic benefit, except the common man, who gets a good drug, who gets a cheap drug. That's why, I fought tooth and nail, even pioglitazone. Tooth and nail, with all the available authorities, and brought it back. 15 to 7.5, blah, blah, blah. Because I'll tell you, it is nice to practice great medicine. See, we have great drugs, SGLT2s, modern gliptins, GLP-1 receptor agonists. But all of us are practicing in India, and all of us are honest clinicians. Be honest. How many people can afford a long time GLP-1 receptor agonist? How many people can afford a currently available best designer combination insulin? Even though it is the best, I know it is the best. But then it is not only being the best, it is also what actually gets implemented. You see, we talk about always on obesity. India has grown from position number 9 to position number. Indian women are the third most obese women on the earth. But you will be amazed to know in the last 80 years, data published by us and a global team in Lancet, our underweight people in 1975 were 48%, India, Pakistan, and Bangladesh. Today it is 52%. It has not improved. So, but they have also diabetes. They have B cell deficient diabetes. There's another story. The point is, a big chunk of people actually get all those benefits that Payush alluded to. And I was telling you, there was a lovely paper Payush published in Nature just few months back from Italy. Says how age-related changes this metformin was changing. And I wish somebody becomes owner of all that data, and then you will see a clinical trial and they will see amazing benefits. If you look at that Lancet paper that was published in 98, after which FDA changed all its thought, tell me one molecule that has shown a 39% reduction in myocardial infarction. So this is what was shown there. Yeah, that's why, we started with gestational diabetes. So I think, we are reasonably on the safer grounds today. You see, now forget about what is the regulatory situation. What is the regulatory situation with your glargine? How many trials have been done in pregnancy? None. How many trials have been done with NPH? How many trials have been done with lenti-insulin? None. We opt, Detimer, you have evidence, and you have two ultra-short acting insulins. You had ultra-short acting insulins came, we were one of the first groups to do a clinical trial in GDM on that. But those days, these ethical groups were not as aggressive as they are today. And I also happen to be one among them now, that the nation should not be taken for granted. So probably many things happening by convention, as they call by expert opinion. Clinical trials in pregnancy are going to be extremely difficult.
Thank you, sir. Thank you for your expert opinion. I think that gives a lot of encouragement.
Can I add something, please?
Please, sir. Please.
Just to reinforce what Dr. Jagar said. See, initially we had no problems when metformin was used till the end of first trimester. We had worries what is happening in the second and third trimester. But after the MIG trial, the metformin in JDM, the results were very obvious that it not only led to less maternal weight gain as compared to insulin and better patient compliance and acceptance. Plus, there was no extra hint of any miscarriages or even placental abnormalities or congenital abnormalities. So that gave us a lot of confidence that metformin can be continued throughout pregnancy. And I fully agree with Dr. Zagar that a cheap drug like this is really needed, and nobody is going to promote this drug anywhere in the country.
I feel, sir, that gynecologists are more courageous than us, because whatever patient I get of GDM is already on metformin. So my worry is gone because they are already on that. Then it comes to the dose only. They are very courageous. They are putting the patient on metformin and sending to us. Whereas all these fancy guidelines and the Western nations always say no problem is seen, but long-term trials especially in offsprings are needed like that. So, but I think most of the Indian doctors are giving it, and that is there. We have some more time, sir. I just wanted to ask, anyone can take this question as to...
Sandeep, I just, like Anil, I just, back memory, when Langer published a paper couple of decades back on sulfonylureas in pregnancy. Now that you raised this issue of pregnancy, gilbenkilimide is safe. So I was doing a journal club with my residents and postgraduates on this thing. So after we finished it, I said, everybody comes to my office and pull up all the 10 years pregnancy and diabetes data from the department, and find out how many people walked into our own institution for delivery and so who were already on sulfonylureas. So we found a whole bunch of people who I'm just like, you are in 7th month, you are already on a gilbenkilimide. I'm just like, you are not asking my opinion. You have come to the gynae has referred her to me, and blood sugars are excellent. We collated that data and published later on. Apart from one additional patient of having had a neonatal hydrocele, who could not find any problem. So sometimes, you must understand, in the Western world and us, there is when, guy like you or Anil or, we sit in OPD and see 300 people. Tell me one professor of endocrinology who can see he has at any stage in life seen 300 people in a day, in a week, in a month. I would say in a year also. So this gives us a unique ability to understand human nature and disease. So that's why we were so comfortable with metformin when the whole world was poo-pooing it.
Right.
When I was doing my DM, when I did my DM, the whole world talked against metformin, but we never stopped it. So I was always telling them, this is one great benefit of Indian political apathy, that decision was not taken banning it. If it was today, you would have 20, NGOs extra pumping on us that you are dumping a Western medicine on us, even on us. So we need to look at our own priorities very specifically.
Okay, sir. Thank you, sir. One or two more quick responses from anyone. Role of metformin in prevention of diabetes, means in pre-diabetics, and also in role in maybe overweight type 1s with a little dyslipidemia. So what is your opinion? Anyone can take that.
I would say with type 1, especially when they enter in the teenage or the later part of teenage, they become obese and insulin resistance, along with change in their sexual hormones also. So it's, I mean, 50% of them, I have put them on metformin, and very good response we can get. At least it reduces the need of insulin.
Lowers the dosage of insulin you need, and also it prevents weight gain. So yeah, more and more people use it in people who are using high dose of insulin.
Obese type 1 diabetic patient also.
Yes, yes.
Moreover, today there is no sharp distinction between type 1 and type 2 diabetes. We are seeing patients of type 1 diabetes who are overweight and obese, and they have some form of insulin resistance, and they do benefit a lot by metformin. Similarly, in patients of pre-diabetes who are obese and having insulin resistance, do benefit by metformin. So there is a subset of patients where metformin is required.
Another small, quick response, if somebody can give. There are a lot of literature about metformin non-responders due to gene polymorphisms and other things. There are about 30 to 40% people who don't respond to metformin, and now they have started doing these tests in urine for, say, citric acid, hippuric acid, and all. I was going through this literature where they can tell you which of these patients will respond to metformin. So there's a huge chunk from 30 to 40%. Now, so any one of you have seen or any experience on this, that, there is a chunk of patients who will not respond, and then will pioglitazone be a alternative? Because we have again seen patients who are intolerant, maybe even non-responder is another thing, he'll not respond, but intolerant to GI because of GI side effects. And he's an obese patient. We know when we take off metformin, very difficult to control his fasting sugars. As Zargar had said, hepatic glucose output is not then controlled, and then sooner or later you have to put him on basal insulin. So in this obese set, what is your take on pioglitazone, which one of the side effects is weight gain, and but it's a most potent insulin sensitizer. So person who is intolerant to metformin or a metformin non-responder, obviously obese, insulin resistance, what would be your take on which drug?
After the IRIS trial, where it was used in patients with insulin resistance who did not have diabetes, there was a 52% decrease in the onset of diabetes, of a whopping 52%, and that itself indicates that pioglitazone is one of the best insulin sensitizers we have. Now, regarding weight gain, weight gain can always be mitigated by lifestyle interventions. But that weight gain is not harmful because it is just a redistribution of the fat. So what fat is harmful in the visceral adiposity is being shifted to subcutaneous tissues, which actually is good. But the patient is not losing weight, or maybe because of some fluid collection is gaining weight.
Yeah.
So lifestyle interventions are going to help there.
And maybe addition of SGLT2 might also help you there.
But just like Dr. Zagar, I'm a big fan of pioglitazone, and majority of my patients are on pioglitazone, and I've hardly found any reason to discontinue because of weight gain or edema. Because you have to be very judicious in selection.
I will say,
Sandeep,
pioglitazone is overhyped. it is not always that significant. It is usually 3 to 4 kg when we are using in low dose. So even
and many people don't gain weight. I have
Yeah.
people over for years, they have not
Many
gained
people
weight,
don't gain weight
but
at
then
all.
there is that 5 to 10% people who do. And when you take them off pioglitazone, they're also very grateful to you, because then they lose weight about 8 to 10 kgs. But very good drug, very much underused. That is what I feel, and what you are also feeling the same.
And that's
A very last
everywhere,
question
you
to
know,
you.
that's
Sandeep,
everywhere. There
Sir.
is a there is a subgroup of patients who don't lose weight with the SGLT2 inhibitors also. So
Yes,
so
yes,
who is
yes, yes.
responder, who is
And
not, we have
so
to
I
find
think,
out only.
Ishita,
Yeah.
are we running out of time now?
So just 2 minutes more
Ishita?
we have. So just 2
Sandeep,
minutes more we
I
have.
would like
Supposed
to
to be
comment. I would like to comment on that.
5:24. It's
Comment on
5:22
that.
in my watch.
Yes, sir.
Important question.
So we should wind
Sandeep.
it up, huh?
Yes, sir.
So
Yeah,
last
sir.
comment from Dr. Jargar, sir.
Okay.
Yes.
You
yes.
know, you said just now about some people, diabetics, not responding to metformin.
Non-response.
See, when we talk about pre-diabetes, this pre-diabetes is twofold: impaired fasting glycemia and IGT. In 2000, we published the first paper on this earth where we showed that lack of agreement between IFG and IGT in a North Indian population. We found out IFG was far more here than IGT. And it took 1.5 decades by other groups. You know, Mohan published a paper exactly 1.5 decades back to show same. And this indicates in a big chunk of people, it's very important to understand, IFG would mean beta cells have started caving in much earlier. And IGT would mean predominantly what Anil was responding to, obesity and insulin
resistance. Yeah.
If this IFG group progresses into diabetes, their beta cells have significantly already gone. Even if you mechanize their insulin resistance, but there needs to be a bare minimal significant insulin level, which needs to give them a good glycemic control. And that is why, you know, if you collaterally see, Anil, we have been so comfortable with giving this combination of sulfonylurea, metformin all along in severe diabetes. We never understood the pathophysiology of it. The pathophysiology was that IFG leading to, it is an indicator of a very early beta cell failure. And the moment we give them an excellent control, probably some of those beta cells which had been stunned, but had not yet undergone apoptosis, do revive and survive and come back. So it is that group where the metformin may not give all those exquisite results that you and me would anticipate in a relatively thickish guy who has IGT.
Thank you very much, sir, for your pearls of wisdom. I think it has been a very useful session.
Yes.
I think Ishita would like to thank everyone. From my side, I thank Dr. Zargar, Dr. Jetwani, Dr. Virmani, Dr. Piyush for bearing with us. And I think the audience must have liked the discussion and good deliberations. Up to you, Ishita.
Thank you, everybody. Thank you, Diabetes India 2021. Thank you to Bansi Sabu sir for organizing such a wonderful event and putting all stalwarts on metformin together under one platform. This has absolutely been, it's been a brilliant session, sir. It's like you know everything, but there is still so much more to learn. Like every single time we hear you guys, Dr. Sandeep sir, Dr. Zargar sir, Dr. Virmani, Dr. Piyush, thank you so much for the session today.
Thank you, Dr.
Hope to
Ishita.
see
We'll
you
wind and
in
they'll go
person
for the
really
next.
soon.
We'll go for the next session. I think we should wind it off here. Thank you,
Yes, sir.
Ishita, for inviting, and thank you, Dr.
sir.
Banshi Sabu.
Bye.
Once again.
Thank
Bye.
you, Dr. Ishita, Dr. Sandeep Rai, Dr. Jargar sir, Dr. Virmani sir, and Dr. Piyush for that excellent session on metformin, pros, cons, where do we stand with metformin in other indications, and what is next after metformin. So we will move on to the second therapy symposium in this all, and that is related to gliptins. And I will invite Dr. Viral Raj, a young diabetologist from the city of Bharuch, Gujarat, as a rapporteur. Please carry on with the session. Viral. Please unmute yourself. Viral, we can't hear you. Dr. Viral, are you there? Please unmute yourself.
Hello, can you hear me, sir?
Now. Yeah.
Okay. Once again, thank you, Dr. Ishita, for the wonderful session. And again, I welcome to all delegates to this tremendous event of Diabetes India 2021. And again, I am thankful to my guru, Dr. Bansi Sabu sir, for this tremendous event. I would like to Hello.
Yes,
Hello.
Viral, you are audible. Yes, yes, carry on.
Hello.
Yes, you
I
are
would
audible.
like to invite to Hello. Hello. I would like to invite two doctors, Dr. Vidyut Shah sir from Dr. Sandeep Desai sir from Valsad. Hello.
Yes, you are audible,
Hello.
Dr. Viral. Yes, you are audible, audible. Please carry on.
Hello.
Dr. Viral, you are audible. You can continue.
Okay. I would like to invite Dr. Vidyut Shah sir and Dr. Sandeep Desai sir. Vidyut Shah sahib from the Rajkot is a very well-known diabetologist, and Sandeep Desai sir from Valsad is also very well-known diabetologist. Heartily welcome to new Gliptin Symposium. Please continue, Dr. Vidyut Shah sir and Sandeep Desai sir.
Thank you, Diabetes India. It's a pleasure to be part of this great national event, and for that I thank the organizers to give me this opportunity. This symposium is about the gliptins, the drugs, though their use has been affected by SGLT, but still we are using it quite frequently and quite effectively in our practice. And for that, the first speaker of the day is none other than Dr. Neglur, who is from Thane. And sir is a very renowned personality in the field of diabetes. He is associate professor of Rajiv Gandhi Medical College and MBBS examiner and convener as well. And he teaches on variety of subjects like diabetes management, thyroid management, pregnancy in diabetes, and cardiology and diabetes by PHFI. And he is on the advisory board of various Indian and international pharmaceutical company. And what is very interesting that he is known as the gentle giant in diabetes by students and colleagues, and he has earned the title of the syndrome man for his interest to go into the detail of impressive diagnosis and treatment. So I'll invite respected Dr. Vijay Neglur to speak on the Indian perspectives of addressing incretin effect in early stage of diabetes. Over to Neglur, sir.
Thank you, sir, for your kind words of introduction. I want to thank Dr. Bansi Sabu, Dr. Arvind sir, Dr. Anup Mishra, Dr. Shashank Joshi, Sanjay Reddy, and all those people who are involved in this India diabetes activity, the huge, very famous kind of a conference. And I thank you very much for this opportunity to discuss about the Indian perspective of addressing incretin defect in the early stage of diabetes. Now, this is the structure of my talk. We'll go through the epidemiology of type 2 diabetes. We'll look at beyond A1C, the uniqueness of the metabolic risk markers in the Asians and the Asian Indians. We have some of the key lifestyle management approaches to be customized for the Indians. We look at the impact of the incretin-based therapy, especially DPP4 inhibitors in the various metabolic risk markers and type 2 diabetes pathophysiology in the population. This is the map of India. Always looks distorted and also inflated because of the large number of populations of diabetes in this country. Of course, we are none other than below China, and both China and India, called Chindia, put together, marks a large number of patients of diabetes in the world. And what is most disturbing is that this is only tip of the iceberg. That's what I said just now. But The undiagnosed diabetes is also a major challenge between the year 20 to 79 years. And this is the 2019 data. And what it shows is about 57% of the patients are undiagnosed so far as diabetes is concerned. And same is true with our neighboring countries like Pakistan, 43% and 56% in Bangladesh. Now, what is again the most important aspect of diabetes in this country is that the rapid conversion of pre-diabetes to diabetes. And this is the Chennai Urban Rural Epidemiological Study, which was again published in 2001, 2003. When the follow-up study was carried out 10 years later, 2013, what we saw amongst the 1,007 patients, which I followed up for a period of median 8.9 years, we had 22,905 years of the patients. And that means the incidence of diabetes is as high as 78.9 per 1,000 person years, which is very huge. And if we compare the other countries, it's also quite huge. Of course, Pima Indians are ahead of us, but those are the different kind of population. So we have these problems of increasing the conversion from pre-diabetes to diabetes. And this is the CARS study, which looked at the atherogenic dyslipidemia. And it's classically South Asian phenotype with the high propensity of metabolic syndrome. And this is the combination of dysglycemia and dyslipidemia. If we look at the various populations, especially the residents of South Asians, the US and the US Blacks, US Hispanics and US White, you can see the blue bars, which tells us about the resident of South Asians. Across the board of any BMI, you can see the prevalence of dysglycemia and dyslipidemia is pretty high, both in men and in women. If you see that, you can very, very striking. This is from the CARS study, which looked at about 2,000 plus population. And you see that the across board of the any BMI, the combination is very high. This is the study from Canada, which looked at the multi-ethnic cohort study of 59,000 patients aged about 30 years and followed up for 12.0 years. These are normal people, they follow up for 12.0 years. And when you adjust for the age, sex, socioeconomic features, and BMI, the risk of diabetes was pretty high in South Asian as threefold compared to the Black and the Chinese. So it's pretty high. And much more interesting is the age of onset of diabetes was again quite low, 49 compared to 55 in China and 58 in the white population. And this is again the correlation with the BMI and the onset of diabetes. If we look at the BMI on the x-axis and the prevalence of diabetes, you can see here what we have prevalence of diabetes at BMI of 24. Similarly, you see the BMI of 50 in the white population. So we get diabetes early, we get diabetes at a younger age, and we have diabetes at lower BMI, and the risk of diabetes is threefold higher. So it makes us extremely susceptible for diabetes. And this is classical Asian phenotype. All of you are familiar with this picture, been shown many times. Both of these, Dr. Yagnik and Yutkin, have the identical BMI, 22.3, but you look at the fat content, Dr. Yagnik has higher fat content. That means we are thin fat Indians. There's increased adiposity, which is called the YY paradox. And what are the features of this? You can see low vitamin B12, low vitamin D, low age of onset, low threshold for and BMI for diabetes, and so on and so forth. So many features of the Indian phenotype that you can identify and make it a classical feature of classically what's called as an Indian phenotype. Now, what is the reason? What are the factors which contribute to this? Namely, of course, you can see the diet. We have got extremely diabetic diet. We have high carbohydrate intake, a lot of junk food, and that's why the susceptibility is pretty high. Physical activity is pretty less, and that is due to urbanization and sedentary lifestyle. We have abdominal obesity. So all these factors make us susceptible to develop diabetes early. Genetics also, we have high prevalence compared to other ethnic groups, strong family aggregation, unique genes associated with diabetes and abdominal obesity. Industrialization because of the high stress, sleep deprivation, and higher depression in the urban population. Low birth weight, as Dr. Yagnik studied extensively, and the industrial chemicals and a lot of the, for example, the smoking, tobacco, alcohol consumption, and pollution, all of them are the endocrine disruptors. All of them make the Indian population extremely susceptible to 3 to 4 times because of insulin resistance, beta cell response is poor, and Asian Indians lose beta cell function very rapidly. It is 4 to 6% per year in patients of diabetes. And of course, the abdominal obesity, which contributes to the further increased insulin resistance. This again study done from Dr. Mohan's center in Chennai, and they looked at about 1,000 odd patients. And these are the patients who are not diabetic, but were included in the diabetes prevention programs. And what they did was they did oral glucose tolerance test with 75 grams of glucose. And what they saw was the patients who had normal glucose tolerance test, they had impaired fasting, the impaired glucose tolerance, combination of IFG, IGT, and of course, frank diabetes. What you see, this is the insulin resistance that you see. As insulin resistance starts riding, we see a frank diabetes coming up. And again, it tells us the beta cell decline is pretty rapid in Asians, and that's why the conversion is pretty fast. And of course, the apoptosis of beta cell is perhaps more than 4 to 6% per year. That makes it a special phenotype from India. This is the hyperbolic curve that we are all as familiar with. And we see here, this is the sensitivity of the insulin, and this is the acute insulin response to glucose. And this is the hyperbola. And most of the Caucasians are at the center of the hyperbolic curve. If we look at the ends, here are the Asians, and here you can see the Black population. The ends of the curve are most unstable, and they're likely to slip into diabetes pretty fast, whether it's the Black American population or whether it's the Asian Indian population, which are very extremely risky to develop diabetes. And what's interesting here, the insulin resistance is a predominant factor here, and it is secretory defect of beta cell is a predominant factor here. So when you look at the Asian Indians, the secretory effect or defect in the beta cell is quite pronounced. And this is a study from Japan, which looked at the intact GLP, GLP, and GIP following oral glucose tolerance test, and they said they did not find any difference. But in Indian population, we found that the high levels of insulin and GLP-1 in the blood, which suggests that probably we are either resistant to the incretin effect, and probably there's the GLP resistance to the beta cells. That's why there's a high level of GLP with high levels of insulin. Now, therefore, diabetes in India is a high risk complication. We get a higher CHT at younger age, a classical dyslipidemia of low HDL, high TG, and low dense LDL, the abnormal adipocytokines, and the serum leptin, C-reactive protein, and low adiponectin are classical features, and lower prevalence of diabetic retinopathy and a higher prevalence of nephropathy and neuropathy are pretty common in this country. So this is about DPP-4. It exists in two forms, the bound form to the membrane of the cell, and there's a free form. Then this is the proteolytic process, which makes the membrane-bound DPP-4 to the what is called as soluble DPP-4. And what's interesting is the soluble DPP-4 levels and its activity has been suggested as a novel regulator for many metabolic diseases, especially diabetes, obesity, and the cardiovascular disease, NAFLD. So it's a soluble, and of course the tissue bound. Both kinds of DPP-4 are suggestive of the increased incidence of these possible complications. Again, this study looked at again more than 990 patients, and they looked at again people with type 2 diabetes, the new onset of type 2 diabetes, the people of IGT and NGT. What you see in this graph here, that this is the levels of DPP-4 activity, that if you have the A1C more than 8.5 that you see in the established diabetes patient, you have a higher levels of activity of DPP-4. And if you look at these patients of IGT, NGT, and type 2 diabetics, the activity is not much common. So therefore, anybody who's A1C of 7.5, less than 7.5, the levels of DPP-4 are quite less. This is a study from Dr. Anup Mishra, who looked at 93 non-obese patients and 40 diabetic patients. And what you saw here is the circulating levels of DPP-4, and you can see the total intra-abdominal fat. As you see the increased abdominal fat, you see intra-abdominal, you can see large number of DPP-4 in this population. As opposed to that, if you look at non-diabetic population, there's a less amount of DPP-4 that you see very clearly. So therefore, circulating levels of DPP-4 is positively correlates with waist-hip ratio, intra-abdominal adipose tissue, liver span, fasting insulin levels, low density lipoprotein cholesterol, and forceps skin fold, and total intra-abdominal obesity or adiposity. Adiponectin, all of us know, is adipokine, which is coming from the fat. The action on AMPK and PPAR alpha, which improves the insulin resistance at the muscle level and also at the level of the liver, and also has inhibitory action on the insulin resistance because of the oxidative stress is inhibited by the adipokine, adiponectin. Now, this is the study from 1,176 patients from Canada, again, Ontario, and it was done by Salim Yusuf and Dr. H. Sharma. And what they saw was that the adiponectin levels were pretty high in Europeans compared to South Asians. We have less amount of adiponectin. We have a high amount of leptin. You can see the leptin and adiponectin have the inverse correlation. So in Asians have a high leptin levels. And we look at the HOMA-IR, at any given decrease in adiponectin is pretty high in Asians. And if you give them food with a high glycemic index, it's associated with the larger decrease in adiponectin among the Asian patients. So in other words, our adiposity is such which produces more leptin and less adiponectin, which is again a perfect recipe for type 2 diabetes. Let's move on to a very interesting area of what is called the gut microbiota. A lot of work is being done in this aspect, and the intestinal bacteria also have something like DP2 activity, especially the organisms like Prevotella have a DP4 activity, and the counter DP4 activity is seen in lactobacilli, lactococcus, and streptococcus. And what you see here, that DP4-like activity in the gut microbiota could be a new mechanism through which the microbes influence physiological and pathological process humans. And these gut microbiota do a lot of digestion of the proteins, especially gluten, and various kinds of proteins are digested much better than what pepsin can do. So that's they have a digestive properties. And once the GLP is produced from the intestine, it is taken to circulation. It does have action on the pancreas to produce insulin. But what's more important, the activated PYY acts on the Y2 receptors in the brain and has the modulation of satiation and emotional effective behavior in this. So the behavior of the person depends upon what kind of microbiota you have in your intestine. And to remind you that we have about 1.5 kilograms of microbiota in the intestine. And this is the signature of the microbiota in Indians, that we have high levels of E. coli, again, Prevotella, Vibrio, and this is a probable association of megasphaera, and the impaired glucose tolerance was reported significantly pronounced in Indian patients. And this is again study. What's the call for the action? We need a healthy lifestyle. We have to have early detection of glycemia, address the beta cell dysfunction, and of course, treat the durable management and smart resource management. This is a study from Michael Nock, which looks at 1,100 patients. And the patients were given metformin to begin with, when they were not controlled, they added sitagliptin or glipizide. Both of them have a good A1C control. If we look at the HOMA-B, you can see that the glipizide shows a good HOMA-B response. Obviously, it stimulates the beta cell and therefore gives insulin. Compared to that, it is much less insofar as the DP2 is concerned. Interestingly, still, though the A1C control is good, how it's possible? Because it has a possible effect due to action on the alpha cell or inhibition of glucagon. And if you look at the insulin, pro-insulin to insulin ratio in the fasting sample, it definitely shows a better response. Therefore, it has a better impact or better impact on the beta cell survival. So therefore, these drugs have a better impact on the beta cell survival. This is on the beta cell effect. I told you it improves insulin synthesis, increases C-peptide, improves insulin secretion, and lowers the beta cell stress. It's a very important function of the beta cell. And also on the alpha cell, it inhibits the glucagon. It restores the glucose-dependent glucagon release and addresses the fasting hyperglycemia, significant reduction in the PPG and the fasting sugar significantly. If you look at the combination of gliptins and metformin, it hits almost all the aspects of ominous octet. These are the various ominous octet parameters. And if you see the combination of metformin and DPP4 forms a good fixed dose combination, which affects most of the 8 factors of the ominous octet. And furthermore, it also has impact on the various biomarkers. If you look at the fasting in prandial in A1C, it's quite less. Look at the fasting pro-insulin reduction is also quite significant. When you combine with metformin and sitagliptin, is quite pronounced. Pro-insulin to insulin ratio, which I mentioned earlier, also very much has a very good impact. And HOMA-beta and HOMA-insulin resistance also show a favorable response. So therefore, it does improve the glycemia. It also improves the parameters, especially the parameters of the biomarkers which suggest that there is an inflammation system is going on. So this is the real world data. This looks at the 990 population from the Korea. And what they saw was they gave the patient the sitagliptin after metformin therapy and saw those who are responders versus those who are not responders, followed them for a period of 4 years, real world data. And what they saw was the responders are those who have the A1C reduction of more than 8%, and the A1C reduction was quite significant. And you can see here that more than 88% of the patient did respond very well. And of course, it responds very well when the duration of diabetes is short, when the family history of diabetes. It also responds well in the low HOMA-B and a high A1C at the baseline. Of course, so far as the trough inhibition is concerned, over 24 hours, these are the drugs, pretty long-acting sitagliptin and linagliptin are pretty long-acting drugs. The others are little short-acting. You need to have at least more than 80% inhibition at 24 hours, which is called trough inhibition, to have adequate action on the DPP-4. Now, the Indians respond better to DPP-4. This study by Dr. Mohan, which again looked at the 190 patients, which are randomized to receive either the metformin with sulfonylurea or the gliptins, and you can see the A1C, which was 1.36, and the fasting plasma glucose reduced by 40, and the prandial glucose reduced by 50, and the A1C reduced by 1.36. So much more impact that you see in Indian population, probably because our secretory defect in the beta cells is pretty pronounced in the Indians, and this corrects that defect, and therefore we have a better response so far as the DPP-4 are concerned. And this is the Dr. Panikar's study, which also looked at the fourth add-on drug for the patients of diabetes after having used triple therapy, and patients are not to target when they use metformin, sulfonylurea, and glitazone, and patient is not responding. When you add the fourth drug, you can see the response is quite dramatic. And in the short duration, less than 2 months' time, you can see the impact of reduction of A1C anyway from 1.2 to 1.3. That is a good impact of reduction of A1C, even if it's a drug which is fourth in the line to treat patients of diabetes. This is Dr. Jyoti Dev's study from Kerala, and he looked at 440 patients who received metformin and insulin, and they were randomized to receive sitagliptin glimepiride, and you can see the A1C reduction is far more superior in sitagliptin, 0.70 versus 0.31, and achievement target below 6.5 was also quite significant in sitagliptin, and also more patients required insulin dose reduction was again high in sitagliptin. So therefore it has got insulin sparing action and also action in terms of good efficacy in compared to sulfonylurea. This is a durability trial which looked at more than 7 years and also showed improvement in the parameters like HTLC, HSCRP, and LDLC. All this showed reduction. That means it has important impact on the parameters which contribute to atherosclerosis, and therefore this is a good study which tells us not only glycemic control, but also reducing the parameters which contribute to atherosclerosis. And this is a study which looked at the adiponectin levels, and there are 26 Japanese patients, 10 in control, 16 in the control treatment arm, and they were, both of them were well controlled, looking at the A1C, the albumin glycation, the 1,5-hydroglycitol, everything was well controlled at the end of 3 months. But what was different is the adiponectin levels. When you give sitagliptin, you see the rise of adiponectin very significantly compared to sulfonylureas, which did not show a good impact on the adiponectin, again suggesting that improves the adipocyte function, and therefore adipokines are much better. And again, gut microbiota, we know that the AGIs and of course the DPP-4 have the most favorable effect on the gut microbiota. So we are now aiming at even improving the gut microbiota. As I mentioned to you, up to 1.5 kilograms of the bacteria stay in your colon, and they contribute a lot. The genomic contribution to us, we have become superhuman because of these bacteria located in the intestine. There's some good bacteria and bad bacteria, and DPP-4 and AGIs improve the good colony of the bacteria and therefore improve the glycemic control. They also improve the behavior of the person and also improve satiety of the person. So just to summarize what I said in last 20 minutes is South Asians, the Indians, contributes to the bulk of the type 2 diabetes population in the world. And type 2 diabetic patients in Asian Indians is unique in many ways. In the current evidence suggests that we may require unique management strategies, which is different from the Western world. And therefore we need to address the problems of our patients. Addressing incretin defect early in diabetes, especially with DPP inhibitor, has been shown to be especially effective in this population. And this strategy is also associated with positive impact on the other cardiometabolic risk markers, especially of atherosclerosis. And more research and experience is required to establish the real impact on DPP4 on these risk markers and also on the microbiota on the intestine. So therefore, these are the future research which will throw more light on the utility of these drugs for the treatment of diabetic patients. With that, I thank you very much and thank you for the patient listening. Over to the chairpersons.
Um, Thank you, Dr. Neglur, for taking us the beautiful journey of DPP4 inhibition. I think we'll take the questions at the end. And so I'll ask my co-chairperson, Dr. Sandeep Desai, to introduce the second speaker and for a second lecture. Over to Dr. Sandeep Desai.
Thank you, Dr. Vidya. Thank you, Dr. Viral. And thank you, Diabetes India, for giving me this opportunity to chair this wonderful Gliptin Symposium. And our next speaker is Dr. Sanjay Agrawal. Can I have his introduction on the screen? Okay, I'll speak here. He's a director, Egle Clinic Diabetes Care. I hope I have pronounced it right. And he's the head Department of Medicine and Diabetes, Ruby Hall Clinic. He's a senior consultant in diabetes and medicine, Jahangir Hospital. He's a national secretary of our RSSDI, and he's a fellow of American College of Endocrinology. Council of National RSSDI, and is a member and of the editorial board of BMG Open Diabetes Research and Care Journal, and he's of course a member of writing committee in various RSSDI, inpatient management of hyperglycemia, consensus of SMBG, practice recommendations, author of various clinical atlas in diabetes, editor of RSSDI, and a lot of other contributions in various other books, and is faculty at various national and international meetings, and is of course a mentor for the postgraduate program. So he'll be speaking on the topic DPP4 and organ protection, evidence-based choice. Over to you, Dr. Sanjay.
Thank you. Can I share my screen, please? I hope you can see my screen.
Yes, perfect.
Thank you very much. I would like to thank Dr. Bansi, Dr. Arvind, the Scientific Committee of Diabetes India, and thank you very much for this kind introduction, Sandeep, as well as the other chairpersons. It's always a pleasure to speak at such a wonderful meeting, and coming after Vijay, I really feel nice because he's covered most of the aspects related to incretins. Now, since the advent of SGLT2 inhibitors and GLP-1 analogs, we've seen a lot of relegation of DPP4 inhibitors for two reasons. One is, of course, the efficacy being modest, and the other one is because there has been a lot of positive CV outcomes and renal outcomes with the SGLT2 inhibitors, and to a certain extent the GLP-1 analogs. The DPP4 inhibitors have gone back a little bit in terms of use. But do they really deserve that? And that's where we are really going to come to that. Should we write it off like we did, like we're talking about even the sulfonylureas? The answer is no. We have all these molecules which have a definite place in practice, and we need to really identify what place they occupy and when should they be used and intensified. So given this background that we are talking about, we all know the landmark trials, the UKPDS and DCCTs, and the benefits of good glycemic control when we sort of start early. So as soon as a patient comes with a diagnosis of diabetes, our endeavor should be that how soon can we get them to goal, because we've seen the long-term benefits in terms of reduction of micro and macrovascular complications and a positive metabolic memory which lasts for a long duration of time to keep them away from diabetic-related complications. We all are familiar with this, that uncontrolled diabetes leads to all kinds of complications, whether it's related to the eyes, the kidneys, the feet, nerves, heart, or the brain.
And we all know from various studies that hardly about 20% of our population reach the target HbA1c goal that has been recommended in our guidelines. So given this fact, is there a real benefit when we target them to better control? And these answers come from our landmark trial. So we have seen that in DCCT, there's a trend towards 41% risk reduction of cardiovascular events in type 1, which was significant in a 9 years follow-up study in the EDIC trial. In UK PDS, there's a trend towards 16% reduction in the risk of myocardial infarction, which achieved significance in the 10 years follow-up, and the risk reduction was about 15%, and this was clinically significant. The earliest CV outcome trial actually comes from the proactive trial, which really did not get the merit that it deserved. And this was a pioglitazone trial. It was a prospective randomized controlled trial. And there was a history of cardiovascular disease in these patients. The trial was for 34.5 months, and the A1C difference was 0.5%. But there was 16% reduction in the 3-point MACE, and this was again clinically significant. So having said this, we all have seen the different oral agents that we use in a clinical practice. And what we are really concerned about is what is the A1C reduction that we get in our patients when we prescribe them various oral agents. And here you can see that the older agents like metformin, glimepiride, and pioglitazone have a very good A1C lowering, particularly the sulfonylureas. Whereas if you come to DPP-4 inhibitors and SGLT2 inhibitors, you find there is a modest A1C lowering of about 0.6 at an average, 0.6 to 0.8, depending on the baseline HbA1c value. So you've got to be careful that, okay, what are you really looking at in terms of safety and additional benefits when you use a DPP-4 or a SGLT2 inhibitors in a given set of patients. If you want a very drastic A1C lowering, then probably you need to have a sulfonylurea on board, which will get you to the target goals. Equally important is the fact that how much sustainability of DPP-4 inhibition is there over 24 hours on a single dose when it is administered. Remember the corollary that less DPP-4 inhibition leads to higher DPP-4 activity, less active GLP-1 because it degrades the GLP-1 molecule and GIP-1 molecule in the body, the endogenous GLP-1 and GIP, and consequently there is less effect on the beta and alpha cells. So you need to have a sustained higher levels of DPP-4 inhibition to have an efficacious action. And you can see the 24 hours DPP-4 inhibition in all these molecules. Only sitagliptin demonstrated more than 90% trough and DPP-4 inhibition among the DPP-4 inhibitors available in India. Clearly, you can see here that Vilda achieved about 29%, tenaligliptin about 60%, Saxa about 73.5%, Lina about 85%, and sitagliptin achieved about 90 to 92% of 24 hours DPP-4 inhibition. Now, what does this really relate in terms of CVOTs? Because it's a very important data that we need to think about. Because after the initial rosiglitazone story, it has become mandatory to see that there is CV safety when we prescribe any of these molecules to a patient, particularly patients who had a CV risk or established cardiovascular disease. So are we causing them more harm by giving them the medicine, or are we causing benefits, or they are neutral? Now, by and large, if you see all the CV outcome trials with DPP-4 inhibitors, they are neutral in their outcomes. So if you look at the 4-point MACE, which is CV death, non-fatal MI, non-fatal stroke, and hospitalization due to unstable angina, in all these DPP-4 and SGLT2 trials, TCOS, SAVA-TIMI, Examine, Carmelina, Canvas, and Pereg and Declare, there was good power of the study. Duration was about 3 years to 4 years. All of them had a history of cardiovascular disease, but you see here the 3-point MACE was more or less was neutral, and there was no sort of a significant reduction in the 4-point MACE. Now, similarly, if you look at the 3-point MACE of CV death, non-fatal MI, and non-fatal stroke in the same trials, you find that there was again no significant reduction of 3-point MACE as reported in the Canvas or EMPIREC trial. So you find that there is, the DPP-4 did not have as much as a significant reduction. So it's more or less that there's very been neutrality in terms of CV outcomes with DPP-4 inhibitors. Now, if you look at the subgroup analysis, when you look at patients with age group, in patients with kidney disease, and against A1C. So if you look at the first group, where you're looking at patients less than 65 or more than or equal to 65, you find that there is no significant benefit, and it's neutral when it comes to sitagliptin for 4-point MACE. When it comes to 3-point MACE, again, there is a neutrality in terms of CV safety. And in EMPA-REG, you find that patients who are older than 65, there's a clear benefit of about 30% reduction in the 3-point MACE, and this was clinically significant. Now, if you look at patients with or without chronic kidney disease, and here you're looking at patients eGFR of less than 60 versus more than or equal to 60, you find in the TCOS trial, it was again neutral. So despite the fact that patients had less than or equal to GFR, there was neutral in terms of CV safety. When you look at the different subgroups of eGFR, whether it is more than 60, between 45 to 60, 30 to 45 or less than 30, again, you find there's no significant difference in terms of CV safety. So they all can be used irrespective of the level of eGFR. And in EMPA-REG trial, you found that the maximum benefit, there was reduction in the patients with 60 to 90 and less than 60. But although this was not sort of clinically significant, it was significant only between the eGFR of 60 to 90, but below 60 and above 90, it was not clinically significant. Now, when you look at the HbA1c subgroups, you find that there is again no significant difference when the median HbA1c was more than, it was, let's say, less than 8 or more than 8, and you found that it wasn't really clinically significant. So the CV safety was established irrespective of the HbA1c, baseline HbA1c values. Okay. Now, how does it really compare with sulfonylureas? Because that's one of the most commonly used drugs that we've got. And we use this pretty commonly. So 2 reasons. Suppose you've got somebody who's already on sulfonylureas and you want to add a DPP-4, or primarily if the patient is, you have to make a choice as a third agent or a second agent between DPP-4 inhibitors or sulfonylureas, what is the CV hazard that we tend to get? And you find when compared to sulfonylureas, the safety profile of DPP-4 inhibitors is higher because of the risk of hypoglycemia being less with DPP-4 inhibitors as compared to sulfonylurea. And that's the reason why perhaps you tend to favor, if you look at the diamond and the total population, you find that there's a clinical significant benefit versus sulfonylurea when you compare between DPP-4 and sulfonylureas. Okay. Now, if you look at the real world evidence of sitagliptin and the CV outcome, and here you're looking at comparative data between patients who were not on sitagliptin versus patients using sitagliptin. And this was almost in a lack of patients, newly diabetes detected patients. And this was from the Taiwan National Health Insurance Research Database between 2003 and 2011. You find that there is a clear benefit of use of sitagliptin in all those patients, whether it comes to all cardiovascular diseases, coronary heart disease, ischemic strokes, peripheral disease, or all-cause mortality. There was benefit, and there was more clinical benefit in patients with all cardiovascular disease or coronary heart disease. Okay, now we're going to switch tracks and see the safety in patients who have renal disease and what are the effects in uncontrolled hypoglycemia. Okay. Now, there's been conventional that can we use DPP-4 inhibitors in all our patients with kidney disease. Now, patients who've got, let's say, up to stage 3B, you find that there is really not much of a problem in using. In fact, DPP-4 inhibitors can be used across the entire spectrum of GFRs. Only thing is, in accepting for linagliptin and tenaligliptin, you need to make a dose adjustments as per the creatinine clearance. So you need to halve the dose once the creatinine clearance is low, but in higher GFRs, you can use the same dose. in linagliptin and tenaligliptin, irrespective of the EGFR, you don't need to change the dose, and they're pretty safe to be used irrespective of the GFR. So by and large, all the DPP-4 inhibitors can be used in patients with compromised kidney disease. Only thing you may need to make dose adjustments at low GFR values. Okay. What about if you look at the efficacies and safety of oral agents in patients with kidney disease? You know that metformin, you've got to be careful, and there is a clear guideline that you can use it patients with more than 60. Less than when it is between 40 to 60 or 30 to 60, you've got to be clinically, I mean, you need to have a clinical indication to use it, but you can reduce the dose and use it. Less than 30, it is contraindicated. So you've got to have a clear indication to use between 30 to 60, where benefit is going to be better. And that's the time that you can continue to use it. What about sulfonylureas? You can use sulfonylureas, but preferentially you shift to shorter acting sulfonylureas. Start and continue on smaller doses. Don't give higher doses because of the risk of hypoglycemia. And if they do tend to get hypoglycemia, it will be a protracted hypoglycemia. So you've got to be careful. And as the kidney function reduces, you have to go down in terms of the dose, because the lower dose would be sufficient to get your dose, to get your A1C targets. So you don't need to really give the same dose as somebody who's got an eGFR of, let's say, 70 or 80 versus somebody who's at a low GFR of 30 around. So you've got to cut back on the doses. Pioglitazone is basically not, efficacy is not majorly dependent on renal function, but you have a red flag. Patients who've got a fluid retention, you should be careful not to use pioglitazone for the risk of edema and congestive heart failure. So you have to be careful in which class of patients are you going to use pioglitazone. In patients who've got near normal EGFRs or just a mild drop in the EGFR, you can use it. But as the patient progresses towards ESRD and fluid, and the patient has a risk of fluid retention, you should try and avoid. And this is particularly more so if the patient has got a background cardiac disease. That's where you should be extremely cautious not to use pioglitazone. What about gliptins? And gliptins are probably safe, and as I just talked about it, that can be used in all stages of chronic kidney disease. Just titrate the dose and you can continue to use them. And SGLT2 inhibitors, by guidelines, you cannot use with less than 60, with less than 45, although the DAPA CKD study and other studies have shown benefits in low GFRs also, but as of now, guideline driven, you can't use it less than 45. So, but you can use it above 45 when there are clear benefits in terms of progression of the kidney disease. All right. So those considerations in CKD is that dose reduction is not mandated for DPP-4 inhibitors, for tenaligliptin and linagliptin, but you need to be careful to adjust the doses in other gliptins. There may be sort of adverse events with higher dosages when you use sulfonylureas, metformins, or pioglitazone. Dose reduction is mandated due to lack of efficacy in CKD where SGLT2 inhibitors are concerned. Dose reduction is not sort of, you don't need to do it for linagliptin, tenaligliptin. I'm just repeating myself. So that's where probably it's safe to use in low GFR values. Now, what about sitagliptin being as effective as used in patients with CKD? And this, the comparator was glipizide, and as per the National Kidney Foundation. So if you look at the study over here, they compared sitagliptin versus glipizide in moderate and severe renal impairment. They enrolled about 426 patients. The duration of study was 1 year. They used sitagliptin at 50 milligrams once a day, and 25 for moderate and severe, and glipizide was used in the dose of 2.5 to 10 based on glycemic control. And here you can see the change of A1C and HbA1c reduction. And you find there's very similar changes that is happening with both the dose, with both the drugs. So there's almost a comparable efficacy that you see. So sitagliptin is better tolerated, although the efficacy is more or less similar than glipizide in both the studies. And there was a lower incidence of symptomatic hypoglycemia in the sitagliptin group of patients. All right. What about patients with mild renal impairment? And this was basically when they looked at an average GFR of 81.6 and patients between eGFR of 60 to 90, uncontrolled of metformin plus or minus sulfonylurea, and they were randomized to sitagliptin and or dapagliflozin once daily in 24 weeks. And here you can see there was better A1C reduction in the sitagliptin group on the background of metformin plus or minus sulfonylurea as compared to dapagliflozin. And the difference in A1C was to the tune of 0.15%, meeting the pre-specified criteria of superiority of sitagliptin versus DAPA. And if you see at the percentage of patients who are achieving the target A1C of less than 7%, a higher percentage achieved this target in the sitagliptin group. And this was achieved with a much lower incidence of drug-related adverse events with sitagliptin. I'm going to come to the last part of my talk, and that's the hepatic effects. And here you can see in metformin that can be used in mild liver disease, but it needs to be reduced or avoided in patients with moderate liver disease and should be avoided in severe hepatic dysfunction. What about sulfonylureas? It should be avoided due to the risk of hypoglycemia. And because in patients with hepatic failure, they lose their ability to correct hypoglycemia through gluconeogenesis. So by and large, we'll try and avoid use sulfonylureas unless it's for a short duration at a lower dose. And if you do have to use the short acting ones, but you don't use it in moderate to severe hepatic failures. Pioglitazone, again, remember that it should be avoided because you find that patients with pioglitazone can have elevated liver enzymes. And specifically, if you've got enzyme elevation of more than 3 times the upper limit of normal, you should avoid using pioglitazone. SGLT2 inhibitors are relatively safe in class A patients, but should be used in caution in class B and avoided in class 3. It's contraindicated in severe liver dysfunction, so you've got to be careful about this. But what about gliptins in hepatic impairment? And here you can see that sitagliptin is indicated in patients with hepatic impairment, mild to moderate again, not indicated in severe hepatic failure because we don't have any data. Wilda should not be used in hepatic impairment because of concerns of hepatic enzymes. Saxa is indicated in patients with hepatic. Linagliptin again can be used, and tenaligliptin in hepatic dysfunction included in the clinical significant adverse reactions. If you look at patients with sitagliptin and the glycemic efficacy in patients with NAFLD, you find that in this study they enrolled about 30 patients. The dose of sitagliptin 50 milligram, duration was 4 months, and they looked at effective A1C lowering without rise in hepatic enzymes. So patients with NAFLD find that on use of sitagliptin, there was a gradual reduction in the A1C, and this was without increasing the liver transaminases, as you can see on the right side of the panel with AST and ALTs. What about the effect on body weight for liraglutide, sitagliptin, and glargine after metformin, and the effect on intrahepatic lipid? They enrolled about 75 patients, inadequately controlled on metformin, and they were randomized on 1:1:1 basis liraglutide, sitagliptin, or glargine over 26 weeks. The primary endpoint was change in the intrahepatic lipid as estimated by magnetic resonance imaging, estimated proton density fat fraction. And the second endpoint was, of course, changes in abdominal adiposity, which is the subcutaneous adipose tissue and visceral adipose tissue, the A1C, and the body weight. And clearly you can see in terms of A1C lowering, liraglutide and sitagliptin had a better lowering than glargine. The weight benefit was far more with liraglutide and sitagliptin. Glargine was more or less compared to sitagliptin. And if you look at basically the markers of in the lipid lowering, the fat lowering as estimated by the lipid and fat lowering as estimated by the markers, you find that liraglutide and sitagliptin had better efficacy, whether it's subcutaneous tissue reduction, adipose tissue reduction, or visceral adipose tissue reduction. So all this, there was clear benefit by use of liraglutide and sitagliptin in comparison. What about patients with alcoholic steatohepatitis? And this trial looked at in 15 number of patients. Dose of sitagliptin used was 100 milligrams, and the duration of study was 1 year, and this is conducted in Turkey. Found that there was a significant decrease in the ballooning and NASH scores, and we found that there was a reduction in A1C, the liver transaminases, the ballooning as measured, and the NASH score. So all this was clearly benefited by use of sitagliptin. And if you look at the histological markers in terms of the NASH score and the fibrous band, and you found that there was a clear improvement in the architecture of the liver with the use of sitagliptin at the end of 1 year. So this was an open label or randomized controlled trial. There was paired liver biopsies from 40 NASH patients, and sitagliptin 100 plus lifestyle versus lifestyle alone was done. And you found that the lifestyle along with sitagliptin had an improvement in the scores. So I'm going to end up here, and I think I've made my point between Vijay and me that we still have a lot of role for the DPP-4 inhibitors in clinical practice. It's not a molecule that you can write off, and against a backdrop of metformin and the newer agents like SGLT2 inhibitors and GLP-1 analogs, we still have a clear benefit and sort of safety, efficacy of DPP-4 inhibitors in our day-to-day clinical practice. Not everybody needs to go on to an SGLT2 inhibitors, or not everybody needs to go on to a GLP-1 analogs, just because you've got a lot of positive outcome data that is there in the literature. So we do find benefits of using gliptins in our clinical practice. Thank you very much for your patient listening.
Thank you, Dr. Agrawal. It was an excellent presentation. And I guess you have some time for question answers?
Yes, sure.
Are there some questions from the participants, or? I have one question for Dr. Agrawal. So mostly the data as you have presented is on sitagliptin. So what do you think in the Indian setting about teneligliptin and vildagliptin? Should we, as a general physician,
that's something that we've always been discussing of teneligliptin.
I know, but still.
But the data is extremely strong with vildagliptin because it's been an older molecule, and we had global data on vildagliptin. And I don't think there is any question about the fact that we have immense data to show the safety, efficacy of proven value, irrespective whether you use it in patients with the background kidney disease, heart disease, just for A1C lowering, and basically a beneficial side effect profile. Teneligliptin is also efficacious. I don't want to write the teneligliptin off. We have been using teneligliptin, but the data is not as strong as what we see with vildagliptin.
Can I add to that?
Yeah.
See, you look at the binding sites of teneligliptin and sitagliptin, they're identical. And both come in the class 3 DPP inhibitors, that is S1, S2, and S2 extensive. The only difference between the binding and the efficacy wise, that it only has a 60% or 70% inhibition of the DPP-4. And what we said earlier, and what Sanjay also said very elegantly, that you need to have at least more than 80% inhibition for 24 hours, which is called a trough inhibition, to get the adequate efficacy of this particular drug. Interestingly, there was a study by Dr. Mohan who looked at INSIGHT study, which was a head-to-head comparison between these two DPP-4 inhibitors, and found there was no much difference so far as the efficacy is concerned. There's a problem of safety. We still have to work on that QT interval prolongation. We need to finalize the dose, whether it's 20 or a 40 milligram, which is safe to be used. And the QT interval is a very important aspect because diabetes itself causes prolongation of QT interval. If you get one episode of hypoglycemia, you get prolongation of QT interval. Presence of CKD, electrolyte imbalance, all of them contribute to QT interval. Therefore, be careful from safety point of view. Efficacy might be similar. So here we're talking of safety. What Dr. Sanjay spoke about, safety in renal disease, safety in hepatic disease, safety in elderly population, safety in frail population, everywhere showed superiority from the safety point of view. So the discussion mainly revolves around safety issue rather than efficacy issue.
May I ask a question, please?
Yes, please.
Sure.
Thank you for the wonderful talk, Dr. Sanjay and Dr. Negler. My question, any of you can answer. What is your opinion regarding OD dose of vildagliptin? Because you know some of the companies have introduced the OD dose, and we know it is to be given twice daily.
Sanjay, पहले आप.
Try that.
पहले आप. There's a famous dialogue, Bobby Phil, pehle aap,
When
pehle
you
aap,
toast
pehle.
the other guy,
लखनवी स्टाइल में लखनवी
हाँ,
स्टाइल
वीरू जी आपने तो विकेट निकाल दिया. Yes, Sanjay.
Let me make an attempt about it. Basically, I mean, if you're using a sustained release preparation, that's different. But by and large, if you're using plain vildagliptin, we don't have enough studies to show that given once a day versus given twice a day, what is the difference that you've got. People do use it once a day. I agree with you there. But we really don't have the graphs to show that really does it have a 24-hour sustained action in terms of lowering of the blood glucose. So that is something that is questionable. So I haven't seen any data. If somebody has seen, I would be very happy to hear it. But I haven't seen a data which compares once a day versus twice a day use, unless you're using a sustained release preparation which has a sustained action over a 24-hour period. Maybe Vijay would like to expand on that.
Yeah, I think there's a very good study done by Caroline Dakin. I think Dr. Sanjay also had got her last time to speak on DPP4. She has some specific observations, especially of vildagliptin. The first thing is when you combine vildagliptin with sulfonylurea, the efficacy of the drug becomes as though it is 100 milligrams or it is a BID dose. That's the first thing, for reasons which she said she doesn't know. But this is just observation. And most of our patients are on sulfonylurea. So it's 50 milligram is equivalent to almost like 100 milligram. That's the first explanation she said. Secondly, as Sanjay said, there is no data to say that 100 milligram once a day is effective and safe. We have no data on that. And we still don't know, just because we give 50 milligram twice a day, and that doesn't mean you should give 100 milligram once. That is not correct so far as the pharmacokinetics and dynamics are concerned. So as we don't have data, I think we should discourage using 100 milligram once a day.
Just to expand on one more sort of thought which comes from what Vijay said earlier, when you combine with sulfonylureas, remember that you need to step back on the dose of sulfonylureas on combining with DPP4 inhibitors, because you can cause an increased incidences of hypoglycemia. And this has been very well shown by Bo Aaron also, that when you combine the two, you need to sort of step back on the dose of sulfonylurea. So be careful when you do that,
because it's secretagogue, and what is not well explained or not well taught about the activity of DPP4 is its capacity to synthesize insulin. We all know that it is a glucose dependent action. As the glucose level goes up, there's a more secretion or exocytosis of insulin. What is more interesting is that it also works through the second messenger. For example, it's a substance called EPAC and protein kinase A. When both get together, they act as a transcription factor and gets into the nucleus of the beta cell and brings about synthesis of insulin. And that's exactly how it's very effective in elderly population. Most doctors ask me this question, that when you become elderly, as a part of the aging itself, you lose beta cells, and over a duration of some time, you also lose beta cell. As I said, 4 to 6% per year is the rate of apoptosis of beta cell. How do you feel that this drug works at that point of time? Its beauty is that it works through synthesis of insulin. Therefore, it is useful at that point of time. And that's exactly how these drugs are quite okay at any time of the disease profile of the patient's diabetes, early part, the middle part, or late part, with the complications also. That reminds me of one very old advertisement of a bike, fill it, shut it, and forget it. So that's kind of a perfect adjective for this particular molecules, the DPP4.
Can you please elaborate on the combination of SGLT and DPP4 and metformin? And is this going to be a
game changer?
Another super combination like sulfonylurea metformin?
Yeah, because they are complementary to each other. Both of them have the action which is very similar in terms of efficacy wise. And what is interesting is that it is the SGLT2 takes the lead in controlling the sugar. So the moment you put the patient on SGLT, it works immediately. It starts on day one. Okay, it starts throwing away the glucose in the urine. So the initial burden is taken by the SGLT2, and subsequently, the later part of the control, when the A1C starts coming down, at that point of time, control becomes difficult, especially for the SGLT2, because there should be some glycemic burden for it to be effective. And as you get down the control of diabetes, the efficacy of drug becomes little less, obviously, because it's basically throws away the glucose in the urine. At that point of time, what steps in is the DPP-4, and that's how this combination works well. And secondly, all of us know that the SGLT2 increase glucagon levels and therefore can have the effect in terms of ketoacidosis, which will be nullified by using DPP-4 inhibitor. So it is a very ideal combination. And in fact, most of the authors who have worked on this especially said that this combination can get the A1C threefold higher than using drug alone, especially Eli Ferrini has mentioned about this, and DiFranzo has done the study of the combination and also shown that they are effective, they have good glycemic control, and all the beneficial effects are always there.
I think we have come to the end of the session. If there are no other questions or comments, I will thank both the speakers for excellent deliberation. And with that, we'll end this symposium.
Thank you.
Thank you
very much. Thank you,
Excuse
Sanjay,
me,
for being with you.
one question, please.
Yes.
Yes.
Yeah. So one question to both of you, sir. Which will be the best gliptin to be added to insulin therapy as far as evidence is concerned? If you want to add on top of insulin, which gliptin is to be preferred? And in this era of evidence-based medicine, will you use teneligliptin or vildagliptin in patients who are already having established cardiovascular disease?
To answer the second question first, I think no, because we don't have evidence of the teneligliptin from the cardiac safety issues. I also mentioned about the QT interval. That becomes always a problem because of it can produce sudden death. And secondly, you said about the combination of insulin therapy, because that's a study I mentioned was a swim study from Jyoti Dev Keshade's place, which he looked at 440 patients, presented as a poster at the American Diabetic Association in 2015. And he looked at 440 patients who were basically treated with insulin and metformin. And they were not to target, they were either randomized to receive sulfonylurea versus the gliptin, that was sitagliptin. And he showed that the response was better with sitagliptin by reducing the A1C significantly and also reducing the insulin dose by 20%. So therefore, it has got insulin sparing action and also efficacious compared to sulfonylurea. So therefore, if you want to combine the DPP-4 with insulin, I think the data is on sitagliptin.
They've actually also used, I'll just add another point, there have been extensive trials, and some of them by Dr. Umperaz, where they've seen in the inpatient population, where they have used DPP-4 inhibitors, insulin, and they found very similar results as to what Dr. Neglur just mentioned, that the amount of insulin dose requirement is lower in terms of total dose of insulin injected, patients with and without DPP-4, and rates of hypoglycemia were lower in the DPP-4 population, the study group, as compared to patients who did not get DPP-4.
Yes.
So this has been seen in outpatient as well as in the inpatient. So conventionally, we keep thinking that does the DPP-4 inhibitors, have a role to play in the inpatient population, and this has been very elegantly seen even in the inpatient population where there has been clear benefits. Yes. And the glycemic variability is lower in patients who have been receiving the DPP-4 inhibitors in the inpatient population. So this is all clear benefit. So there is a role to play when combining DPP-4 inhibitors and metformin along with insulin.
I think we conclude. Thank you, and over to chairpersons for any last comments.
I guess we can end the session. We have already overshooted. Thank you.
Okay, thank you very much, everybody. Thank you, Sanjay. Thank you, Sanjay.
Thank you, Dr. Sanjay, Dr. Vijay Neglur, sir, Dr. Sandeep Desai, Dr. Vidyut Shah, and Dr. Viral Raj.
Thank you, sir.
Excellent symposium on gliptin.
Thank you, everybody.
I will now hand over to Dr. Malay Parak to conduct the last session in this hall. Over to you, Malay.
Yes, sir. Good evening, all of you. So now I have welcomed Dr. Abhishek Arun, sir. He is a MD, consultant diabetologist. So over to you, Abhishek Arun, sir.
Thanks, Malay. Nice to hear from you after such a long time.
Today we'll be having the Therapeutics Symposium, some very important persons to chair this session, Dr. Jyotirmay Pal and Dr. N.K. Soni. Can I have the introduction slides for them, please? The slides for the chairpersons. Do you have the chairpersons? Yeah.
You can continue, Abhisat sir.
Okay. So
You
we
just
have
welcome.
the first speaker over here, Dr. Hemant Thakkar. He'll be talking on the beta cell preservation, the holy grail in the diabetes management. He's an eminent physician practicing in Mumbai, and he is also a consultant at Jaslok Hospital, Bhatia Hospital, Breach Candy Hospital. Dr. Thakkar is a chief medical advisor, Bennett Coleman Limited. Dr. Hemant Thakkar is also a consultant editor for Health in Times of India, Bombay, and the Economic Times, 1999 onwards. Dr. Hemant P. Thakkar is DNB examiner and appraiser at different teaching institutes in Mumbai from 2004 onwards. He is also co-founder and faculty expert for the Pre-Diseases Forum, an international initiative with members from all over the world, launched in IDF December 2011. He's also part of the steering committee member for national clinical trials and projects in diabetes and metabolics from 2011 onwards. So a lot of accolades to his name. I invite Dr. Thakkar for this, and Dr. Parag Shah will be the next speaker.
So good evening, everybody. And thank you, Diabetes India, for giving me this enormous honor of allowing me to participate in your program. I think without wasting time, I'm going to go straight to the presentation of my slides. I'm going to talk on the Holy Grail. And we all know that the Holy Grail of diabetes is chasing the beta cell. Remember, the beta cell is the bank capital of any company or of any country, and the income and expenditure of that is something which tells you everything. So we begin with the beta cell preservation, and if we can preserve the beta cells, we will be able to beat the diabetes and clear everything up. Now, the table of content, as you will see, is beta cell dysfunction, beta cell functional decline, and higher beta cell dysfunction with the beta decline study, and the different therapies available, and how DPP-4, and in particular vildagliptin, has potential therapeutic benefits. We all know that the critical determinant for type 2 diabetes is the beta cell. And beta cell dysfunction is compounded with insulin resistance, and both these pathological states synergistically exacerbate diabetes by influencing each other's pathway. Beta cell dysfunction emanating in the pancreas leads to islet beta cell degranulation, reduced insulin content, and reduced plasma insulin. Simultaneously, insulin resistance breeds in the liver to increase glucose output, which also leads to hyperglycemia. And both these put together decreased glucose transport and activity. In the muscle, the same thing happens, where because of insulin resistance, you get elevated plasma free fatty acid, and then you get muscle involvement. And all this put together leads to hyperglycemia and worsening of diabetes. Now, if you look at the beta cell function decline over time in type 2 diabetic patients, you can see in the graph how the beta cell, we all know that about 45 to 50% of beta cells are gone. You already become bankrupt with beta cells by the time the diagnosis is made. And then, of course, we trudge along, lifestyle, monotherapy, dual therapy, insulin, blah, blah, blah. So irrespective of treatment, beta cell function declines over the years, and recurrent failure, because patients are allowed to become hyperglycemic before the next step is considered. So we are treating to fail and not treating to succeed. The next drug is always introduced when the first drug fails. Instead of that, the strategy, use those drugs which will give you success. And remember, the higher the degree of beta cell dysfunction, the poorer the glucose control. The beta decline study, which showed that type 2 diabetic patients with A1C more than 7 or less than 7, according to the degree of beta cell dysfunction. You can see the PI versus I quartiles, and the number of subjects with out of target A1C values increased with increasing ratio. Beta cell dysfunction, unfortunately, in Indian type 2 diabetic patients. Why Indians? Because Indians have a poor insulin, and high resistance. So poor insulin tolerability with increased resistance. Because there is a high diabetes susceptibility in South Asians. There's a dual, parallel, and or interacting mechanism where the decreased beta cell function and impaired insulin action, along with the need of the hour, which tells you that because of this, you have strategies needed in diabetes prevention, which must minimize the loss of beta cell function. And relatively early loss of beta cell function may ask you to use insulin providing therapies early. And most likely there will be a failure of metformin monotherapy. So because there's going to be a failure of monotherapy with metformin, insulin providing therapies must be started early. So the beta cell preservation is important and allows you to have further prevention of deterioration. Now, the anti-diabetic therapies and beta cell function, if you see, the main factors associated with progressive alteration of beta cell function and pharmacologic agents that influence them. You know that from lipotoxicity, autoimmunity, inflammation, islet amyloid, incretins, insulin resistance, hyperglycemia causing glucotoxicity, this all revolves around the beta cell function, and the outer circle clearly shows what groups of drugs can help and where. But remember, the incretin therapies, which is the DPP4 inhibitors, protect and improve the function of beta cells. They favor the maintenance of beta cell mass by stimulating regeneration, stimulating proliferation, stimulating neogenesis, and enhancing the resistance of apoptosis. So all this works to bank the beta cell, to build the bank of the beta cell, and to preserve the value of the beta cell. So the beta cells, regeneration, proliferation, neogenesis, and prevention of apoptosis is a function of DPP4 inhibitors. Now let us see one of the best DPP4 inhibitors like vildagliptin, how it works in the preservation of beta cells. The therapeutic efficacy of DPP4s on HOMA beta and HOMA IR in type 2 diabetic patients. If you use DPP4s as monotherapy, there is a significantly improved HOMA beta. And you can see that in the same way, when you add DPP4s to some other therapy, when they are add-ons, there is again a significant improvement in HOMA beta. So as mono and as add-ons, and what happens to insulin resistance? No significant effect on insulin resistance. So therefore, the therapeutic potential and the deeper belief and the deeper conclusion of the benefits of vildagliptin, if you look through the clinical evidence, you will see that improvement in beta cell function with vildagliptin, there are improvements in both AIRG and SI with increased disposition index by 69%, indicating improvement of beta cell function with vildagliptin. And vildagliptin, there is a 5x enhancement of beta cell function when vilda with met is used in comparison with placebo and metformin. A 5x increase in beta cell function. Again, if you look at beta cell function, where vildagliptin and metformin were used in newly diagnosed type 2 diabetic patients. And this is now the much talked about verify study. And in the verify study sub-analysis, look at the mean change in HOMA beta from baseline to end of period 1. A phenomenal change in HOMA beta, 17.21 to minus 2.2. So the Vilda metformin combination therapy showed improvement in beta cell function compared to metformin monotherapy. Again, if you looked at the improvements in insulin sensitivity and beta cell function with vildagliptin, the changes in parameters were obvious as early as 3 months after treatment of vildagliptin 50 to 100 milligrams a day. Obviously, the A1C came down by minus 17.9%. The fasting sugar also by more than 18. The HOMA IR, the insulin resistance, definitely reduced by as much as almost 12. And the HOMA beta, which is the preservation, went up by 70.9. So vildagliptin decreased HOMA IR levels and increased HOMA beta, indicating improvement in insulin resistance and beta cell functions respectively. So both insulin resistance and beta cell function, which is the crux of preserving the beta cell, is positively affected. And thus vildagliptin enhanced the beta cell secretory capacity, which was seen after 1 year, where the disposition index after 1 year was definitely better, indicating enhanced secretory capacity with vildagliptin. So not only did it look at income and expenditure of the bank of beta cell, but it also built the bank. And building the bank is enhancing beta cell secretory. Truly something which goes to putting forward the help in improving the cause and the very root of diabetes. Therefore, the key takeaways that I wanted to point out, I have proven to you that the beta cell is the holy grail. And the holy grail is preserving this beta cell. And if you can choose a tablet or a mode of therapy early enough in diabetes, because by now when the diabetic patient comes to the fore and surfaces, 50% of his beta cells are gone. So now you have to early enough give the right therapy choice, where if you use a drug like vildagliptin in type 2 diabetic management, you improve beta cell function, you improve insulin sensitivity, and obviously the A1C levels come down, the FPG and the PPG also improve. With that, I want to end my talk because I wanted to just point out that we have absolutely a great modality of action to adopt, especially when you're using a oral therapy where the beta cell, which is the crux, is involved positively. Thank you.
Thank you, sir.
Since I have time, I'm happy to answer any questions.
Yes.
Since I have those 5 minutes, I have timed it that way.
The audience is requested to post any questions to Dr. Hemant if there are any.
No any question in the chat box, so you can continue, Dr. Abhishek.
So we have next speaker, Dr. Parag Shah. He's from Ahmedabad, and his topic is insulin resistance and role of pioglitazone in Asian Indians. Dr. Parag Shah is the director, Gujarat Endocrine Center, Ahmedabad since last 23 years. He's DM Endocrinology, DNB Endocrinology from SGPG IMS Lucknow. He's been awarded one of the most inspiring endocrinologists of India by Economic Times 2020. He has more than 50 publications in reputed index medical journals. He's been involved in more than 70 multinational landmark clinical trials as principal investigator, and he was also organizing secretary of ESICON 2015, Ahmedabad. So, Dr. Parag Shah.
Yeah, thank you for the kind introduction. So I'm just sharing my screen just. So are the slides visible? Hello?
Yes, they are, sir. Go ahead.
Okay. Good evening, everyone. What I would be discussing next 20 minutes or so about the role of insulin resistance in a pathogenesis of Asian Indian population and how actually is the place of pioglitazone specifically for the Indian Asians who are having a insulin resistance. It's just a symbolic case which all of us are seeing day to day in our routine clinical practice. A 44-year-old gentleman, diabetes for last 3 years, is a taxi driver with a sedentary and irregular lifestyle, skipping meals off and on. He's a smoker, he takes alcohol, and he's on metformin 1 gram per day and glimepiride 2 mg once a day in the morning. He has acanthosis, central obesity, high BMI, hypertension, dyslipidemia, and A1C is around 8.3. So he's a typical type 2 diabetic patient with a central obesity, and he has a failure to the glimepiride and metformin, though we have scope to increase both. So how actually we should be managing such type of the patients? Of course, we would re-emphasize the need of lifestyle modifications, but we have to understand the certain limitations of lifestyle modification. So he needs a addition of a drug like a pioglitazone was added to this patient. So 15 mg was added once a day and glimepiride was continued and metformin was continued. So after a month, his fasting and postprandial started coming down without getting too much of hypoglycemia. So he was advised to continue on the 3 drug oral anti-diabetic agents. After 3 months, when he came back for the follow-up, he had a A1C of 6.9 and he has fasting of 94 and postprandial of 120. So he's not getting hypoglycemia, but still he is coming under the target, and we don't want with a irregular lifestyle letting him to go for the hypoglycemia. We reduce the dose of glimepiride to 1 mg from 2 mg. So what is actually the insulin resistance? We all know this very well, that main insulin resistance occurs is at a muscle, fat, and the liver tissue, where in spite of having abundant sugar into the blood because of the resistance to insulin, the cells are unable to utilize this glucose for energy and the metabolism. That is how we develop a hyperglycemia. So what is a correlation between Indian typical phenotype and the insulin resistance? We all know that we don't have a usually very high BMI. Even with the low BMI or even in a normal BMI, we have got a more abdominal fat. That is how we internationally now known term as a thin fat Indian. We are more insulin resistance, more hyperinsulinemia. We have more inflammatory markers in our body, low level of adiponectin. We have got typical dyslipidemia, which is again characteristic of a insulin resistance, high triglyceride, low HDL, and high level of small dense LDL. And this all together not only just makes the person more prone to get the diabetes, are more prone to get the atherosclerotic events. So if you compare the Japanese, Mexican, and Indian populations and see the prevalence of the insulin resistance, it is highest among the Indians compared to Mexican, and the Japanese as the least among these study populations. And this is reflected into the socio-economical status also. Higher the socio-economical status, more would be the insulin resistance, maybe because of the bad lifestyle which comes with the increase in the income, central obesity, more sedentary life, more stress also is there. So insulin resistance leads to the hyperinsulinemia with a pre-diabetic stage. Then beta cells fail to produce enough insulin to keep the sugar into the normal range, and then there is a development of type 2 diabetes. So associated symptoms, though they may not be present, but excess hunger, specifically 2 to 3 hours after the food, people feel more hungry, weight gain, intestinal bloating, sleepiness after the meals, depression, presence of acanthosis, presence of hypertension, central obesity. So who has a more insulin resistance? If you take the type 2 diabetic population, 90% have insulin resistance. If you take the dyslipidemic population, 88%. If you take hypertensive CHD patients, almost more than 50% would have underlying resistance as one of the important pathophysiological defect present in such type of the populations. So what is the pathophysiology of insulin resistance? It is mainly twofold. One is the elevated free fatty acid levels due to obesity, specifically central obesity, causes insulin resistance. On top of that, if there is a refined carbohydrate, which leads to the increase in the appetite, overeating, unwanted weight gain, and high blood sugars, requiring more insulins to compensate for to have the normoglycemia. So again, putting beta cell at a more stress. So this is how actually the insulin resistance occurs. There is a hepatic level, there is a impaired hepatic insulin signaling, leads to decreased insulin activations, leading to decrease into hepatic glycogen synthesis and more production of the hepatic gluconeogenesis. So there is a more glucose coming out of the liver when actually it is not required. So among the natural history of type 2 diabetes, insulin resistance is the first primarily pathophysiology in almost 90 to 95% of type 2 diabetic patients, which remains more or less static all throughout the course of type 2 diabetes. But unfortunately, beta cell starts gradually falling because to overcome the insulin resistance, beta cell had to work harder and harder, and that actually leads to the beta cell fatigue. So there is a gradual beta cell dysfunctions. So what are the common clinical markers of the insulin resistance? Waist circumference, increase in the BMI, waist hip ratio, which is high, neck circumference also is elevated. And another laboratorical investigations are the euglycemic hyperinsulinemic study, not used for the routine clinical practice. HOMA, yes, we can do. And when we can even simple hyperinsulinemia against the fasting hyperglycemia also is a marker of a insulin resistance. So what is the correlation between the insulin resistance and a cardiometabolic risk in a type 2 diabetic patients? If you see the cardiovascular disease burden in type 2 diabetes is mainly not just linked with the hyperglycemia, it is also linked independently with the amount of insulin resistance, adipose tissue inflammations, and decrease into the insulin secretions, leading to the increase into the platelet activity, endothelial dysfunction, vascular inflammation. So all this as a result of insulin resistance would aggravate the atherosclerotic vascular process and leads to the unfortunate micro and macrovascular complications. So if you see the Indian data from the southern part of the India, and you see the number of abnormality in a presence or absence of the insulin resistance, whether you took a low HDL, those who have insulin resistance has a low HDL, high triglyceride, high blood pressure, more hyperglycemia, and more family history of type 2 diabetes. So those who have insulin resistance naturally would have a more chance of all metabolic abnormality, what we see commonly in our type 2 diabetic patients. And if you take the normal weight versus overweight populations and see the cardiometabolic abnormality clustering, and you see with the HOMA IR values, the normal values with the normal individuals would have a less cardiometabolic lab abnormalities, and more the weight, more is the insulin resistance, more abnormality of the cardiometabolic markers are seen. So again, emphasizing the need of tackling the insulin resistance in a timely manner, not only to have the good glycemic control, but to prevent the beta cell exhaustion and probably to decrease the atherosclerotic cardiovascular disease. So this is a very beautiful study in around 94,000 Chinese adults where they compared the risk factors associated with the insulin resistance and the beta cell dysfunctions, and what is more contributing to the cardiometabolic disorders. Higher the insulin resistance, you can see from quantile 1 to quantile 5, higher the insulin resistance, more percentage of the people would have more than one cardiometabolic abnormalities, as against the lower the beta cell functions, again translating into the hyperglycemia, but then the cardiometabolic disorders would be slightly less. But if unfortunately in Indian populations, we got a combination of both high insulin resistance and decreasing beta cell functions, again making us more prone to have more cardiometabolic disorders translating into the atherosclerotic cardiovascular or the cerebrovascular disease. So how to tackle this insulin resistance? We know hyperglycemia and the drugs which work beautifully on the insulin resistance are metformin and the glitazone group of the medications. So apart from medications, a good exercise at least 30 minutes a day, 5 days a week would significantly reduce the insulin resistance, even though patient may not reduce the body weight as per their desire. So by exercising, muscle will burn more stored glucose, and then there is a decrease in the muscular insulin resistance. Healthy lifestyle leading to weight loss, smoking cessation also helps to reduce or reverse insulin resistance. And we got a medications like metformin and the glitazones groups of the medications. So what is the effectiveness and safety of pioglitazone combination in an Indian type 2 diabetic patient? This is a study published in the British Journal of Medical and the Health Research. And here the safety and the efficacy of pioglitazone in a combination with metformin and glimepiride was studied in around 600 population patients. On top of glimepiride metformin, if you add the pioglitazone, A1C reduction is 1.6%. Fasting blood glucose reduced by 45 and postprandial also reduced by 61%. So it is found to be quite effective as far as the glycemic parameter is concerned. What about the antioxidant potential of metformin and pioglitazone in type 2 diabetic patient? We know that atherosclerosis or endothelial dysfunctions, and you have a good antioxidant potential of any medications or lifestyle changes or dietary changes would help for endothelial dysfunctions. So by giving metformin or pioglitazone, there is a significant reduction with the improvement in the oxidative stress more with the pioglitazone compared to the metformin therapy. So naturally, we also have observed that pioglitazone is more powerful insulin sensitizers compared to metformin, and ideally is of course the combination of both. So effect of continuing versus discontinuing pioglitazone when starting bedtime insulin in a patient who are poorly controlled with type 2 diabetes. So if you are starting the basal insulins like glargine and you are continuing versus stopping the pioglitazones, those who are continuing on the pioglitazone has a significantly better HbA1c control, and reduction into the fasting plasma glucose was also much better. But the $1 million question about the safety of pioglitazone. After rosiglitazone controversy, people are worried about the long-term safety of this group of medications. So I will try to highlight demystifying the myth of cardiovascular side effects of the pioglitazone. This is we all know proactive study which showed a cardiovascular neutrality with the pioglitazone. But 10-year follow-up study after the proactive study was over, there was no statistically significant difference into the primary endpoints for the people who were originally on pioglitazone versus on standard care other than pioglitazones or the therapy. And what was the primary endpoints here? All-cause mortality, MI, cardiac intervention, stroke, major leg amputation, leg revascularization, or MI, stroke, or any cause mortality. So there was not difference between pioglitazone arm versus the standard care arm. And you can see here the forest plot of primary composite endpoints with the pio versus standard care arm. Primary composite endpoint, all-cause mortality, non-fatal MI, stroke, non-fatal MI individually, non-fatal stroke individually, cardiac intervention, major leg amputation, bypass surgery. There was no statistical difference. So there was no safety signal after 10 years of the proactive follow-up study that pioglitazone group in any way increases any morbidity or the mortality as far as the atherosclerotic event is concerned. So you can see all-cause mortality, which would include the carcinoma-related mortality also, did not show any statistically significant difference even after total period of 13 years of follow-up. So what about the LV dysfunctions? We all know that pioglitazone would lead to weight gain, increase into the plasma volume. So those who have got a LV dysfunction to start with, because of the fluid overload, there would be precipitation of LV dysfunctions and acute LV dysfunctions. But what about the diastolic dysfunction? If you give a pioglitazone where there is no systolic dysfunctions, it improves the myocardial glucose uptake, it improves the perfusion, it improves the diastolic dysfunction. So giving in a diabetic patient without significant LV systolic dysfunction is not harmful. What about the pioglitazone exposure and the risk of all-cause mortality in an insulin-treated patient with a type 2 diabetes study? Again, this is a Taiwanese study, and you can see this is a 13-year follow-up study, retrospective study of around 20,000 patients. Those who are on pioglitazones with insulins and those who are on not on pioglitazone but on insulin therapy. Those who are on insulin with pioglitazone has a less overall cardiovascular mortality. Cardiovascular events also was less. So mortality rate did not show any increase, but it showed a trend towards some significant, statistically significant reduction into the all cause as well as the cardiovascular events. So again, re-emphasizing that it is not harmful to the heart unless patient has a bad LV systolic dysfunctions. So what are the global and Indian clinical evidence for the pioglitazone? We have talked about the proactive study, and there are lots of Indian studies which again boosted our confidence that our old age friend pioglitazone, which was not available for some time, and we show that we all have experienced that when the pioglitazone was not available, patients who were on pioglitazone containing therapy, many of them were stable even after a few years where they did not come for any follow-up. So this is a proactive study, efficacy and safety data. Naturally, the first part showed that it is quite effective and with slight increase into weight and the edema. But you can see addition of pioglitazone to metformin sulfonylurea patients led to further 1% reduction into the HbA1c, and need of insulin was significantly reduced if the patient is on sulfonylurea metformin. On top of that, if patient is given pioglitazone, because of the significant reduction into the insulin resistance, the beta cell exhaustion would decrease and need of a permanent insulin therapy also was significantly reduced in this proactive study population. This is a tried study from India. Their A1C reduction was compared with metformin, glimepiride, and pioglitazone, and then premix insulin with metformin, and it showed that A1C reduction was almost similar whether patient was on premix insulin with metformin or triple drug oral anti-diabetic therapy. The tried study again, C-peptide levels also showed slightly better with the glimepiride metformin pio compared to insulin metformin therapy, mainly because insulin will only help in beta cells by reduction into the glucotoxicity, while pioglitazone on top of the reduction in the glucotoxicity would reduce the insulin resistance. So there would be slightly better beta cell function preservation with triple drug combination therapy. So if I conclude my talk, diabetic epidemic experience in India may be due to not only strong genetic factors, which has significantly increased with rapid change in urbanization and lifestyle changes leading to high insulin resistance. For Asian Indian populations, we got a bad phenotype, we got a central obesity, increased visceral fat. So even with the less increase in the central obesity, we are more centrally obese and we are more insulin resistance. So there is a sufficient evidence that many environmental factors adversely related to glucose intolerance are modifiable through lifestyle changes. So that is a cornerstone of any chronic disease therapy. So considering that Indians are having a more insulin resistance, right, before onset of type 2 diabetes, it is advisable to have the healthy lifestyle and have the diets which are rich in fibers, exercise, try to reduce the central obesity, stress reduction, avoiding smoking or the tobacco usage. So this is the need of the hour to reduce the diabetes and diabetic related complication burden. Among the pharmacotherapy, along with the metformin, I think pioglitazone addresses the critical aspects in the Indian type 2 diabetic patient, that is insulin resistance. So intensifying the existing oral therapy, if there is no contraindication, adding pioglitazone would significantly improve the glycemic control, but it will reduce the progression of beta cell deterioration and need of insulin therapy in the future. Thank you very much for your patience hearing.
Thank you, Dr. Shah. Are there any questions for Dr. Shah? We'll wait for a while and then proceed to the next speaker. So I hope there are no questions. So we proceed to the next speaker. Thank you, sir. Next speaker is Dr. Sujoy Ghosh from Kolkata. His topic is importance of glycemic variability and how do we flatten the glycemic curve. He is DM endocrinology. He is also FRCP from London, Glasgow, and Edinburgh. He's specialty certificate in endocrinology and diabetes from UK. He's also professor of endocrinology at IPGME and Kolkata. He is an international advisory board member, endocrinology section, Davidson textbook of internal medicine. He has got various administrative positions, like he's been the National Secretary, Endocrine Society of India, National Joint Secretary, Indian Thyroid Society, National Joint Secretary, Research Society for the Study of Diabetes in India, that is RSSDI. He's worked as clinical faculty in the University of Glasgow. He has got several national awards, including the American Association of Clinical Endocrinology International Clinician of the Year 2021, WIDF Award for Innovation in Diabetes 2021, and he has got publication of over 300 articles and has also contributed chapters in various books and has been co-authors of almost 8 books. So over to Dr. Sujoy Ghosh for the next important topic.
Hopefully my slides are visible. Thank you very much. Thank you, Diabetes India, for having given me this wonderful opportunity to present before you and talk before you about an important topic, that's the importance of glycemic variability and how do we flatten the glycemic curve. I understand that this particular talk is a sponsored talk of Bayer and the makers of Acarbose. So the focus of this talk definitely is on alpha glucosidase inhibitors and how they actually reduce glycemic variability with a focus on Acarbose. So that's the outline of my talk. Essentially, I'm going to talk about the importance of glycemic variability and then the significance of glycemic variability in clinical practice and what measures do we use and how do we actually flatten the glycemic variability. In terms of the importance of glycemic variability, let us first have a look at this particular CGM chart, which shows us when even in individuals who do not have diabetes, there is variability of blood glucose levels, but that is within a particular narrow range. As glycemia worsens to the stage of impaired glucose tolerance, this variability keeps on increasing. And finally, if you look at type 2 diabetes individuals, the glycemic variability is even more. And if we had another graph of type 1 diabetic individuals or even type 2 diabetic individuals with either organ dysfunction or significant insulinopenia, this variability would have been even more. And this is exemplified by this particular slide, which tells us that both patients in red and yellow have the same HbA1cs, but you can see quite clearly that the individual in yellow has much wider glycemic variability in terms of much bigger difference between the peaks and the troughs of the glucose excursion, particularly in the postprandial state. Now, this variability can be variability within a day or between days. And like I've shown you, HbA1c does not actually capture this variability. And this might actually represent an additional risk factor of prediction of complications of diabetes. So we are now adding another dimension to, say, fasting glucose, postprandial glucose, HbA1c, to something of an acute and chronic glucose fluctuations, the glucose variability, which perhaps increases glycation and activates oxidative stress and leads to further increase in diabetic complications. Now, this is a particular cell culture study which shows if you look at human umbilical vein endothelial cells and put them in glucose levels, and if you find that if you are changing the glucose concentration in the culture media very rapidly, say between 5 and 20, then there is rapid cell death. Whereas if the glucose level does not change that badly, then the cells seem to live longer, essentially telling us that fluctuation of glucose perhaps is detrimental for cell survival. So we know that this variability of blood glucose level leads to oxidative stress, which is often measured by nitrotyrosine levels. The reason why I'm mentioning this here is that, when you're looking at improvement in glucose variability, you could look at this particular surrogate marker. So if you find that the nitrotyrosine level comes down, it perhaps means that there is improvement of oxidative stress following normalization of glucose variability. So what are the other implications of glucose variability? Of course, it could mean that the more variability you have, that it could mean that an individual is more likely to have deeper nadirs or troughs of glucose level, leading to severe hypoglycemia. Particularly, variability of fasting hypoglycemia can be an issue, particularly leading to increased risk of nocturnal hypoglycemia. This is very particularly prominent in type 1 diabetic individuals. And in terms of cardiovascular disease and macrovascular disease, you can see that the MAGE, that is mean amplitude of glucose excursion, is an independent predictor of cardiovascular disease and coronary artery disease. And repeated postprandial hyperglycemic episodes are now considered to have greater physiological effects on the cardiovascular system than persistent hyperglycemia. So high blood glucose levels are bad, but greater fluctuations is even perhaps worse than just simple high blood glucose levels. And we all talk about the ticking clock hypothesis, in which postprandial hyperglycemia is strongly correlated with coronary artery disease. So if you look at postprandial hyperglycemia, induced glucose variability is clearly associated with increased risk of macrovascular complications. And you look at all of those studies, starting from Monier's study, which shows that cardiovascular disease risk is linked to postprandial hyperglycemia and postprandial glucose variability. What about microvascular disease? The microvascular disease as well, in terms of retinopathy, increased microalbuminuria, and neuropathy, all of them are significantly correlated with glucose variability in addition to hyperglycemia. And if you even go back to the old DCCT study and look at indirect ways of recalculating what was time in range, because we remember that we did not have CGM at that point of time. It was 7-point and 5-point SMBG readings, which have been extrapolated into variability in terms of time in range. It seems that the ones who had the greatest variability had the worst microvascular complications, even in the DCCT trial. And it's suggested that every 10% increase in time in range led to increased risk of retinopathy and nephropathy, almost to the tune of 64% and 40%. So those are clearly telling us that, of course, hyperglycemia is a predictor of bad microvascular complications, but variability is also an increased risk factor for microvascular complications. The other is a visit-to-visit change in glucose levels. You often find a patient coming to your clinic once with an A1C of, say, 6, 6.5, and then the next time it's 9, the next time it's again 7, and the next time it's again 10. So if you look at the Horn study, which clearly shows that if you have such kind of variability happening even over a relatively longer period of time, that seemed to kind of indicate greater risk of both micro and macrovascular complications and even cardiovascular mortality. If you look at the DEVOTE trial, one of the things that I was trying to talk about is that greater variability is a predictor of hypoglycemia, and particularly fasting hypoglycemia and nocturnal hypoglycemia. That's reflected in this particular slide, that the severe hypoglycemia risk increases with greater variability, just as all-cause mortality does. Now, this again is a clear indicator that variability of blood glucose is an independent risk factor for increased mortality and survival. This again holds true even in the acute setting in a critical care setup. Now, how do you actually go about measuring such glycemic variability? Now, we've got the new time in range consensus guideline, which tells us how to actually go about, but not everyone is going to have a CGM. But if you did have a CGM, you could look at parameters like coefficient of variation, standard deviation, and MAGE. These are probably the commonest measures that we tend to use, but we are still not very sure which of these are the best parameters to look at, because if we look at this particular data set comparing sitagliptin versus vildagliptin, the one drug in one study where standard deviation is used, one drug seems to be doing better than the other, whereas if you used a MAGE, then the other drug seems to be doing better than. So we are not very sure which of the parameters we should be using when we are looking at glycemic variability. But we are at present all talking about ambulatory glucose profiles and SMBG readings. And this is what the summary of all of that consensus statement talks about. And as you can see in your standard type 2 diabetes patient, you would want the blood glucose levels to be between 70 to 180 at least 70% of the time, and very little of it, at least less than 4%, to be time below range, and maybe about 5% to be target above, say, 250. So you can, and remember that these are all consensus guidelines, not necessarily having huge amount of clinical evidence or data to actually back it up. Now, when we are talking about glycemic variability and we are talking about these complications and outcomes, you've got to remember that it could well reflect the underlying disease process itself and not necessarily reflect into clinical complications. And glycemic variability is going to depend on the insulin variability, the day-to-day changes in the diet, the day-to-day change in the lifestyle, particularly in physical activity, and glucose monitoring variability. So when we say that someone is at a greater risk of dying because of glycemic variability, the glycemic variability per se might not be the cause of the increased death, but it could be because of what the condition of the individual is. For example, has the disease of type 2 diabetes progressed so far that the individual is now becoming insulinopenic, and that's actually the reason why the variability is happening. It could be because of variability in diet. It could be variability in energy expenditure. It could be because of a background organ dysfunction. For example, someone with a renal dysfunction or a hepatic dysfunction would obviously have greater glucose variability compared to someone who doesn't have that. Similarly, someone having hypothyroidism, hypopituitarism, hypoadrenalism, they would perhaps have greater glycemic variability. And of course, the drugs. So if you are using a secretagogue or if you're using an insulin, the individual is going to have greater variability. Even in insulin, perhaps a basal bolus is going to have less glycemic variability. A pump will have even less variability, and a closed loop pump will have an even less variability. Whereas something like a premixed insulin is going to obviously have greater glycemic variability. So what do you do in terms of reducing glycemic variability? You need to reduce glycemic variability to improve outcomes of patient. So one of the things in terms of the diet that you can do, you can have small frequent meals with lower glycemic index, with lower carbohydrate load, and maybe complex carbohydrate, protein, and fat would be useful, and matching diet with exercise pattern and drugs would probably be one of the most important things to reduce glycemic variability. Now, let me come and talk about the alpha-glucosidase inhibitor and how they can flatten these curves and improve glycemic variability. So we are all aware that if you look at the two curves that I've shown at the bottom of this particular slide, that if the individual was not on an alpha-glucosidase inhibitor, the peak or the postprandial peak is going to be higher. Whereas with an alpha-glucosidase inhibitor, because the glucose absorption is going to be spread out in the gut, the peak is going to be much flatter. So even if the area under the curve remains the same, you will have less postprandial peaks and flatter glucose levels. And this is what is explained in this particular slide as well. You can see it would work in an insulin sparing manner, reduce the risk of hypoglycemia, and flatten out these postprandial peaks that we are talking about. And this is a little bit of our data that is still under progress in publication. And if you look at all of these alpha-glucosidase inhibitors that we are talking about, on an average, the AGI is going to reduce the A1Cs by about 7.3%. And there is very little to choose, but perhaps acarbose does a little bit better than the others in terms of the glucose lowering, not just in the A1C, but also in terms of the postprandial glucose values and also the fasting glucose values. And if you look at, because we all talk about weight gain with the drugs, you can see clearly that the alpha-glucosidase inhibitors are not just weight neutral, but they might be having some weight losing benefit when used properly in individuals. And if you look at the insulin levels as well, they tend to go down with the alpha-glucosidase inhibitor usage, particularly with acarbose. And if you look at the combination use, because most of the time we use AGIs, including acarbose, as prandial glucose regulators and not as monotherapies. And if you look at this drug when used with all other kinds of anti-diabetic medication, let us see how it does in terms of improving glycemic variability. This is a clinical trial looking at the use of acarbose in patients who are using premixed insulin you can clearly see that the coefficient of variation, the standard deviation, as well as the mean amplitude of glucose excursion, they all improve in an individual who is on premixed insulin if you add acarbose. And a lot of times we have been using acarbose. Maybe you are using premixed in the morning and dinner time, you're using acarbose, say, in the lunchtime, or even with the evening snack. And if you look at the baseline glucose levels, the C-peptide and the other parameters, they also tend to improve when you're using acarbose in metformin group studies. And if you also look at this particular study comparing the efficacy and safety of preprandial and prandial insulin in combination with acarbose in insulin requiring type 2 diabetes individuals, the addition of acarbose seems to be doing very well, particularly in individuals who are elderly, wherein you can see the standard deviation, the MAGE, they're all improving in individuals where you have actually added acarbose. The effect of acarbose on glucose fluctuations in type 2 diabetes patients receiving insulin therapy, you can see the MAGE, the 24-hour glucose fluctuation, and mean proportion of time spent in hypoglycemic range all improve because of the reasons that I've explained, this flattening of the postprandial glucose excursion, and therefore postprandial peaks are lower and the preprandial levels are better leveled off, reducing hypoglycemia. So if you again look at glucose variability in insulin-treated type 2 diabetes patients, this is another study which shows that individuals seem to be doing better in terms of the MAGE and MODD. What about acarbose when added to a DPP-4 inhibitor? This is a study where acarbose has been added to allogliptin. You can see again, in addition to a DPP-4 inhibitor, acarbose seems to be doing very well in terms of improving 24-hour CGM profiles. And here again, if you look at metformin vildagliptin patients, wherein acarbose has been added, if you look at the MAGE, the standard deviation, and the reduction in the time above range and improvement in time in range, it all seems to be improving in patients where it's been added to vilda-met combination. What about those individuals when added to metformin versus sulfonylurea plus metformin when you're adding acarbose? Here again, you realize that sulfonylureas are drugs which are prone to increased glycemic variability. That seems to be leveled out when you add acarbose to metformin in comparison to the sulfonylurea that we're talking about. And again here, acarbose metformin is more effective in glycemic variability control than repaglinide, which is again not secretagogue when added to metformin. All of those parameters seem to be improving. What about the newer drugs like, say, the gliflozins and exenatide, that is the GLP-1? Here again, if you look at the DIVE study, looking at dapagliflozin, where you've added acarbose, you can see that there is improvement in the glucose variability. And similarly, when you're looking at patients who have been given exenatide, if you add acarbose, it seems to be doing very well. So in conclusion, I would say glycemic variability is a reality of diabetes, particularly as the disease progresses. The more insulinopenic the individual becomes, and the more organ dysfunction the individual has. And glycemic variability, in addition to increased fasting glucose, postprandial glucose, and HbA1c, might increase oxidative stress and increase diabetes-related complications. There are several ways of measuring glycemic variability. We are still not very sure which is the best way forward in terms of best measure of measuring glycemic variability. However, there is emerging concepts and consensus about the ambulatory glucose profile and the CGMs and the use of time in range concepts. And it might be that glucose variability might be predictor of hypoglycemia and mortality. But the flip side, I've also mentioned that it could well be that the individuals who are more likely to die, the individuals are more likely to have hypos, are the ones who are having greater glycemic variability. There are several ways by which glycemic variability might be reduced. Of them, alteration in diet, change in exercise and physical activity pattern, appropriate management of underlying organ dysfunction, and trying to match dietary pattern and diet with the medication that we are using improves glycemic variability. All of the drugs have different effects on glycemic variability. For example, insulin and sulfonylureas have bad effect in terms of glycemic variability, whereas drugs, particularly like the alpha-glucosidase inhibitor, as exemplified by acarbose, improves glycemic variability and cuts postprandial glucose peaks and improves preprandial hypoglycemia. However, when we are talking about evidence of translation of improvement of glycemic variability to reduction of complication, we have relatively less evidence. But what we have evidence in terms is there is improvement in quality of life, there's improvement in hypoglycemia risk, but whether there is improvement in long-term risk of micro and macrovascular complication, only time will tell. Thank you very much. I shall stop there.
Thank you, Dr. Sujoy. So, very interesting session from Dr. Sujoy. And I would like to ask the audience if there are any questions. We can wait, sir, for a while, and then we can proceed to the next speaker.
Dr. Sujay, can I ask a question, Dr. Abhishek?
Yes, yes, sure, sir. Sure, sir.
Excellent talk, Sujay, but since it was sponsored, I just wanted to know one thing. Do you feel voglibose is as good as acarbose or better because of the less gastric tolerance?
Right. I actually did not show you some of the slides of our meta-analysis, which is under publication. Honestly speaking, if we look at the data, the published data, acarbose probably has much stronger data than voglibose. Though I myself, I'll be honest that I probably prescribe more voglibose than acarbose. The challenge, I think, is, or the reason why in India we prescribe more voglibose is more market noise. And it's more a pharma-driven noise rather than actual science. In terms of the side effect profile, our meta-analysis suggests that there is no difference in terms of the side effect profile of acarbose compared to voglibose, particularly the GI side effects. And there's almost about 30 odd studies which we have included in that particular meta-analysis. And I can probably bring up that slide if I'm given a moment. Just give me a second. You need to let me share slides. If you look at, this is the adverse events of all of the AGIs combined. And you can see that flatulence and diarrhea are common to all AGIs, whether we are talking about acarbose or whether it is voglibose. And I couldn't find the other slide, which essentially shows that there's no difference between the molecules, whether it's smeglitol, whether it's voglibose, or whether it's acarbose. They are all equally bad in terms of the side effect profile.
But what is your personal experience?
Sir, I don't have that data to actually make a scientific comment, unless and until you are prospectively collecting data and then actually scientifically analyzing. I don't think I should be making any comments in terms of what my gut feelings are.
Yes, yes. So if there are no questions, we can go to the next speaker.
Thank you very much.
So the next speaker for today's symposium is Dr. Rupa Mehta. She'll be talking on the current place of sulfonylurea in the diabetes management. And she's a renowned endocrinologist and researcher, Department of Endocrinology and Metabolism at National Institute of Medical Science, Mexico. Over to Dr. Rupa Mehta.
Thank you, Dr. Abhishek. I'm going to now share my screen. Okay, can you all see the screen properly? Okay, so let's get started. And first of all, I'd like to thank Diabetes India for really inviting me to participate in this event. It's a great honor, and I'll just get started. So the title of this talk is there a current role for sulfonylureas in diabetes management? So I thought I would start with this slide first. And this is really just a reflection, thinking about the evolution of therapies in diabetes in recent years. And I wanted to just highlight that really we've had sulfonylureas since before the 1950s at least. And really we've used them much longer than any of these newer agents. In fact, their safety profile and their efficacy is now well established. But I just wanted to highlight that to you. While I was training in endocrinology, really, we only had, insulin, sulfonylureas, metformin. We had very few agents. And really all these newer agents have appeared after the 1990s. So as I've mentioned, really, we've had extensive use of the sulfonylureas in the treatment of diabetes since the 1950s. And they've become a mainstay of treatment, either in monotherapy or in combination. And on this table, I'm showing you the main agents that have been used or are currently available. And you can see that we have several generations of sulfonylureas, the first, second, and third generations. And I'm also showing on this table the duration of action, the time to peak, the excretion in the majority of cases, which is renal, and then the use in patients with renal dysfunction. With the earlier sulfonylureas, there needed to be some adjustment or you had to avoid them. But with the newer generations, really, there's no dose adjustment needed. So it's just to basically show that really we've had them around for a very long time. And I would say that we're still using a lot of the second generation agents, and really a lot of the newer third generation agents are now becoming available in generic form. So let me just go through briefly the mechanism of action, which I'm sure you're all aware of. So we know that really the sulfonylureas stimulate insulin secretion from the beta cells in a non-glucose dependent manner. We know that as the sulfonylurea binds to the sulfonylurea receptor on the beta cell in this case, and this is shown on the diagram on the right-hand side, and you can see it's the left box. When the sulfonylurea binds to its receptor, which in this case is SIR1, there is closing of the potassium ATP channels, and this inhibits the efflux of potassium ions through these channels and results in membrane depolarization. As there is membrane depolarization, this results in opening of voltage-sensitive calcium channels and allows the influx of calcium ions. As the calcium concentration inside the pancreatic beta cell increases, there is an exocytosis of insulin-containing granules. All of this we learned in medical school. But I like this particular diagram because it shows us clearly that sulfonylureas may have effects on other tissues as well, which carry these potassium ATP channels. And in particular, we're worried about the heart when we consider the use of sulfonylureas. The myocytes contain the SIR2A receptor, and really the main concern is that sulfonylureas may inhibit ischemic preconditioning. Let me just go through what ischemic preconditioning is and why it's important in the heart. So we know that ischemic preconditioning occurs when the cardiac potassium ATP channels open automatically during brief episodes of mild myocardial ischemia. You can see on the left-hand side, here we have no ischemic preconditioning. And what happens when you don't have this is that there is prolonged occlusion of a major coronary artery, and we may get a large myocardial infarction. When ischemic preconditioning is permitted, with repeated and brief occlusion of the same vessel, this preconditions the myocardium such that subsequent prolonged occlusion leads to a smaller infarction. So drugs that can inhibit these potassium ATP channels, such as sulfonylureas, may actually inhibit this process. And you can see this in the diagram on the right. Certain sulfonylureas, and this is the worry, may abolish ischemic preconditioning, resulting in risk of a large infarction size. So this table has come from a recent work, well, from 2015 of Sanjay Kalra and his team. And I just wanted to highlight this idea of ischemic preconditioning, and that, as I've already mentioned, sulfonylureas may increase the risk of losing this. However, we have to take into account that it's not all the sulfonylureas. Gliclazide, for example, does not interfere with nicorandil activity and does not interfere with ischemic preconditioning. Glimepiride as well suppresses ventricular tachycardia and lowers blood pressure and induces ischemic preconditioning. There are also other pleiotropic events or effects of sulfonylureas. So I've just talked about the mechanism, I've talked about the risks with respect to the heart, but there are advantages such as antioxidative properties, angiogenesis, and also vascular health as well. But let's talk about really the role of sulfonylureas in diabetes. So I'm just going to summarize some of the data on the glucose lowering efficacy. So this table really is comparing, as much as we can, the degree of glycated hemoglobin reduction with the major classes of hypoglycemic agents. Direct comparisons are lacking, but meta-analysis of placebo-controlled trials does show that the mean reductions may be quite similar between GLP-1 receptor agonists, SGLT2 inhibitors, and sulfonylureas. But you can see that really sulfonylureas have consistently shown, I think, quite significant glucose lowering effect. On this table, I'm showing you meta-analysis data of randomized controlled trials. And here on this table, we're looking at the reduction in glycated hemoglobin. There's also data on risk of hypoglycemia. But I just wanted to show you a couple of these studies. For example, the Hearst meta-analysis, again, looks at 31 studies, and we can see that the reduction in glycated hemoglobin is roughly 1.51 or 1.62 with the sulfonylurea versus a comparator. If we look at the other study that I've highlighted, again, 27 treatment comparisons, and we can see here again, there is with sulfonylureas a reduction of 0.79, DPP-4 inhibitors, again, 0.79, and GLP-1 receptor agonists, 0.99. So the idea of showing you this is not so much to compare one agent to another, it's really just to show you these agents are very effective in lowering blood glucose. They may be as effective as, for example, some of the newer agents that we are currently using. And finally, I wanted to show you the classic trials that we have. And of course, we can't really avoid talking about the UK PDS study. And here again, remember the intensive arm was really sulfonylurea, chlorpropamide or glibenclamide or insulin versus conventional treatment. And if we look at the glycemic efficacy at 6 months and long term, we're getting reductions to 7% or 7.9%. And this was associated with a 12% lower risk of any diabetes-related endpoint. The advanced study, another older study, looking at intensive treatment versus standard treatment, again shows this glucose-lowering efficacy. And again, the incidence of complications decreased. But let me just highlight 2 additional studies which look specifically at long-term complications in diabetes. So we have the analysis of the advanced study, which is the advanced on study. This was a post-observational follow-up from advanced, and again, looking at intensive versus standard therapy. And here you can see with respect to glycemic efficacy, we had glycated hemoglobin levels maintained over 10 years. And this persistent benefit showed really benefits with respect to end-stage renal disease. If we look at the BADT study, here we have the follow-on study of intensive versus standard care, And again, the reduction in glycated hemoglobin, 6.9% versus 8.4 at 6 months. And long-term, really, the difference was not significant. However, long-term follow-up, again, showed significantly lower risk of major CV events with intensive therapy. So it's just really to highlight that this significant glucose lowering effect is also related in the long term, in many cases, to benefits with respect to micro and macrovascular complications. But let's turn our attention as well to durability. And really, the evidence we have from here is from the ADOPT study. Remember, this again was a study comparing the effects of rosiglitazone, metformin, or glyburide. And I'm just showing you on the right-hand side, here is the difference in glycated hemoglobin, or the change in glycated hemoglobin during the 5 years of the study. And you can see that really glibenclamide, or glyburide in this case, was really the least durable. And in fact, monotherapy with sulfonylurea was durable for only 2.75 years, and for up to 4 years in 67%. But you can see by the two graphs, the graph on the left shows you the incidence of monotherapy failure, and you can see that this is significant with glyburide. So I've shown you now really the data on glycemic efficacy. I think it is important. We can see why we keep using these drugs, and I've shown you the durability aspect as well, that maybe at least compared to, in this case, aglitazone and metformin, the sulfonylurea was not as durable. But let's turn our attention to weight gain. As you all know, this is another concern with the use of this class of agents. And I've only got one slide here. The weight gain observed with sulfonylureas may be explained by the insulinotropic actions, the reduction in glycosuria, increased caloric intake to prevent or treat hypoglycemia. In fact, in the UK PDS, patients on sulfonylurea monotherapy gained more weight compared to dietary intervention, and you can see the figures here. However, the sulfonylurea-induced weight gain stabilized after the first 3 to 4 years, whilst insulin had progressive gain. So I think this is another aspect of sulfonylureas. Yes, you will get a little weight gain, but it doesn't keep increasing. It tends to stabilize. In another study, initial treatment with glimepiride was associated with a significantly greater decrease in body weight than with glibenclamide, while providing equivalent glycemic control. So here I'm just highlighting that, yes, we may expect weight gain. However, certain sulfonylureas are associated with a lower incidence of weight gain, in particular glimepiride. So we can think of glimepiride and maybe also gliclazide and glipizide to be associated with less weight gain than the older generation sulfonylureas. The real world evidence, just to show you a little bit more information, and this is the only other slide on weight gain, we have from the Zodiac study. Now, if you look, this was almost 30,000 patients with type 2 diabetes, and the idea was to look specifically at change in body weight with sulfonylureas added onto metformin therapy. I just want to show you the main findings. Again, non-significant linear change in body weight during follow-up and a non-significant difference in body weight between sulfonylurea add-on combinations. But we can see there is a difference in the change in weight after 5 years. Here, 3.9 kilograms for gliclazide, 3.3 for glibenclamide, 0.1 for glimepiride, and 1.4 for tolbutamide. Again, supporting this idea that certain sulfonylureas, in particular glimepiride, are associated with a lower risk of weight gain. Let's turn our attention to hypoglycemia, another effect of sulfonylureas that we may be concerned of. So I'm just showing you this table, which really summarizes the randomized controlled trials in which we're comparing a sulfonylurea either with another sulfonylurea or with another treatment. And you can clearly see, in general, for example, look at the advanced study, gliclazide versus standard control, there is an increase in the rate of severe hypoglycemia. However, remember, severe hypoglycemia Yes, we are worried about it because it is associated with increased mortality, but this is probably not a causal relationship. Hypoglycemia is probably a marker for illness severity. In the Carolina study, if you remember, and I'll go into this in further detail, remember in a high-risk population, the risk for MACE was similar between both arms. So even though the hypo rate was greater with glimepiride, this does not translate into a greater mortality risk. And if we look specifically at a couple of the studies shown on this table, for example, let me just go back to the UK PDS. Here, the risk of hypoglycemia was 0.12 per person year with the sulfonylureas, and this was much lower than the rate with insulin. But let me just remind you of the GUIDE study. Now, here it's shown on this table, and we can see here the treatment comparisons were gliclazide MR versus glimepiride. You can see that in this study, there was significantly lower confirmed hypoglycemia with gliclazide versus glimepiride, but you can see that the rates of severe hypoglycemia were no different in either arm. So it's just to highlight that, yes, we do worry about hypoglycemia, but remember, hypoglycemia may be a marker of disease morbidity. But there are studies that have shown that really, even though we may get greater rates of hypoglycemia, they're not related to an increased risk. And again, this table, it does show that there is a greater risk, but it's not that high if we're thinking about the rates in real world. Let me show you the real world evidence as well. And again, there's this study by Holstein. This is a meta-analysis of real world data. And we can see here that the episodes are quite low. Obviously higher with the sulfonylurea as expected, but it's 5.6 episodes per 1,000 person years. And this is with glibenclamide. If we turn our attention to the Van Dalem study, here again, 120,000 new users of anti-diabetic drugs, duration almost 4 years. And yes, there was an increased risk of hypoglycemic events in existing sulfonylurea users compared with metformin, but this was really associated with a GFR less than 30 in a lot of the cases. So yes, hypoglycemia is something that we do worry about. Certain sulfonylureas may have a slightly lower risk of hypoglycemia, maybe the newer generations more than the older generations, but in general, the rates in a lot of the cases are not as high as we may believe. So let's now turn our attention to the CV outcome studies. Now, let me give you a brief history about one of the most famous studies that really brought attention to this possible CV risk. And it's associated with this mechanism that I showed you right at the beginning of the talk with the loss of ischemic preconditioning. So this is the University Diabetes Group program, and this study included 823 persons, tolbutamide versus insulin versus diet. This study was carried out in the 1970s. And here they found that in the tolbutamide arm, as you can see with the curves, there was an excess of cardiovascular deaths versus placebo. However, we have to remember that this study did have methodological issues. There was variable cardiovascular risk at baseline. It wasn't carried out as the current CVOTs are carried out. There was also a small number of events, so we can argue that it was underpowered. And also there was no real formal assessment of CV deaths. There was no adjudicating body as we have nowadays. But as a result of this study, there was an FDA black box warning for CV mortality with sulfonylureas, and tolbutamide itself was withdrawn. But things have changed. So let me just show you that really the CV outcome data with sulfonylureas is quite controversial. Meta-analysis of randomized controlled trials show really neutral outcomes, whereas observational studies show variable but increased cardiovascular risk with sulfonylureas. So this is where the controversy is. No? When you actually do a meta-analysis with all the studies that are randomized controlled, they don't find a risk. But when we look at a lot of the observational studies, there is an increased risk. But there are drawbacks with this. For example, individual randomized controlled trials are limited by lack of high-risk patients at baseline, low event rates, and short study duration. Whereas if we're looking at observational studies, despite their large numbers, they suffer from selection bias, information bias, and residual confounding. And on this table, I'm just showing you a couple of the most famous studies that have included sulfonylureas and evaluated cardiovascular outcomes. So we have the ADVANCE study. Remember, this was intensive control versus standard control. And I'm showing you here the rates or the incidence of the CV outcomes. And we can see that really there was the cumulative incidence, let me just read that, of CV death, MI, stroke with a hazard ratio of 0.94. Not significant, but not really showing risk. If we look, and there was a significant decrease in microvascular and macrovascular events, but a non-significant decrease in major macrovascular events. If we look at the TOSCA study, now this was also a very interesting study. Again, this is patients with type 2 diabetes, and we're looking at add-on treatment with pioglitazone or add-on with sulfonylureas, and we can see there were 3 sulfonylureas included. And what was evaluated was the first occurrence of all-cause death, non-fatal MI, non-fatal stroke, or urgent revascularization. And we can see here again, we've got a hazard ratio of 0.96, a P that is not significant. So really, we're not finding any difference between the 2 arms with respect to the primary endpoint. So again, there is data that is showing neutral outcomes. These are randomized controlled trials, but observational data does seem to show increased risk. However, I think what has helped us in come to some kind of conclusion regarding sulfonylureas is the Carolina study. I'm sure you're all aware of this study. This was a cardiovascular outcome study, and the question here was, what is the effect of linagliptin compared with glimepiride with respect to MACE in patients with type 2 diabetes and elevated cardiovascular risk? And you can see this study included 6,000 patients follow-up of about 6 years or so. And we can see here the primary endpoint of 3-point MACE with a hazard ratio of 0.98 and with a P of 0.01 for non-inferiority, showing really non-inferiority of linagliptin versus glimepiride. But we can see here that the rates, and I've shown you on the table on the left, for MACE were 11.8 versus 12%. So really there was no difference between the arms. So the meaning of this study at that time was really showing that the use of linagliptin showed non-inferiority with respect to MACE compared to glimepiride. But it also showed us that glimepiride does not increase at least the risk for MACE in this particular population. If we look at the other outcomes, for example, hypoglycemia, you can see on the curve on the left, clearly there is a greater risk of hypoglycemia with glimepiride, the hazard ratio of 0.18 with a P that is highly significant. However, you can see from the table, while the rates of hypoglycemia were higher with glimepiride, it's important to note that the absolute risk of hypoglycemia was quite small, even in the sulfonylurea treated patients. And if we look at the risk for severe hypoglycemia, it's 0.3 with linagliptin versus 2.2 with glimepiride. It's still quite low, even though it is significantly different. And finally, I just want to show you the effects on mean change in glycated hemoglobin. Again, these favored glimepiride over linagliptin, but overall there was no significant difference between the groups. And you can see the levels during the whole study. They're very similar between both arms. If we look at weight gain as well, again, a modest weight gain with glimepiride, and this was maintained thereafter. Remember, I mentioned that with respect to weight, you may expect a certain weight gain, but this tends to be maintained. It doesn't really increase with continued use of the sulfonylurea. And finally, this recent systematic review and network meta-analysis of mortality risk with sulfonylureas does seem to suggest that there is a difference between the first, second, and third generation of these agents, with gliclazide really showing the lowest risk. And you can see that the last 3 are the really third generation sulfonylureas. So in summary, with the CV outcome data, it's still controversial. I think Carolina does reassure us a lot, but if we look at this kind of mortality risk data, it does suggest that the older generation drugs were associated with a greater risk. And finally, in the last part of the talk, I'm just going to talk about the guidelines. Why are there differences? And I think this is really where I can answer the question of this particular talk. So if we look at the recommendations for use of sulfonylureas in patients without atherosclerotic cardiovascular disease, there is a difference among guidelines. Australian, Indian, and the WHO guidelines specify sulfonylureas as second-line agents, whereas NICE and IDF include sulfonylureas as one of the preferred options along with DPP inhibitors and either pioglitazone or an SGLT2 inhibitor. But really, it's the ADA, EASD, and the European Society of Cardiology that place them in the 4th or 5th line. If we look specifically on this table, we can see here they say add SU as second-line agent only if cost is a compelling issue. They say reserve sulfonylureas for 4th-line treatment if there is a compelling need to minimize hypoglycemia or weight gain. But in general, if we look at the European guidelines, they actually say reserve sulfonylureas for 4th-line treatment. So why are there these differences? Let me just first of all just show you this evaluation of guidelines. And I think when we decide to use a particular guideline, it's important to know really what we are seeing or what is being assessed. So this is an old analysis from 2018, really, looking at the AGREE 2, which is the appraisal of guidelines for research and evaluation. We can here see that they compared the ADA guidelines of 215, the Canadian Society guidelines, also the NICE guidelines, and also the ACE guidelines. And we can see here that they give overall scores. Now, the ADA guidelines come out with a 50% overall score. And this is because it tends to be a consensus. The actual scientific rigor is given a very low percent, 28%. So though evidence-based, the recommendations are really the opinions of the authors. And this happened with the consensus statement in 2018. And in fact, if we look at really the Canadian guidelines and the NICE guidelines, they have a significant amount of scientific rigor, clarity of presentation, and also if we look at applicability and resource implications, these are also considered in the NICE guidelines. So just take this into account when you're looking at guidelines, that sometimes they're not as thorough as we would possibly want. So why are there differences among guidelines? So I've already mentioned that the ADA guidelines are only considering sulfonylureas if cost is a driving factor. I think they're not taking into account the other properties of this class of agents. If we look specifically at the EASD ADA and the ESC EASD recommendations, they suggest SGLT2 inhibitors and GLP-1 receptor agonists as second line based on the results of CVOTs. And they cite evidence from the observational trials for increased cardiovascular risk with sulfonylureas. However, remember, the majority of patients that we treat do not fulfill the inclusion criteria for CVOTs. So this also brings into question the generalizability of these results in a broader diabetic population. Remember as well, I've shown you the randomized control trial data, and that hasn't shown increased cardiovascular risk. It's been really the observational trials. So in my opinion, the weight of evidence does not show increased risk with this class of agent, and in particular with the newer third generation agents. As I've said, there may be differences among the individual agents. And finally, many times it's really only the NICE guidelines that take into account the cost-effective data, and they should perhaps be considered. So this is my final slide. Is there a current role for sulfonylureas in diabetic treatment? Of course there is. Remember, again, the EASD ADA consensus or recommendations do not provide recommendations for patients without compelling indications. So they're only considering hypos, weight, and cost for a particular drug class in their algorithm. And this is possibly the majority of patients. They may not have these issues. So really, we do need to look at sulfonylureas and assess them in a more honest and correct manner. Current evidence would suggest that in the absence of atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, a later generation of sulfonylurea is still the most cost-effective second-line agent for these patients, especially in where we live, India, and myself in Mexico, but I think even in the first world setting. So I just want to end with this quote. This is probably why, despite the negative narrative towards sulfonylureas over recent years, they remain the most widely prescribed second-line agents, suggesting that practicing physicians know something that the consensus experts do not. Thank you very much for listening to me. That's my last slide.
Glycemic control has gone down. And number two, the use of sulfonylureas has decreased by almost 25 to 30%. So already a comment, I think possibly because the sulfonylureas decreased, they have deterioration of glycemic control because they are putting them on SGLT2 inhibitors and not looking at the glycemic control. What is your opinion?
Yeah, I think you may be right. I think the bad press sulfonylureas are receiving is probably not warranted. We need efficacious glucose-lowering agents, but we need to choose probably the later generation sulfonylureas and obviously personalize our treatment. You may not use it in an elderly patient with comorbidities who may have a high risk of hypoglycemia, or someone who is obese who you don't want to maybe gain 2 or 3 kilos. But there is no doubt, as you say, these drugs are very efficacious for controlling blood glucose. And you've seen the studies and the follow-on studies with VADT in advance that showed that long-term microvascular complications is significantly reduced. And chronic kidney disease is one of our major problems in diabetes with respect to cost more than anything else to society. So I think you're absolutely right. We do have to keep using these agents, especially in our countries, which is out of pocket. You know, my patients have to buy their drugs. A GLP-1 receptor agonist is often unaffordable, but a generic SU is, and I know I'll help this patient prevent long-term complications. Yes, completely in agreement.
Yeah. So even besides the cost, because now we have generic SGLT2 inhibitors in India, and I have, in my experience, I've seen that in patients who have an eGFR between 30 to 45, there is a lowering of the glycemic efficacy of SGLT2 inhibitors. And you still need sulfonylureas to control the, to get a good glycemic control.
Yes.
So we cannot just get rid of sulfonylureas. They have been with us, they will be with us, and in future also we are going to use them.
I think it's just being judicious in the way we use them, so we use them in the correct patient at the correct time. That's it.
Absolutely right. Thank you.
Great. Thank you.
So thank you so much, madam. And there is no any new question in the chat box. So thank you so much for wonderful presentation, madam. Thank you so much.
Do we have another question and answer session, or are we finished?
No, ma'am. No,
We're finished.
there is no any.
Thank you very much again for the invitation. It's great to take part in such a great event. And please send my congratulations to Dr. Banshi for his organization and presence. Thank you again.
Definitely, ma'am. Thank you so much. Thank you. Bye-bye. Bye.